India after returning back from UK. He boasts an impressive array of accolades and had the distinct privilege of serving as a personal ophthalmologist to the late Dr. APJ Abdul Kalam. Dr. Lokeshwar Rao Sajja, Senior Consultant Cardiothoracic Surgeon and Director of Cardiothoracic Surgical Research at Star Hospitals, Hyderabad. Dr. Sajja is globally recognized as an original researcher in the field of cardiothoracic surgery with over 100 peer-reviewed publications to his credit as a main author. He holds the distinction of being the founding president of the Society of Coronary Surgeons and currently serves as the president of Indian Association of Cardiovascular Thoracic Surgeons. Dr. Alok Ranjan, Senior Consultant and Head of the Department of Neurosurgery, Apollo Hospitals, Hyderabad, India. Dr. Alok is highly experienced and acclaimed minimally invasive brain and spine surgeon. He is one of the few pioneering surgeons to start minimally invasive surgery in India. He currently serves as the Secretary of Minimally Invasive Spine Surgeons Association of Bharat, the MISAP. Dr. SUKUMAR SURA, Senior Neurosurgeon and Chief of Spine Surgery, the Chairman and Managing Director of Asian Spine Hospital. He was the first to establish the first standalone full endoscopic center in India. Dr. Mahesh Kantila, Senior Endoscopic Spine Surgeon from Bengaluru, India. Dr. Pramod Lokhande, Senior Endoscopic Spine Surgeon from Pune. Professor K. Karthik Kailash, Head of the Department, Department of Spine Surgery, SRMC Chennai, India. He is the President-elect of MISAP. Dr. Praveen Kadarcherla, Endoscopic Spine Surgeon and Medical Director, Atlantic Spine Center, New Jersey, USA. Dr. Hussein Ozturk, Endoscopic Spine Surgeon from Turkey. He is the International Instructor, Revo Spine Center, Germany. Dr. Kai Ting Chen, Endoscopic Spine Surgeon from Taiwan. Dr. Suresh Ramaswamy, Endoscopic Spine Surgeon from Elostar, Malaysia. Dr. Zakiri Rashid, Endoscopic Spine Surgeon from Malaysia. Thank you, everyone. Ladies and gentlemen, we now kindly request everyone to rise for the Saraswati Vandanam. Thank you, sir. Now I kindly request all our distinguished dignitaries to take part in the traditional lamp lighting ceremony. A sincere thank you to all our esteemed guests for lighting the lamp and illuminating our path to the knowledge and progress. May I now request Dr. SUKUMAR SURA to kindly deliver the welcome address.
So, good morning everyone. So, distinguished my teachers, chief guests and seniors, my dear friends. So, it's our honor to welcome you all to this Spinoscope 2023. Last year when we did our first master class, it was a basic course where we understood the principles of spine endoscopy, the advantages of spine endoscopy. So then this time we are going to the next level where the principles are understood, the basic principles are understood. A lot of people ask what next. So going to the next stage is the most difficult stage where understanding the concepts are different from the basic principles. So we thought we'll dedicate this master class to the advancements, especially the stenosis, which is the incidence and the number of patients suffering is more than the regular simple disc disease of spine, and the fusion surgery. So the concepts are there's a lot of confusion in fusions and the management of stenosis in elderly especially. So this master class is entirely the 2 days. We have not kept the lectures this time because we don't want to waste precious time understanding the steps of these surgeries. So we are more spending time on live surgeries, step by step. You can interrupt, interact. You need not, there is no time frame here. So definitely everyone is welcome to stop and ask the masters, because here the distinguished masters all over the world are here. Try to utilize the opportunity to discuss, debate. Don't think we are asking some silly questions. No. So every question is a learning point, and here we are all here to learn and shorten our learning curve. So we welcome you all. So the next 2 days, just enjoy the academic feast, and again, thanks one and all. Thank you.
Thank you, Dr. Sukumar SURA. Now I request Dr. Sukumar to kindly felicitate Dr. Kasu Prasad Reddy, our chief guest. Only 3. May I now request Dr. Kasu Prasad Reddy, our chief guest, to deliver a concise speech, please.
Good morning, everyone. First of all, I would like to welcome all the Spinoscope 2023 delegates. And I'm basically an ophthalmologist, but I lived in England for 20 years. A very mixed education, I must say, that I started off after MBBS. I did my MS General Surgery, went to England to get into general surgery, but got into orthopedics for 4 years, and then neurosurgery for 1 year. So I have a small relationship with you guys and the spine. And in that period of time, what astonished me was the orthopedic surgeons were dealing the spine in a different way with the disc prolapse, unlike the neurosurgeons, you know. So this is one thing I learned, but never have I imagined a day will come where I would be learning about endoscopic spinal surgery. And it fascinated me when I met SUKUMAR. Naresh was known to me for a long time, and when SUKUMAR was introduced to me, and he wanted to, first of all, that he's an endoscopic spinal surgeon. That was a very exciting thing for me, that I have heard about endoscopy in other areas, especially the laparoscopy, but how would anybody go into the spine in an endoscopic way? And then I realized what is technology doing to the world, and youngsters like SUKUMAR and all of you are the future of more and more technology. And I also had the opportunity to, they actually came to, for an advice from me, because I was one of those people who kind of started a single specialty into multiple centers, and today my exhibition Eye Hospital, which I founded, got a Singapore investment of 1,300 crores to go pan-India. So I'm sure all of you have dreams of your own. Today at the age of 75, I'm more or less fulfilling my dream of in the field of ophthalmology, having achieved many things. But seeing that SUKUMAR had just started and already doing great things, and I've seen some of my own patients being treated, and I'm sure all of you guys as neurosurgeons are going to wonderful future, and then you're going to learn a lot of things between yourselves. And I would like to thank SUKUMAR, Naresh, and rest of you guys for giving me this wonderful opportunity to be here this morning and sharing with you this great thing, especially this Saraswati Vandanam. For the first time I've heard, and a great introduction, Amma, Dr.
Thank
Padma.
you. Thank you, sir.
Good luck to all of you. Thanks once again for the opportunity.
Thank you, Dr. Kasu Prasad Reddy, for your insightful words. And it's nice to know that you are also one of the many neurosurgeons included in our team. Thank you, sir. Next, I would like to request Mr. Naresh Kumar to felicitate Dr. Lokeshwar Rao Sajja. Thank you, Mr. Naresh. We request now Dr. Lokeshwara Sajja, our guest of honor, to address the gathering and share his thoughts.
Good morning, everybody. Dr. Kasu Prasad Reddy Garu, Dr. Alok Ranjan, Dr. SUKUMAR SURA, and the distinguished endoscopic spine surgeons and from the Indian and international surgeons and distinguished delegates, ladies and gentlemen. I am truly honored to stand before you today as one of the guests at the Spinoscope 2023, the second international master class on advanced spine endoscopy organized by the Spine Endoscopy Research Foundation and Bharat Academy of Spine Endoscopy. As a cardiothoracic surgeon, it's an incredible privilege to be a part of this gathering that brings together some of the brightest minds in the field of spine endoscopy and surgery. First and foremost, I want to extend my heartfelt gratitude to the organizers, Dr. SUKUMAR and his team, for inviting me to share my thoughts and experience with all of you. The work you are doing in the field of spine endoscopy is revolutionizing the way we see so many endoscopic surgeons here in this gathering, the way we diagnose and treat the spinal disorders, offering new hope to countless individuals around the globe. In my years as a cardiothoracic surgeon, I have seen firsthand the critical role of technological advancements play in transforming the healthcare landscape. The rise of minimally invasive procedures, such as spine endoscopy, has been nothing short of extraordinary. It has not only improved the patient outcomes, but also reduced complications and recovery times, allowing individuals to return to their normalcy faster. The theme of this conference was at the forefront of evolution in full endoscopic spine surgery is particularly significant, and it signifies the commitment to push the boundaries of medical science and technology. It is through research, collaboration, and innovation that we can continuously refine our techniques, provide the best possible care to our patients. As we delve deeper into the realm of spine endoscopy, I want to emphasize the importance of evidence-based practice. While it is essential to embrace new technologies, we must always ensure that our decisions are guided by sound scientific evidence. Rigorous clinical trials and research studies are the backbone of progress in medicine, and they should guide our path forward. Collaboration is another pillar of progress of healthcare. We must foster an environment of cooperation, open communication among medical professionals, researchers, and industry stakeholders. By working together, we can share knowledge, pool resources, accelerate the development of cutting-edge solutions that will benefit patients worldwide. As the President of Indian Association of Cardiovascular and Thoracic Surgery, I am well aware of the challenges that medical societies face. However, I have also witnessed the incredible impact that such organization can have on advancing medical knowledge, improving patient care, advocating for the welfare of the healthcare professionals. I encourage all of you to actively engage with your respective professional societies and contribute to their growth and development. I want to commend the organizers of the Spinoscope 2023 for incorporating education into the conference agenda. Continuing medical education is vital for all the specialties to stay abreast with the latest advancements and best practices. By investing in our knowledge, we ensure that the patient receive the highest standard of care. Before I conclude, I would like to extend my heartfelt wishes to all the participants, international and national faculty, the exhibitors. Your presence here today underscores your dedication to excellence and your commitment to pushing the boundaries of spine endoscopy. In conclusion, let us remember that as medical professionals, our primary duty is to serve and heal our patients. By embracing innovation responsibly, collaborating across disciplines, and staying true to the evidence-based practice, we can continue to make a significant impact on the lives of those we care for. Thank you all for listening. I wish you a successful and enriching conference. Thank you.
Thank you, Dr. Lokeshwar Sajja, for your thoughtful words. Next, I would request Dr. Abhinandan Reddy, spine surgeon, to felicitate Dr. Alok Ranjan. Thank you, Dr. Abhinandan. We now request Dr. Alok Ranjan, our guest of honor, to kindly share his thoughts. Dr. Alok.
Welcome to all delegates from Hyderabad, rest of India, and rest of the world. First of all, congratulations. SUKUMAR is a very great teacher. I'm actually learning from him time and again. And I wish him all the best and all future endeavor and for this conference. You know, there's an evolution of a surgeon or any doctor. First you are a delegate, then you are a faculty, and then you are on a dais. This is like life's evolution. So SUKUMAR is already putting me on the dais, and it doesn't speak well for my rest of my career now. Thank you, SUKUMAR. See, minimally invasive spine surgery started in a very serious earnest way back in 1990s. But the cavities which were available, like oral cavity and thoracic cavity, they allowed early surgical intervention through that route. In India, minimally invasive spine surgery really took off in late 1990 and early 2000. Basically, I represent Minimally Invasive Spine Surgical Society of Bharat. They did not allow us to use India there because of the government regulation. I'm the secretary, and the future president, Karthik, is sitting there. We have 3-4 systems. Basically, one is pure endoscope, other takes the stendu system, and the third is tubular system. And it is my belief that not one system is right for everything. So a time will come where people will have to make the teams, and in the team they will be expert in every field, and that's how the pathology will be taken. That is the future of the surgery. Now, I still remember in 2007 or 8, sometime in Pune, there was a national conference, ASICON. There was a presentation from PLED side, tubular, and there's another colleague of mine, the Standu. And we three were put like monkeys on the dais, and rest of the spine surgeons were asking questions from us. I still remember that scene. And some gentleman of my age was firing questions. It was nearly 20 years ago. Today, scene has changed. That is very difficult for a conventional surgeon to justify all their cases through the way they were doing. But we should not become very arrogant, because I'm quite sure in 20 years' time, this scene will also change. The medicine will change, the procedures will change. It's a constant learning, but now this is a decade where this learning has to be done, and I feel this present decade, although I'm a great advocate of tubular surgery, I do everything through that, but I know that next 5-10 years is going to be innovation in endospine, where a lot of bigger and bigger procedure will be done, and it's very imperative that we all learn. Actually, I have sent one of my colleagues to learn. So this is going to be the way forward. I wish all of you to have a very happy learning. Thank you.
Thank you, Dr. Alok, for your enlightening and thought-provoking insights. Now I request the other guests to share their thoughts. Can I call upon Dr. Praveen Kadacharla to have a few words, please?
Hello, thank you for having me here. My name is Praveen Kadacharla, coming from New Jersey. I'm the medical director of Atlantic Spine Center. I was lucky enough that when I joined the practice that's been doing endoscopic spine surgery at a standalone center for over 20 years. And since first day of fellowship, all I did was endoscopic spine surgery. And over the last few years in the US, it's getting more and more mainstream. Patients actually know about endoscopic spine surgery. They come asking for spine surgery. And I've been learning a lot and been collaborating with the Asian Spine Hospital for the last 3 years, and working together to really take endoscopic spine surgery to the next stage where it's going to become the standard of care. Thank you.
Thank you, Dr. Praveen. Can I request Dr. K. Ting Chen to have a few words, please?
Good morning, everyone. I'm Kai Ting Chen from Taiwan, and I represent the Taiwan Endoscopic Spine Society to come here. It's my honor to be here. And endoscopic spine surgery is getting more and more popular in Taiwan. And a lot of young surgeons will learn this technique in his initial stage. So our society is getting bigger and bigger. So it's very great to come here and sharing our little experience about this field and discuss and have a great brainstorming in this meeting. Okay, thank you.
Thank you, Dr. Chen. Dr. Hussein Ozturk from Turkey. Can you have a few words with us?
Welcome from my side. I'm Dr. Hussein Ozturk. I'm an orthopedic surgeon, and I'm an international instructor from the RevoSpine. I started to do my journey in 2016, and then I completed all the basic courses, intensive courses. Then I started to do my surgeries. I believe the endoscopic spine surgery begins with a journey. Then now, right now, I'm international instructor. I know that you are interested in the spine surgery, endoscopic, so you are here. So welcome to this journey, and I would like to thank the organization committee. The first time I'm in India, I'm really excited to be here. Thank you.
Thank you, Dr. Hussain. Professor Karthik, a few words, please. Dr. Karthik Kailash, few words, please.
At the outset, thank you, Spinoscope team, Dr. SUKUMAR and Naresh for having us over here. Me and Dr. Alok represent the MISAB on this, and we are grateful to you for having us. I just want to say two things, two quotes. One is a quote from our favorite president, Abdul Kalam. He said, dream is not that one occurs in the sleep, but it's that which doesn't let you sleep. I think that dream was what SUKUMAR had, and it didn't let him sleep to create this. I've been talking with Suku for the last so many years about this, and I think that dream has fulfilled and fructified into the Asian Spine Hospital. So that's one of those. The next thing is, it reminds me of Lord Alfred Tennyson's poem, Brook. It says, men may come and men may go, but the brook goes on forever. I wish that this endeavor goes on forever. Thank you very much.
Thank you, sir. Since time is running out, I would like to start the sessions. The day one of this extraordinary event is dedicated to stenosis, and tomorrow the day two is focused on endofusion. I thank you all for being a part of the Spinoscope 2023, and without further ado, let's commence this remarkable journey together. Now I would request Mr. Naresh to deliver the vote of thanks.
A very good morning to everyone. Thank you for participating in Spinoscope 2023 inauguration ceremony. Without thanking our teachers, our parents, and our mentors who have accepted to come and spend their time here and share their wisdom with us, on behalf of Team Asian Spine and Spine Endoscopy Research Foundation, we thank personally Dr. Kasu Prasad Reddy sir, who has been our backbone and a true mentor, fulfilling our dreams of starting the Asian Spine Hospital, and always been encouraging us to further pursue excellence in spine care or starting a single specialty center. So we're following your footsteps, sir. Thank you for having with us this morning and starting this academic festival for the next 2 days. Then I thank on behalf of our team, Dr. Lokeshwara Sajja sir. Has been one of the things I wanted to say, the word research, the true meaning, I personally learned from Dr. Lokeshwara Sajja sir, and he is the second Indian who got membership of American Academy of Thoracic Surgery because of his original research work, and a very high prolific researcher. And God is kind that we've been closely associated with him, and he is with us today. And Dr. Alok Ranjan sir, as he said, the evolution continues, and the next decade of spine endoscopy, and we all work together to make it happen and further innovate and advance this spine endoscopy, and it's going to be only possible when we work together. Thank you, Alok sir, for having us here with us this morning, and a special thanks to the international faculty, Dr. Praveen, Dr. K.T. Chen, and Dr. Hussain, Dr. Suresh, and Dr. Zakiri for being with us, spending their time, sharing their experiences for all our delegates, and make this more productive and practical, sharing their experience and wisdom. Not last but not the least, I thank you, the national faculty, Dr. Pramod sir, Mahesha sir, Dr. Karthik Kailash sir who are here. And we are very honored to have you all here to do our best, and request you all to spend as much as time and enjoy this. And any shortcomings from outside, please forgive us. But hope you'll have a best academic learning over the next 2 days. And I thank you everyone, and we'll proceed with the next steps of a small press release. And I request the delegates to have a quick coffee break, and we'll start with a keynote lecture of Dr. Pramod Lokande sir. And I thank you everyone. Jai Hind.
Thank you, Mr. Naresh. I open this conference for the sessions, please.
So in around 15 minutes or so, we'll start with the first case. It would be a stenosis case. So just if you want to come back quickly. Thank you.
క్లిప్ మీ నెంబర్ చెప్తారా? 40 సెకండ్స్ క్లిప్ ఉంటుంది.
ఇది పొద్దునిచ్చారు, ఇది కదా సార్?
అదే అదే
ఇదేనా?
అదే మధ్య మధ్యలో ప్లే చేయండి, స్టార్టింగ్ నుంచి ప్లే చేయండి.
లూప్ అయితే సార్ ఇచ్చేస్తాను.
అంటే బ్రేక్లో ప్లే చేయండి, ఓకేనా? ఇప్పుడు ఖాళీ ఉన్నది కదా అట్లా. అర్థమైంది కదనా?
లూప్ అవుతుంది లేండి ఆల్రెడీ. శివ వైఫై పాస్వర్డ్ ఇచ్చారా దీని వైఫైది
Hello. Hello. All the delegates are requested to join back in the hall. We're going to start the keynote lecture. All the delegates are requested to please be seated. In 2 minutes, we're going to start the keynote lecture. Thank you. Hello everyone. All the delegates are requested to be seated. We'll move on to the next session. We'll have a keynote lecture by Dr. Pramod Lokande sir. For this, I would request Dr. Karthik Kailas sir, Dr. Praveen Kadim Cherla and Dr. Hussain and Dr. Karnakaran sir to chair this keynote lecture session. And now I would like to request Dr. Pramod Lokande sir to deliver his keynote lecture of Spinoscope 2023, full endoscopic spine surgery, 20 years of journey and experience, and what would be the next 20 years forward. Thank you, sir. Welcome.
Can I change this? You have an HDMI now with you? See around this side. यहाँ पे इधर से आना है. Okay. HDMI चाहिए. हाँ. Yeah. Uh, Respected chairpersons, Dr. Karthik Kailash, and all my senior colleagues, my dear friends, a very good morning to you all. So when Dr. Sukumar and Mr. Naresh, they called me up a few days back. They asked me to deliver a keynote lecture on 20 years of journey and experience. I was really astonished and humbled. And this was my reaction, why me? And frankly, I'll tell you, I don't have enough experience to deliver this keynote lecture. And secondly, I'm not old enough. So, but Naresh insisted very much and he was very persuasive. So I took up it as a challenge. And I would like to slightly modify the lecture. It's not about my journey or me. It is about about the philosophy of endoscopic surgery through my eyes and how I pursued my endoscopic career. So these are my three biggest influences. In 2000, Dr. Satish Gore sir, he introduced me to endoscopy when he just came back from US, from Anthony Young, and I was like a wide-eyed, boy at that time, just very, very new to endoscopy, not only endoscopy, even for spine surgery. So I assisted, learned from him a lot, and till 2005. My real teacher was Ganchoy. I did a fellowship under him in 2006 for more than 1 year. But the biggest influence in my life, I think, till now has been the German guy, Sebastian Rutten. He actually inspired me and helped me to take up endoscopy very seriously. So, like all the endoscopic surgeons in that era, I think we all started from central disc debulking. This was a technique where we used to put the endoscope in the center of the disc, and we used to take out the disc material, and we assumed that the extruded material in the canal, it would fall back and cause indirect decompression of the nerve root. But frankly, I'll tell you, the only person who was happy with this technique was the surgeon, because he was able to remove some disc fragments. The patients were not happy, and there was hardly any clue that we really saw any nerve root properly in this technique. This really revolutionized transforaminal endoscopic surgery, the lateralization of the skin entry point. And as we lateralized, we were able to go into the epidural space. We were able to see the nerve root, decompress the nerve root, remove the herniated fragment. But again, the challenge was, this was the biggest challenge, how much to decide the skin entry point. There were different techniques, like the most common technique or the reliable one was to measure it on axial MRI sections. So these were the different techniques. We had Young, we had Hoagland technique of outside in, Ganchoy's technique of half and half, and Rutten technique of extreme lateral. So there was a lot of confusion. But it was only with time and experience we understood that all these techniques are very, very important in our practice, and each of them, they have their own merits and demerits. So Ganchoy's technique is the most commonly used. Rutten in special cases like only L4-5, very large facet and a large central disc. Hoagland again is the outside, it is very good for migrated disc herniations, or in cases where you are not sure of the position of the exiting nerve root, or if the Campion triangle is very, very narrow. And the Young's technique, which we actually thought that it has become obsolete, I feel that now it has re-emerged as a phoenix, because we have started putting transforaminal interbody cages with this particular technique. So none of them is obsolete. It took me almost 13 years to understand and become comfortable in selecting my skin entry point. And this was the technique which really helped me to become comfortable with transforaminal endoscopy. So we marked two lines, the lateral line and the AP line. The lateral line from the tip of the spinous process, there are two lines, the green line tip of the spinous process and the red line at the dorsum of the facet. So this is how you do. Your safe zone is between these two lines. Okay, so 90% of the time it is the green line, and very rare cases we come towards the red line. So this is the safe zone, and we draw the AP line. The intersection of this lateral line with the AP line is the skin entry point. And the skin entry point changes depending on the anatomical location of the disc herniation and also the level of the disc herniation. Like if you have a very central disc herniation, you go more flatter towards the red line. So this simplified the whole stuff. The second confusion which I faced in my career is there were so many different schools of thought, outside in, inside out, half and half. And this really creates a lot of confusion amongst young endoscopic surgeons. But again, with time and experience, I think we have learned that each technique has its own merit and demerit, and it's important for you to master all these three techniques. The Young's technique or the inside out technique is the safest technique, very less bleeding, but it is not useful for migrated or sequestrated disc herniations. Whereas the outside in technique, where we always try to cut the facet and go inside the canal, it is a very aggressive technique. It is recommended for high migrated disc herniations. And as I told you before, that where the Cambian's triangle is distorted or narrow. So even though as a young surgeon you start your foundation with one technique, I feel that it is important for you to learn the other techniques and master them, because you can use them in some special situations. I started interlaminar technique in the year 2007, and I learned it from Ganchoy. It was done under local anesthesia and in lateral position using a round cannula, and it was only limited for L5S1. So this is how we did. We put the needle in the lateral position towards the medial part of the pars on the bone, and you just slide it over along the medial border of the facet joint into the disc, and the rest of the things were like serial dilatations and then insertion of the working channel. But the problem of this technique again was, there was a chance of neural injury because the part of it was blind. It was under CM guidance. And the second problem is because it was facing upwards towards the facet side, we were not able to get herniations out from the undersurface of the dural sac. So a lot of cases of incomplete decompressions were there with this technique. Learning Rutan's technique, interlaminar technique. I saw his video in 2012 for the first time, probably on YouTube or some recorded CD, and that really inspired and really revolutionized my career as an endoscopic surgeon. I think it is one of the simplest technique, orthopedic principles applied, the microdiscectomy principles applied to endoscopic surgery. And as the new technology came in, the drills, the Kerisons, it expanded the indications. I started doing it in 2013 for L5S1, and with the drill in 2016 for the other levels. So looking back and with a lot of introspection, these are the principles which helped me to grow as an endoscopic surgeon. And as I always tell most of my people, all my young colleagues, you can adapt either what is useful for you, you can discard the useless, and you can add what is unique for your own thing, just like what Bruce Lee did. So one of the first principles of endoscopic spine surgery is building a strong foundation, and this foundation is open surgery and its surgical principles. You have to really master open surgery, at least do 50 to 100 discectomies and decompressions before you venture into endoscopic discectomies and decompressions. Only a surgeon who has mastered open surgery will have the ability to come out of difficult situations, deal with complications, and explore the possibilities of new indications. And mind you, I think full endoscopy is a surgical procedure. It is not a pain procedure. Only a surgeon with good open surgery experience can become a good endoscopic surgeon. So these are the primary objectives of endoscopic spine surgery: to minimize the access-related injury and to avoid unnecessary fusions. And endoscopy is based on the principle of target-specific approach. So depending on the location of the target, there are different approaches available, but the two main approaches are interlaminar and transforaminal approach. All the other approaches are variations of these two techniques. So I really want to stress that you have to learn to master both these techniques equally well. You will always be an incomplete surgeon, incomplete endoscopic surgeon, if you're just good at one technique and not good at other. Learning both the techniques together, I think it helps you to choose the right approach for the right kind of patient. The third principle which I feel is, you have to really invest. I've seen a lot of surgeons, young surgeons, they took very dedicated training, they do observerships, and they spend a lot of time learning endoscopy, but they don't invest. When I came back from Korea in 2007, I had an option of either buying a car or an endoscope, and I bought the basic endoscope first, the basic set of transforaminal endoscope. And one of the best advice given to me by my CA, my first CA, was, I asked him, what should I invest in? Should I invest in shares? He told me that the best investment in your life is in your profession and passion, because the gains which you get from this is beyond monetary. So why you have to buy the endoscope set immediately after you do a proper training? Because if you don't buy it immediately, the initiative and the enthusiasm goes away. All that is learned is lost and you have to start from scratch. And if you don't start immediately, there is a slim chance that you will ever start. The other thing, the fourth thing which I feel is embrace the learning curve. Now this is where most people they falter. Surgical skills, or for that matter any kind of special skills, acquiring them is a time consuming process. So just after a few days of observing live surgeries or attending workshops, everybody has gone through this phase that I know everything. But when you really start doing your own endoscopic surgeries unassisted, then you start feeling that it is harder than I thought, it's not working. And then you really sink into this valley of despair. It is only when you are really very confident, when you are really very focused, then you can come out of this valley of despair and move towards the, is it working? And yeah, and move towards the proficiency or lifelong learning. So understanding this is very, very important. You have to shorten and flatten this learning curve or the valley of despair. And this is how you do it by undergoing structural training programs. This is what we didn't have at my time. So now we have the facilities to do that, especially with centers like Dr. SUKUMAR SURA's. So we have seminars, we have live surgeries, observership, cadaver training, fellowship training, and supervised surgeries. But all this should be based on the belief in endoscopy, the consistency in training, and you have to be really, really very, very patient. You have to learn that whenever you are moving from one set of surgery, like from open surgery to a tube surgery, you have learned to overcome one set of complications, but you inherit a new set of complications. And similarly, when you are moving from tube surgery to endoscopic surgery, again you inherit a new set of complications, and this is not related to experience or seniority. Even the most senior surgeons, they falter. You just have to be very, very patient in this. So another important thing which I feel is don't jump the learning curve. Like I've seen people, starting with stenosis as the first case of your endoscopy. There, I think you're just going to mess up with your career. The fifth principle I always believe is you have to think open and do endoscopic. Now this is a very important sentence. Think open, because all the basic principles of surgery are from the open surgery. You should not, we don't have different principles for endoscopy and different principles for open surgery, because the end goal is the same for both the surgeries. For example, in spondylolisthesis surgery, when we started spondylolisthesis, we shifted from PLIF to TLIF to prevent neural injuries. So I think again, removal of the facet to create space for the passage of the cage is very, very important. Either you can do it from the inside by the interlaminar technique, or you go from the outside by the transcambient technique. The second principle is you use adequate bone grafts, because it's a fusion procedure. Fusion is more important, not the instrumentation. And you have to get the bone grafts both in the disc space outside the cage and inside the disc cage, disc. And what I did is, instead of using the drill, I've started using osteotomes so that I can save a lot of bone from the facetectomy and laminectomy, which I can use for bone grafts. And follow the basic principles of distraction and compression, again for a good reduction and good cage fixation. So this is the amount of bone graft which I usually get from my endoscopic procedures. And this is how I do laminectomy with a osteotome. This is identification of both the nerve roots, exiting and traversing. End plate preparation, you can see, all done under vision, and final cage placement. Bone graft insertion, again with a tunnel through it, and we can do it. There are different ways of doing it. You can either use tab incisions for different screws, or I prefer to use a disc, because it's easy for me to insert the distractor and compressor between these two. So this is my, one of the cases which I've done. Another thing is, now this is a case of irreducible C1, C2 instability with severe myelopathy. Now, what is the standard treatment for this? Either you can go posterior, or you can go all anterior using a plate, or you can do an anterior release of the longus capitis or longus coli and the facet joint capsule, followed by posterior fixation. So the anterior procedure is a higher retropharyngeal approach. Can we reduce the morbidity by using this endoscope? Yes, we can. Now, this is the incision which is being taken at C5-6 level. This is how I go inside, find a plane between the TO complex and the carotid sheath, and this is the placement of the working channel. And this really reduces the morbidity of open surgery. So endoscopic, this is the joint. Once the endoscope is inserted, the capsule is removed, you can see the mobile joint. I'm drilling the part of the joint, and you will be able to go inside this is the joint of C1 and C2. You can see the joint being opened and distracted with this dura dissector. So these are the final post-operative images, placement of the screws, and the reduction is well done. Now the sixth advice which I would like to give, especially to younger surgeons, is you have to choose your patients wisely. Remember that it takes 1,000 patients to build up a reputation, and one bad patient to lose that particular reputation. So don't get involved in controversial treatment protocols, like a black disc or treating patients with back pain only with endoscopic surgery. The surgical treatment of back pain is very, very controversial. What you see on MRI is not always the pain generator, and it is like an elephant with a blind man. Every person or every surgeon or a pain physician or a physiotherapist, they have a different perspective of treating this particular issue. Local anesthesia, is it an option? Yes, it is very, very useful, especially in the olden days. You get the feedback from the patient, less chance of neural injury, early recovery and discharge, very less expensive. And this was mandatory in the olden days for a couple of reasons. First of all, both the technique and technology was not advanced in those cases. So previously we were not sure of the technique, how to do an endoscopic transformal approach. And secondly, the endoscopes in the era 15 years back, they were so bad that it was very difficult for us to differentiate confidently between a nerve root and a disc. So that's why doing it under local anesthesia was very, very important. But now with all the latest third generation endoscopes, I don't think the visualization is an issue, and the technique is also established. So the disadvantages of this local anesthesia is, it's a difficult position for the patient, especially if your surgical time exceeds 1.5 hours. You can't lie prone on a bolster for more than 1.5 hours. And sometimes if the patient develops some ECG changes, or because of slight pain, they develop some kind of severe hypertension, like BP shoots to 200 or something like that. It's very, very difficult for the anesthetist to control the situation and get back. And another thing is very difficult in anxious patients. People who are just afraid of needle, little bit of hammering noise also, the patient will start shifting. So it makes the life of the surgeon miserable. So I personally feel, this is my personal viewpoint, that local anesthesia should be an option. It should not be an obsession. Improvise and innovate. All of us know that the techniques of endoscopy, they are well established in degenerative disc diseases. Disc herniation, stenosis and fusions are now routinely done with endoscopy. And now we have to explore the newer avenues, which are infections, tumors and deformity. So let's start with one of the simple cases. Tubercular spondylodiscitis here, and you can see a large iliacus abscess which is not communicating with the disc. And what is a conventional treatment for this? You just take a biopsy, you debride, you do an abscess drainage and fusion if necessary. So what I did is that I went by interlaminar approach, removed the entire disc. I cut the anterior annulus and under direct vision. Now this is possible only with the endoscope. You cut the anterior annulus, and once that annulus was cut, the communication with the iliacus abscess, it got connected, and the abscess, it started flowing like this. So this is one way of treating it. you are dealing with the drainage of the abscess, you are debriding the whole thing, and you are also doing fusion. So this is another case of non-Hodgkin's lymphoma, one of my old cases. I had operated him almost very long years, I think many years back. Lumbar spine, lumbar decompression was done for paraparesis 10 years back. Cervical decompression again for recurrence 7 years ago. Multiple chemos over 10 years, failed chemo. Once he almost developed a severe reaction and almost near death. So my oncologist, he refused to give any kind of chemotherapy in future. So there was a recurrence of severe right anterior thigh pain. The oncologist, as I told you, refused chemo, and for pain relief, you see that the tumor is invading the canal on the right side, causing severe radicular pain. And I did a transfemoral endoscopy. One of the problems with this this kind of situation is that there are no anatomical landmarks. You are just entering the blind room. There is the only friend of yours is a bone, and that bone is also hidden under a lot of tumor mass. So you have to be very, very patient. You have to go under and decompress properly. And this patient really had a very good post-operative pain relief. Endoscopy is an evolving technique, and there is continuously evolution going on. So I would like to advise all my younger colleagues that unlearning and relearning is a very, very important step of this technique. So whatever you have learned previously, when you are exposed to newer techniques, you have to compare with the newer techniques. You have to discard whatever is not useful for you, and you have to learn to be flexible and adapt newer techniques. That is the way to go forward. Empty your cup. Don't be very rigid. Don't be very obsessed with personal techniques and personal concepts of treating diseases. This is how I look at it. Full endoscopy for me is a meaningful pursuit. I don't look at it as a disposable pleasure like a marketing tool. And it's a long journey. It's not a destination. And all of us have to go through it. And you should enjoy the journey. Thank you very much.
Thank you, Pramod. Thank you, Pramod, for the wonderful keynote address.
Thank you.
A keynote is a keynote, and you justified it. Two things. One is physiologically, you're young, chronologically, you're old. So that statement is negated. And I think the days of present times where we see do one, see one, do one, teach one, 20 years of experience is not to be discarded. Thank you for that.
Thank you very much, sir. Thank you.
Praveen.
No, thank you for showing that you can do complicated and unique situations with this. And one of the ways that I've gotten really into endoscopic spine surgery is early on I was doing foraminotomies, discectomies, and there's a patient with severe scoliosis, thigh pain, and leg pain, was not bothered by the curve at all. Patient comes in, multiple opinions, went to HSS in New York, said we're going to do a T10 to pelvis, we're going to correct the curve, we're going to fix everything. She just wanted her thigh pain gone. And you know what, I did a few endoscopic discectomies, and I said, you know what, let's do a block at L23, L34. We did a foraminal block, and she got 90% relief. We did a 2-level foraminotomy. The curve stayed exactly the same, but all of her symptoms are gone. So I think, with endoscope, as you get these new techniques, it's, like you said, think open, but, do endoscopic. I think you have to think symptom, and I think there's a lot of different uses for the scope. You don't always have to fix the x-ray, you don't always have to fix the MRI, you just have to fix the symptoms. And doing endoscope enough, I also realized there's pathology that you see on a scope that you don't see on an MRI. You can see strands of adhesions on the nerve, holding the disc down, which you'll never find on an MRI. They might be brushed off as, this is nothing. But doing enough endoscopes, you realize the patients could be dealing with adhesions in the foramen, could be dealing with foraminal stenosis, not just interlaminar and central stenosis. So I think it's important to get the skill so that you could find the indications in a proper way, so that every 40-degree curve with thigh pain doesn't have to be a T10 to pelvis. It could be a 2-level foraminotomy, because that's what the patient is there for, not for they just need their symptoms fixed.
Yeah, I agree with you. Yeah. Thank you. Any questions?
Any questions or anyone? There's none. We'll close this keynote address and move on to the next topic.
Thank you. Thank you very much.
Hello. Thank you, Pramod sir. I mean, I know we persisted you. One of the main reason was, by definition, keynote lecture was more to inspire people to pursue excellence. I think from your experience, more for the younger spine surgeons is what not to do and what exactly to do. Thank you. Thank you, sir. And we'll move on to the live surgery, interactive live surgery demonstration for the next 2 hours. And I request all the delegates in between, the tea, coffee is ready. But whenever you want, just step in, step out, and but continue the live surgery demonstration. I request we have for this live surgery, Dr. Praveen, Dr. Arun Banath sir, and Dr. Ramesh Chandra, Dr. Zakiri Rashid to chair this session, and we'll arrange the chairs on the stage so that moderate and interact on the live surgery. Dr. Zakiri. Hello, Gaurav. Over to you, Gaurav. Yeah.
Good morning. This is Dr. Gaurav here from
3 chairs down.
We welcome everyone. So now we are starting with the first case, that is the stenosis case. You can see the history, case history being put up here. Middle-aged female homemaker. She was complaining of low back pain.
Hello, sir. Yeah, very well. Please go ahead.
Good morning. Welcome to Spinoscope 2023. So here today we'll start with a case which is stenosis. The neurogenic claudication is predominant in this lady. So whenever there is a clinical history of neurogenic claudication, they always tell all spine surgeons rule out cervical spine. Once you rule out cervical spine and you think that the lumbar is a cause of the claudication symptoms, then the best is to understand both cuts, the T1 and T2 cuts, but the pathology is better understood in T2. Here you can see the axial cuts of T2 here. Can you focus here? So always when you are doing an endoscopy in a stenosis case, you are practicing endoscopy. 2 things you should understand, whether the stenosis is in the upper half or the lower half. So that you
Go
target
the screen and
that.
talk of it.
Here when you always tell your technician, radiology technician, that he needs to give the dedicated 5 to 6 cuts at that level. Suppose in this case it is a L4 pathology. So you need to have an upper end plate, upper disc cuts, middle disc cuts, and the lower disc cut and lower end plate. So this is the thing we need to give. You can see here the cuts which he has given, almost 7 cuts they have given here. So this is what we need to tell the technician. I want more information at that level so that I can plan whether to upper lamina to be drilled more, lower lamina to be drilled more, or the recess below or the superior articular fascia to be drilled more. This need to be understood before surgery. Here when you see here in this cut, this is the upper end plate, that is L4 end plate, and the foramen here on a bilaterally, the exiting roots, you can see the exiting roots here, and they are exiting out without any stenosis here. They have already crossed the facet area beyond, going beyond, so there is no compression of the exiting root here. Coming to the next cut, that is the upper disc cut. You see there is some stenosis, facets are okay. When you come to the next level, that is the disc level, the disc 2 cuts. The disc level, definitely there is more stenosis here, more stenosis here. Again here patient is more symptomatic on the left side. That is probably because the disc prolapse is leaning more towards the left side. Here whether to do discectomy or not, we will go inside and see. Here now when you see at the disc level, there is a facet hypertrophy, the ligament hypertrophy, the canal is narrow, there is a disc prolapse. So anteriorly there is a pathology, posteriorly and posterolaterally there is a pathology. So now what all structures need to be removed. When we come to the lower end plate, this is an important area we need to see. The lower end plate and the pedicle level, that is the lateral recess area. You should see, try to understand the pedicle superior facet. How much ligament is thick here? Sometimes the ligament is so thick here, and you only do at this level decompression, patient will be never happy, the lateral recess remains. So here when you see here, right and left, the left side, the lateral recess, the superior articular facet and the pedicle junction, there is a small projection for the bilaterally, there is a trefoil formation of the canal here. When you compare the upper level and the lower level, the canal has become more trefoil here, and here it has become almost medicinal. So we need to understand, we need to take care of this area also, where the traversing root exits just below the pedicle. So in this patient, we need to address the disc proper level of canal, disc level canal, and mostly some inferior work also. Superiorly it is okay, so we need not worry. The next question asked is how much facet need to be drilled here. So here when you see here, so there is, this is the inferior facet, this is the superior facet. So when you want to come laterally, where we are going from left side here, inferior facet and a part of superior facet to reach the lateral edge of the root. That is the idea of facet drilling, and how to extrapolate this finding on C-arm. Patient is prone under GA now, so catheterized. Now when we are doing here, we take a C-arm shoot. That C-arm shoot, what is the plan? So here today we are doing with a, and X-ray doesn't show any mobility here, so the plan of only decompression has been taken. Now when you come to the pen, sterile pen, sister, sterile mark. So what I always, this we have now devised a new technique. So can you see here? Once you patient is prone and you take a C-arm shoot, you see the canal here. This is left side, this is left side, this is right side. So when you see here, you see the canal, I am marking the canal here, I am marking the canal. So this is the canal, where is our pedicle, this is our pedicle area, this is our pedicle area. So how does the, naku gauze pe sterile gauze istara? Sterile gauze, ma. So where is the traversing route going here? Sterile. Not very glove column. So your traversing route is going here like this. So sorry, traversing route goes here. Traversing goes right like this, and it exits out, and traversing route is like this. So when you want to drill the facet here, how much facet need to be drilled? You should roughly estimate, draw a line. You can see here the bone we need to drill here is like this. This much bone need to be drilled just flush to the pedicle. So this much bone need to be drilled. You can roughly assess. They need to be drilled some part of lamina, some part of facet, and some part of inferior lamina. When you drill this much, so when you take a post surgery C-arm shoot, you should have a window like this, so that all your lateral recess, both inferiorly, cranially, you have nicely decompressed the shoulder. That is our idea today, where we need to drill a part of lamina, and in this patient, being it bilaterally, you can see a small spinous projection here. You might have to drill the spinous process here, go to the opposite side. So we need to drill and go to the opposite side. So our landing, I will explain by taking the C-arm shoot. Give me a new glove. So here patient is positioned. Normal petis. And GA, and today we are using a scope of size. The sheath of the scope we are using is a Spinoscope. You can see here, this is a 10 mm sheath. This is a 10 mm sheath where the length of this is around, you can see the length is around 120, that is 12 centimeter, and the scope what we use here is 5.5 working channel. This is the scope we are using. This is called Spinoscope. This is a 180. So this is 12 centimeter. This is 18 centimeter length. Why this length increase? I will tell you while doing surgery. So this goes inside, and the advantage here is this scope shape is oval and the cannula is circular. What does this? How does this help? When it goes inside, there is a gap. There is a gap here where the saline seeps out, so it doesn't create the epidural pressure. So that's why this system has this unique distinction that scope is oval and the sheath is circular, so that you have a gap. Then the next thing is this is a 25-degree scope with a 5.5. This is a 5.5 mm working channel. We have a 5.5 working channel here, and 2 irrigation ports and the light source. Now this is connected to the camera, the light source and the irrigation. The irrigation port can be revolved all around according to your use. Then how to hold it? So commonly people ask, we get fatigued often. So how to hold? I'll show you once we are inside. Now the advantage of this Spinoscope is we are either we can use a serial dilators or a single dilator. This dilator is 9 mm dilator. So 9 mm dilator accommodates a 10 mm sheath. So this is a 9 mm dilator. I am using a single dilator today, so that we can have a ease of doing that. And the simple punches and anything used for endoscopy we use here. As we progress, I will show you the instruments. So now we mark. How do we mark? Marking is a different surgeon marks differently. Different surgeon marks differently. So what we will do here is, patient is positioned, confirm with your colleagues that you are standing on the right, what is the important pathological side. Then the next question to be asked is, are you marking the right level? Here again you tell yourself you are marking at L4-5, that is the last but one level here. So I'll just mark here. You see the window, can you see the X-ray? Can you see the X-ray image? Can you see the X-ray image? Hello? Hello?
Hello.
Anyone there?
Yes, we can hear.
Can you see the X-ray?
Yeah, we can see
Siam image?
Yes.
So now here what I am trying to tell is there are different techniques different surgeon use. One technique is land on the facet junction. Shoot. One technique is they just land at the shoot. Laminofacet junction. Shoot. So this is one technique where they land at the laminofacet junction. Eyes just land little bit cranially and medially. Shoot. So that it is easy to drill and go to the opposite side in stenosis. Shoot. So this is where I land here. So how does this help? I am landing at the laminospinous junction, same like a tube technique where we dock our tube at the spinolaminar junction. So same, I am landing there just off midline. Shoot. Just off midline. Then I'll mark. Just marking is very small marking. Can you see the marking here?
Yes.
కొంచెం హైట్ చేయి. దీని మీద ఫోకస్ అవుతుందా దీన్ని ఫోకస్ చేయి, జూమ్ చేయాలి. మనకి ఒక టేబుల్ చైర్ అక్కడ స్టాండింగ్ స్టూల్ ఏంటి. Just I want to show the incision. Madhu, you can show the incision there, a small incision. Madhu, show the incision there.
Yes, we see the incision.
Yeah. So small incision is placed, and I am just giving though patient is under GA, sometimes the dermal ooze will irritate us. So I am just giving the subcutaneous small injection using a so that there is no dermal ooze. Now I am using a 11 blade, and again the trick here is just give a stab incision first to the skin and the dermis and the subcutaneous area. Once you are done, go inside and give a small nick on the fascia. So this facial incision will help us putting the dilator easily inside. So now I use this 9 mm dilator. Don't make oblique or the direction change. What happens as a beginner, either you are tilting your dilator like this or like this. As a result of which what happens is you are deviating away from your area of interest. So go straight vertically and land just on the bony structure. Here because you are doing a stenosis, can you see the Siam image? Siam image?
Yes.
So make the Siam image bigger. Again, the question commonly asked is how to understand the dilator, whether which part is distal, which part is proximal. So when you want to know that, try to just tilt the dilator, take a shoot. When you take a shoot, you can see the distal part is bigger. The proximal part which you are holding, the proximal part is bigger, the distal part which you are holding is smaller. Can you make out?
Yes, we can see.
Okay. So now what I do is, now I take a lateral here. अकड़े और कोई respond नहीं कर रहा है. Who is having the mic? Just ask them.
Yeah, we can hear you, Dr.
Yeah.
Sir.
Okay, friend. So again in lateral, always take a lateral shoot before you dock your cannula. So hold the sheath. Now you can see you have Can you see the Siam image?
Not yet. Okay.
Yeah, now we can see.
Sure. Yeah. So here we are at the space now. There is no need again, people ask, should we land parallel to the end plates? Here, because we are trying to start from the interlaminar space, so most of the time our interlaminar space is inferior to the disk space. So always landing here is not a problem. From here we can start drilling up. So I use this cannula, which is a beveled cannula. You can see this is a beveled cannula. The beveled cannula goes to the medial side. The bevel faces medial. This is a bigger cannula than a discoscope. This is a bigger cannula of 10 mm outer dia. So I am using this cannula, just using some simple twisting motions going over the dilator. You can see there the sheath is snugly sitting on the bone. Now we remove this dilator. So the biggest advantage of interlaminar surgery is the radiation. So hardly you take 5 to 10 shots to reach the area of interest. That's the biggest advantage. Now, as I said, you have 2 irrigation ports here in this scope. So the 2 irrigation channels give us a better irrigation and a better view. My colleague has already done the white balance. So I am going inside now. Make the endoscopic image bigger. Make the endoscopic image bigger. And once you go in, what you see when the scope is inside, you see a circle at 6 o'clock of your screen. The image circle, you see a mark, that is an arrow mark, that is towards you. So we are standing on the right side here. Salindra. We are standing on the left side here. So when you stand on the left side, the 3 o'clock is caudal, that is 3 o'clock of your screen is caudal. 9 o'clock of your screen is cranial. So that is left hand side is cranial, right hand side is caudal, 6 o'clock is towards me, that is towards the facet. The moment you dock inside, you should understand 6 o'clock is the facet, 9 o'clock is the upper lamina, which we are interested in. So the small muscle fiber is there, we just coagulate this muscle fiber. I am using a bigger bipolar, the RF probe here, it's a stenosis probe where 2.9 mm is the surface area and it is a rigid one. So as a result of which we can coagulate on the bone and we can shrink the tissue faster, use more wattage of current so that we can shrink the tissue faster. Once you just coagulate this small bit of muscle, again always as a beginner you should be focused that 6 o'clock is the facet, 6 o'clock is the facet and lamina. So I am just removing the small bit. Again now sir, there is a small bleeding now, so don't get panic. So what you do is just go near now, just go near. I am taking the scope near. See my left hand what I am doing. I am taking the scope near. I am just taking the scope near. Once you take the scope near, you will find the bleeder. So on.
What is the blood pressure?
100/50. So sometimes there will be small intramuscular vessels which bleed profusely. So they trouble. So common question asked by the beginner is that we spend lot of time coagulating these vessels and we have a problem. So there are many ways of tackling it. Mahesha uses monopolar here so that he can shrink the tissue faster and better way. You can see the plexus of vessels here. So this is the one which is causing the bleed. So you can use a monopolar, you can use a bipolar here, because as long we have not entered the spinal canal and exposed the thecal sac, you can use the whatever type of current you want. But the moment you have exposed the thecal sac, you should be very careful which type of technology or current you are using. So once this coagulation
Sukumar, do you use pressure pump here or just a simple gravity pressure?
Yeah. So again, the second common doubt asked is the pressure pump or the gravity. So most of the time, everyone can't afford a pump because it's very costly. So again, you keep your hand still, don't move too much, you go to the next level. So you are feeling some bone here. Once you start feeling some bone, you try to understand what is that bone. So just remove this small soft tissue, that is the fat. Now you can see there is a bone here. Can you see the bone?
Yes.
Once you see the bone, try to work on the medial side of that bone. So try to understand the interlaminar space. So I just go medially and try to remove this small bit of muscle fascia which is attached to the lamina and the facet. So I'll just try to cut this cutter small.
So if you are using gravity, always use saline bags, not bottles, because bottles, once the 10 ml, 15 ml fluid goes, it stops giving you the pressure. So always use bags.
So what I am trying to cut here is the fascia of the muscle, which is it inserts there, which attaches to the bone. So you can use various techniques here, but as a beginner you can use a cutter and coagulate the edges. So I have used the cutter here just to see the our corridor is very narrow here, as we saw in the X-ray. Now I am just trying to delineate the medial border. Here Mahesh has developed a wonderful few instruments where we can use and make our work faster. Curated, yes. So he has designed some curates which makes our work very fast. Initially you have to struggle to clear this soft tissue. Now with the curates we can usually scrape off this tissue from the bone to delineate the bone. So what we are seeing is a lamina here with the curate. I am using a curate which is little bit curved. Can you see the curate here? I am using the curate now, trying to scrape off the soft tissue from the bone. Why I do this is, before you start drilling, if you have this soft tissue on the bone, every time sister has to clean your burr, and the soft tissue comes in your burr, and your vision is always hampered because of the floating particles like this. So that's why I always try to delineate the bony anatomy very well before going to drill that. So you can see that there is a bone seen there. There is a medial edge started appearing. That's a medial edge. That's a medial edge. So once you see the medial edge, just try to follow that medial edge medially and cranially, where you can reach the spino-laminar junction. So all we are interested is the spino-laminar junction also here. So now I will remove the further soft tissue here. I will remove the further tissue so that I can see the interlaminar space a little bit. So I just remove the soft tissue. Now can you see the interlaminar space there with yellow ligament?
Yeah, we can see it.
So this is an interlaminar space with a yellow ligament. Now, as we saw in the MRI, we need to drill the base of spinous process. Little bit of spinous process has to be cleared. So this is a base, side protection. But this is a facet. Now I just delineate some tissue inferiorly, so that every structure need to be understood before drilling, so that as a beginner there is no confusion, there is no bleeding. Cutter. So I just cut the facet here medially so that I try to understand the inferior most part of the inferior facet. This is the inferior facet we are seeing here. I am trying to just cut the tissue here so that I can understand the medial part and inferior part better, so that drilling is better. So I am just going to cut the tissue here. Because of stenosis, the tissue becomes tough. because of the hypertrophy, the tissues are very tough. So you tend to break your instruments here. So always be careful. Instruments are costly, so try to use it very carefully. Once you break the instrument, sometimes you don't have a backup. You have to stop or you have to convert the surgery. So always, as a beginner, you have a less instruments, use it very wisely.
Dr. Sukumar, can you show us how you're holding the scope? Like you mentioned?
Yeah, so I forgot to show that. So just now again, I'm using the ring and little finger to put
Can we put that
the
on
place. Yeah, can you focus this here? Yeah, so little finger and the ring finger are sitting on the sheath. What does this help? I can rotate the sheath up and down, medially, laterally, inferiorly, craniocaudal. Then the second is the thumb. My scope rests on my thumb like this. This thumb works for zooming, zoom in, zoom out technique. So you can zoom in, zoom out. So your hand doesn't ache much, curate. When you hold like this, some people hold with their entire hand, they hold. So it's an individual way of doing. Once you start learning, you can use whichever you are comfortable. What here I am trying to do is remove the soft tissue so that I can entirely delineate the. So I am using a curate here. See the curate how I am using here. So to remove the tissue, punch, so that I can delineate the entire that curvature of spinolaminar junction. So now you can see the curvature. I'll just do the RF here, the floating things. Can you see the bone curvature here?
Yes.
So bone is curving here. That's a lamina spinous junction. You can see nicely here.
Do you check that with the X-ray to make sure that's the spinous process, or you're going by
can you,
memory?
Praveen, can you just be louder? I am not able to hear you.
Do you check with X-ray to make sure you're at the spinous process, or you go by your feel during the surgery?
Here, because we are, the space is important. Once I am sure that I am in the L4, L5 space, and I am at the anatomical landmarks here, I am seeing the lamina, I am seeing the base of spinous process. So with the anatomical landmarks, I don't take a X-ray here, because here you want to see the X-ray, you need to take a AP view. So you want, I'll just take a AP view.
Yeah, you can take one AP view. And also you can keep a burr and show them where it is.
Yeah,
huh?
I'll show them.
Yeah.
So okay, AP kotra. I'll just show that. AP. నాకు ఒక dissector ఇస్తావా? Yeah.
At this stage, during AP,
Yeah.
the fear about the scope coming in our way and hitting like what is happening.
Yeah.
I think that is one challenge, and scope is totally perpendicular to the.
Yeah, you need to have a good technician for that. The question asked by Dr. Professor Karnakaran here is, when we are taking a X-ray image here, always we have a difficulty in taking a AP view. Can you see the image there?
Yes.
So this is a area of interest where we were talking about. Shoot. This is the area of interest, and I just put my dissector there and show the anatomy.
Yeah, that's the challenge.
Yeah,
which,
I know. So,
but there is a very good coordination between the technician and the surgeon.
Yeah, he's an expert. I have technician. I'm fortunate to have a wonderful staff here. So what I'm just pointing out is here the facet. Just I will show, oblique my scope and show. Can you see that? This is a facet area. This is a lamina. I just come out. So that's a lamina, starting of lamina. Can you see that?
Yeah.
Yes.
So I'll go in again. I'll remove it. Lateral bit. So we are sure that it is in the lateral. We are sure that we are in the spinolaminar junction punch. So we'll start drilling from here, then slowly delineate the things better. Here you see a bony projection here. This is the base of spinous process, and this is end of interspinous ligament here. So to go to the opposite side, if you can drill this hump little bit, so it will be better that you can go to the opposite side in a better way. So I start drilling first. I just lower this hump as an side protection. So now I am using a drill system by RevoSpine. The drill system is a shaver system. You can see the burr coming inside. It's a sharp side drilling burr with a protection. The advantage is soft tissue doesn't come in your burr here when you are using, and you can see it is drilling from only sides, and sometimes you can only use the tip also. So what you should do is, when you are drilling, go near, start drilling, and you should have a suction where the fine particles are sucked. So I start from the base of the inferior-most part of the inferior facet. You can start, see how I am drilling it. So once I am drilling, I am using the sheath as a small retractor here. I keep the tissue and I start drilling. Once I am drilling here, make a stop every time you drill. Remove the soft tissue. See the bone what you have drilled. See how I am curving there. I am just curving towards the medial side. That's the base of spinous process. Towards the dome I am drilling there, which I was talking about. I just shave it off so that going to the opposite side becomes much easy. Much easy. Once this is done, again I go inside. Now you see some floating particles there. So what to do with that floating particles? Just remove it and just do RF. Otherwise you don't see the edge properly. So see, the cavity has become bigger now. Cutter. So just remove the particles. I am using a cutter just to cut this small fascia so that I can see the bone properly. Again I come deeper, just cut this small fascia so that I can go more correctly. Yeah, drill again. Then again I'll drill. Now I can see the better space there. I got a better space now. I'll just go and again drill. No need to hurry here because you don't want to lose the facet. So do as much less facet removal as possible. Only how much is necessary you remove it. So don't hurry and drill more facet. So I'm just drilling the facet lamina junction. Lamina can be drilled, no problem. Then going medially, lamino. This is a laminospinous junction. Yes, sir.
Quick question, Dr. Sukumar.
Yeah?
You are concerned about the facet being compromised.
Yeah.
So how do you know that this is the limit beyond which you don't want to take the facet? You might be afraid to compromise on stability.
So question from the Professor Karnakaran is, for a beginner, how do we say that here we should stop? So as we discussed before, we need to, yesterday I was discussing with Dr. Hussain. So when we go inside, now my cannula is straight. You can see my cannula is straight here. When I cannula is straight, and see there, I have landed as medial as possible. I have landed as medial as possible, and my cannula is straight here. So when my cannula is straight and you see a bone there, see, you can see a bone there.
Okay.
So whatever bone seen there need to be drilled, because at least when you say from midline, one midline till the pedicle, if you have a 15 mm of space, at least your 10 mm sheath should accommodate in that space.
Okay.
So you are working with a 10 mm sheath. If 10 mm sheath goes inside, so you have created a 10 mm space there, which normally from the midline till the pedicle average it would be around 12 to 15 mm. Drill. Superface, yes. Yeah. So the
Dr. Sukumar, is this typical amount of bone bleeding that you see, or is this a little bit lower than usual?
I didn't
The bone bleeding, is this typical of the amount of bone bleeding that you see, or is this a little bit lower than
Yeah,
usual?
sometimes the bone bleeding is more, then you need to take the diamond burr. So here, the initial part of the bone drilling, you don't get a bleeding much. The moment you go deeper, the bleeding will start. So then you might have to take the diamond burr, which eventually I will take. So here, diamond burr kotta తీసుకున్నాను. So here what I am trying to do is trying to the drill and make the shape as a L shape here. Now I use a curette. The question asked here by Dr. Ramesh was, when we are drilling like that, how do we know that we are we are at the correct space, correct level, that is, we have not crossed beyond the superior facet. That's why this is a technique what I do. You remove the superficial layer of the ligament. So what I am trying to do here is, I am trying to strip off the superficial layer of the ligament. You can see that's a deeper layer which is more yellow. This is a fibrous ligament. So I am just trying to remove the superficial ligament here and strip it off from the inferior lamina. So that helps in me two ways. Answer to your question, I can start seeing the superior facet also, and I can with the removal of the superficial layer. So this is what I want to show to the beginners. You remove the superficial layer of the ligament before you remove the entire ligament. So what happens with this is, you can see the yellow fibers orientation. So deeper part, the yellow fiber orientation is seen nicely. I will just show you punching. I'll just remove this superficial part first and show you the upcut. The second important point, Dr. Karnakaran, here is, this is what I always emphasize, you remove the yellow ligament, then see the orientation of the fibers here. Punch. So you can see the orientation of the fibers here. The biggest advantage what I see after removing the yellow ligament is, I try to find out the midline raphe. So now you go deeper. Can you see the red line there, dissector? Can you see the red line here?
Yes.
Here. So this red line is the midline raphe. This is a midline raphe. Now you imagine yourself, this is a midline. Inferiorly you can see there is a canal is wide here. Can you see the canal is wide here?
Yes.
When you come up, the canal is become tapering here. So from midline, the canal is tapering. So our traversing route is somewhere here. To decompress the shoulder better, we need to remove this bone. Only then our shoulder will be decompressed. So when you take out the upcut, take out the super. Yeah. Yeah. RF. Yeah. So that is the opposite side. The yeah. On. So I'll just coagulate this and start doing superiorly. So now I just have to drill the apex here towards the apex. So I'll just make a good inch of diamond. So now sister has taken diamond because here your bleeder start. So that's why I take a diamond here. So now you can see I just go near and start using the diamond at the edge. Because we have removed the superficial layer of the ligament, you see the bony landmarks better once you remove the superficial layer. So here go near at the edge of the ligament, you can say start drilling. So first cranial limits of our drilling are, you need to detach the attachment of yellow ligament. So it is going cranially anterior to the lamina, almost 1/3 of your lamina. It spans and ends there. So till there you need to drill the lamina to expose the yellow ligament. So detach the yellow ligament. So I'm just going there towards cranially. Yeah. Yeah. So otherwise your vision is very hindered. So yellow ligament will definitely hinders our vision. Once it is removed, you see start seeing the better. Now you can just see the distance between that red line, that is the midline raphe, and laterally it is increasing now. So it means that we are creating a good canal diameter here. So this is a pars area. For all beginners, you should be very careful drilling here, because this is a pars area. You drill more. So yeah, so for that you take a shoot here, you take a lateral shoot. Can you see I am at the disc level now. Beyond that I will start drilling the pars. So you should be careful here not to drill too much bone. So go stepwise. That's why I take a diamond burr. The advantage of diamond burr is it drills the bone slower, not faster. The cutting burr drills the bone faster. So that's why if you want to save the bone and the bleeding also, it helps. So once you go cranially, idea is to go till the cranial attachment first, then come laterally. So I'll just go cranially here. Then we go to the opposite side also once it is done. So then the common question asked is how to identify that my cranial end is almost done. So that also there are pointers. The ligament changes its pattern where it inserts into the bone. It becomes more granular from shiny ligament. So I'll just show you that point now. Here. So you can see the ligament here. Again I just scrape off the attachment here, just scrape off the attachment here. So just see dissected. And the ligament is attached to the pars bone here, very towards this area. The ligament is attached very tightly. So just try to detach the ligament here so that we can pass the upcut easily. So here it is very tight. Our upcut, that is the kerison doesn't go here inside. So just detach the ligament here, then go up and detach the ligament here so that I can put my kerison here. So I'll just use a kerison now, kerison punch. RF. Yeah. So I just make my vision better with this coil. So now you can see the bone clearly. I'll just use a kerison here, pass the kerison. You can see the kerison, just pass the kerison. Because I use a dissector to dissect the ligament, it is going easily now. So just I am using a kerison to undercut the bone rather than through cut the bone. So I am not using a through cut here, I am just using undercut and using the angle of the scope to see. We can use the burr, So as a beginner sometimes you might just plunge here. So I am just doing as if I am a beginner, I am doing this case. So step by step, I don't want to plunge there. So I am just going bit by bit. So the moment you reach the end point, your ligament starts becoming more granular. So I'll just take out this and see and show you that granularity, what is the difference of a normal ligament area and the area where it inserts. So just cut this bone and just starts to, yeah. You can do that, but sometimes bone is there inside the kerison, the mouth. So you might crushing the same bone. We can do that also. So yes, punch. Yeah, so it keeps on floating and irritates you. So sometimes. So now we'll try to on.
Dr. Sukumar, I want to ask a question.
Yes.
Do you use any special drugs to prevent the bleeding, especially for the bony bleedings?
Special?
For the bony bleedings, do you use any drugs to the patient, for the stenosis patients?
No, just use a RF and some pressure and some technique I'll show you. Once any pointed bleeding comes, I use a dissector technique. Yeah, you can use bone wax, but sometimes it because of the I use a dissector here. You can see the pointed bleed there. So what I use is I use a dissector and just crush the bone there. So you can see there the bleeding stops. The second thing I wanted to show is you can see the yellow ligament has become more granular here. Here it is more yellow. It has become more pinkish and more granular. So I'll just use a curette to check whether we have reached there or not. So I just use a curette and just check whether we have reached or not. So need to drill little bit more. A little bit more need to be drilled. So I just use a drill now. So little bit drill cranially. So then we start drilling laterally and see our lateral work is done or not. So I just go cranially. So this is very important for a stenosis surgery. If you don't detach the ligament properly and hurry yourself, then the stenosis work is incomplete. So try to do it. Try to take the moment you say you are an endoscopic surgeon, you need to have a lot of patience. Don't skip the step as a beginner. You always follow the rules. Go step by step so that you will not cause any complication. If you skip the steps as a beginner, master can do that, but not the beginner. Why I am going very slow is to show the step by step. So how you want to do it, how I do it rather. So yeah, definitely. Yeah, that should be learnt in our practice. Upcut. Yeah.
I think one of the key tricks is to remove the superficial phlegm, because that definitely will give.
Now you can see that that's a midline raphe. Yeah, go ahead.
Yeah, like the Dr. Sukumar showed just now, the removing of the superficial phlegm will definitely give a better view, and it helps a lot.
Yeah, so it's all credit to Mahesha. Now you can see there is a pointed bleeding, very small bleeding, but making your field very blur. So first use RF, whether you can coagulate that bleeder. Can use RF first. Try RF, ledante dissector. So I am using a RF here. This is only to make our field better, not to worry about this bleeding. It doesn't cause much problem. Only thing, blurry, so you are all worried, so you don't know. So now you can see that bleeding stopped, curate. So now I'll just, you can see this is a midline raphe. So I'll just try to so small, we have reached there. I can see the, can you see the end of the, can you see the end there?
Yes.
So that's a opening. Again, for beginners, my suggestion here is don't pull the ligament, smaller, right? So I am using now the smaller RF probe where first you coagulate the vessels here. The moment you pull the ligament, the bleeding starts and you start troubling you. So this is where you coagulate the vessels here, it will not bleed. Setting is 20, that's a 20 coagulation, 20 for cutting. Now here it is done. Here it is done now. So one lateral, whether the question of Ramesh, whether we to stop here or see the superior facet, that we'll see now, because we have removed the, so I'm coming inferiorly now on. We'll see the superior facet. Once I drill some little bit of bone, you can start seeing the superior facet. Yeah, so I detached it very initially itself. It is very tough from the detaching the ligamentum, the pars area. So now what I do is, best way to identify the superior facet is curate. Take out this ligament from the inferior attachment. So once you go to the inferior, once you take out the inferior attachment here, I'll show you the inferior lamina now. So what I am trying to do is trying to strip off the ligament from the inferior attachment punch. Once you detach it, you can follow the lamina and see the superior facet nicely. So I'll just show you in a minute. I'm just removing the inferior superficial ligament which goes and fuses to the tip of the spine, tip of the ligamentum flavum. So I'm just cutting this which goes and attaches to the tip of the lower lamina or lower lamina there. So I'll just show you in a minute. I'll just coagulate this. So this is a lower lamina. Yeah, I'm feeling the lamina. I'll just clear this soft tissue and show you the lamina. You are seeing already, you can see the bone here. Can you see the bone there? Can you see the bone? Yeah. So that's the inferior lamina edge. So can you see the inferior lamina edge?
We can see it.
Ligamentum. So this is a bone, this is a edge, this is a ligamentum flavum. So deeper part going just below the edge of the ligament, edge of the lamina there. Now you follow that lamina medially. This lamina medially, this is your superior facet coming here. So we need to little bit drill here so that you can identify the superior facet nicely. So what I do is, now I drill here. So now I drill here with the projection of inferior facet which is bulging medially. So I'll just drill here. So we are okay here. We have not done more bone loss is not happened. We are sure that we have not drilled the superior facet. So we can little bit drill here. So this way as a beginner you are always safe. Your bone loss is not there. Go step by step and identify structures. So now you are drilling the inferior facet, medial border inferiorly.
While you're here, do you worry about violating the facet joint as you're drilling?
Yeah, so that's why don't open this ligament more here. If you start opening this, you open the joint more inferiorly. So that's why don't open this soft tissue once. So if you cut the soft tissue here, you expose the joint too much. So don't do that. So just stay here. That's why I'm going step by step, not removing the tissue, not cutting that area much, because you will expose the joint too much. So now you start seeing the superior inferior facet interface the joint there and the cartilage there. So you can see the difference in colors. Difference in color. This is pink. Again, in between there is a white, yellowish white here. That is a cartilage, joint cartilage. This is a joint cartilage. Below that is your superior facet. So you are there now with the medial border of the superior facet, but you need to drill a part of it also. Drill. So I'll just drill a bit there to expose the superior facet and drill a part of superior facet also, because we need, according to our MRI, we need to drill the part of superior facet also. So now you can see what I am doing. I am not doing through and through drilling. I am only doing the drilling deeper. So I am using the angle of the scope. I am only doing the drilling deeper. So you can see how I am drilling. I am not using superficial drilling. I am only doing the deeper drilling. So here you can see the yellowish cartilage. So this is a cartilage. Can you see the cartilage? That's a joint cartilage.
Yes.
You can see that's a joint cartilage. Once I remove the curate, you see the superior facet. This is where our lateral recess need to be opened up. So we always talk about lateral recess. Youngsters, you need to understand the lateral recess is this area where the pedicle facet interface, where is the lateral recess is there. So punch. It is not at the disc level, it is below, inferiorly. So you can see this is a superior facet. Can you see the superior facet now?
Yes.
RF.
So how much of superior facet you are going to drill? Number one. Number two, do you routinely remove the tip of SAP?
No. So yeah, so always here we need to correlate the MRI whether our foramen is narrow towards the foramen, that is upper disc level, is narrowed or not. If the exiting root has already exited out, as we saw in the MRI, there is no need to drill the tip of SAP, just the medial border of SAP is enough. So you can see here, I will just delineate the medial border here. That's a medial border of the facet, that is a superior facet. So here one more landmark is, if we can see today, I will show you one vessel comes here. The moment that vessel comes, also it's one of the endpoint that beyond that root will not be there. We'll just see whether we can see that small thin vessel. So upcut. So now here I use a upcut here to just, you see now my direction of the scope is caudocranial. So I just go in, rotate the scope and see caudocranial. So the advantage is I am not drilling doing a kerison of entire bone, only I am using the medial part of the bone, I am just removing it. So advantage is I will not lose the joint more. So that line which I was talking about is coming there. I will just show you in a minute. Yeah. Sure, it is a dissector. Tip of ascending facet is still little bit cranial. So they just want to know, see, you can see here. It is little bit cranial still. This is what Dr. Hussain is there in the audience. Dr. Hussain?
Yes, I am here.
Yeah, Dr. Hussain, this is a vessel I was talking about. Can you see the vessel here?
Yes, I can see.
So this vessel is the one which just it is parallel to the vessels which we see on the root laterally. So this will be the lateral edge of the root. So if you see this vessel, you need not go beyond this. So that's the end of our this one. So to make it more clear, I will drill little bit of that SAP and then we'll start going opposite side, to the opposite side. So here I'll just drill this apart.
Can we see an X-ray in this position? In lateral?
X-ray? Mm-hmm. Yeah, shoot. Yes. See, just at the edge of the pedicle where the lateral recess is to be opened up. So that's the area. So just I am drilling there. But Huh? Yeah, you can do that. That was Mahesha was asking, will you always remove the tip of the facet? No, if it is too much, once you are drilling here, you know that it is too medial, you can drill it. So this is almost the tip we are drilling now. This is the tip we are drilling. Almost we are shoot. Shoot. Can you see? That's the tip of SAP we are drilling. So we have almost reached the tip of SAP here. So what is the craniocaudal or caudocranial orientation of the scope helps us is to drill only the deeper part. We are not drilling the superficial part, so our joint is not violated, facet loss is not there. Still you are able to achieve your decompression. That vessel has come, so I am happy. You can see the vessel there. So I am happy now. My root might be decompressed. So we'll see once we remove the ligamentum flavum, we can identify it better. So just I go cranially little bit, remove this facet and pars area, little bit drilling, so that I can have a more shoulder clearance here. Shoulder will get cleared more. So this is the advantage of diamond drill, because your ligamentum flavum is there. We can drill little bit bone on the flavum itself. So now I drill the entire laterally. We are okay laterally now. We can start going to the inferior. Once we are done with the inferior, we can go to the superior. So opposite side. So superior is over, lateral is over. Then just I come to the inferior level. As we thought, we need to little bit drill the inferior lamina a bit, curate. Yeah, I'll drill the part of it so that we need not use much force on the upcut, the kerison. I'll just drill. This is. Yeah, till opposite side is a little bit over. I'll keep the ligament. It's just for the safety understanding. I keep the ligament. Just I'm drilling here because we can use a kerison here directly, no problem. But just for the sake of saving my kerison for longer time, I'm using a drill here. So now I've drilled here a bit. So then I'll just open the ligament here, curate. Use a curate here again. Just use a curate and start opening the edge of the. See, you can see that is the edge. Can you see the edge? Yeah. That is the edge. So I just detached it. It's a detachment. Again, I will not pull it. I do the RF first. I'll do the RF. RF first there, so that inferiorly again the no bleeders come in my way and irritating me. So these are the bleeders here in the fascia. So they get retracted once you pull the ligament, and it causes tremendous irritation later day. So I guess. So that is a midline. So we can detach it opposite side towards our side later. So once this is done, now the common question asked, the professor asks me often is how to go to the opposite side. You see this is the midline raphe. You can see this is a midline raphe. What I do here is I just detach the ligament, curate, either dissect. So now I use techniques which we use in cranial surgery, the pituitary surgery or ENT surgeries here, where they create a mucoperiosteal flap in the nose. So same way you use here, just you can see this is a midline. This is a midline. So I am going to opposite side of the midline. This is opposite lamina. Can you see?
Yes.
This is opposite lamina. So I am just stripping off the ligament. See? I am just stripping off the ligament from the opposite laminas. Can you see the ligament is getting stripped off?
Yes, we can see.
Can you see the ligament being stripped off here?
Yes, we can see.
So we have just stripped the ligament. Now what I do is give upcut. I start drilling a bit of lamina to the opposite side also, so that we can have a good access. So now what I'll do is I take the scope sheath outside, my sheath is outside, and drill goes inside. Drill. So what I do is now little bit drill the opposite lamina. So I start drilling the opposite lamina here. I know that I stripped the ligament, so I have some space, and Revo has developed a wonderful drill bit which we can drill on the opposite side also. So I'll just show you in a minute that drill also. It's a wonderful drill bit where it protected burr we can use on the opposite side. So you can see I am drilling the opposite side. This is opposite lamina I am drilling. No. Huh? Yeah, we can use it now because this angle it will not work. I'll show you in a minute. So you can see how I am creating a space. What I have created towards myself, I am creating towards that side also. So just doing a laminotomy so that you can have a good space post-op. So you can see here now I have created a space. Curette. Now I will use a curette to further detach the ligament. So I have gone to the opposite side now. You can see here I am just going. This is a facet.
Do you take a C-arm shot now? No.
Yeah. So I am just take a C-arm shot here. Shoot. You can see here the opposite side inferior facet.
Yeah.
So now I will just drill here. The protection bar is first stitch. What I am trying to just strip off the ligament connections from the bone as much as possible from
what
this.
What is that which you are seeing between the bone and the ligament? Is it the upper, at 11 o'clock, 10 o'clock, there is a bony part and a ligamentum part.
Yeah.
Is it the base of the spinous process?
Base of spinous process, and that's a lamina. I will show you the dissector. See, first again orient yourself. So this is the midline.
Okay.
This is the opposite lamina.
Okay.
This is the opposite base of spinous process.
Okay.
Base of spinous process, lamina. You can see the difference. Lamina is a more compact bone. Spinous process is more cancellous.
Okay.
So this is the opposite lamina coming down. Lamina. This is a lamina facet junction. Lamina facet junction. You see the bone becomes more pinkish here.
Okay.
So this is a facet. This is a facet.
Okay.
And you can see the facet capsule here. So here we'll just use the protected drill. Ramesh was asking. So you can see here this is a different type of a drill. You can. It's a half sleeve is halved there. You can see, so that to go to the opposite crevice, it is easy. So I'll just go to the opposite. Just have to negotiate a little bit. I can go to the opposite side like this.
Okay.
So once you go to the opposite side, you can correct.
Not articulated.
So you can drill there. So just I'm finding it difficult to negotiate into that crevice. I'll use a upcut. Diamond pettese. So now the angle of the scope always helps here. Because of the angle, I am going to the opposite side and I am able to work onto the opposite recess before opening the ligament. So how does this help is, you are not causing any bleeding during the bone removal. Otherwise epidural bleeding will hinder your bone removal and cause lot of problems. So I am using the upcut to remove the medial part of the facet and just a part of the lamina which I have drilled.
How much facet do you take on the contralateral side?
Yeah, just a part of it, not too much, because once I remove the ligamentum flavum, till I see the opposite root, and if a bone is too much overhanging over the root, then I remove it, otherwise I just undercut it. So here why I am removing the bone before I open the yellow ligament is the ease of removing the entire ligament at one go. Second thing, there is no bleeding here before removing
sorry for
it.
interrupting. This part you want to remove, that bony part which is coming on a wave, do you want to remove it?
Yeah, upcut. That's the base of spinous process.
Yeah, to
so
make
you need not worry, just you can remove it so that our vision becomes much better. It's a small projection of your spinous process. You can just remove it. Sometimes the Bastrop disease happens here, and the both spinous process meet RF.
Burr, you can use the burr too.
Yes, you can use the burr there, RF, then burr. So just I am removing this
that is the superficial part of ligament.
superficial part of the ligament on the opposite side.
And if the patient has bilateral symptoms, do you think it's enough to go to the contralateral side from, the left?
Yes, yes, definitely. So I am just showing how it can be done, where to see the anatomy better, to see the opposite inferior lamina better, and just show you the inferior opposite lamina here, cutter. So it is just to delineate the anatomy better. You have a opposite inferior recess stenosis, also very bad recess stenosis. So once you remove this part earlier, so your vision becomes better, and ligamentum flavum removal becomes better. Once root is well decompressed post-op. So it's just to show, you need not do this way. I am just showing it can be done like this, so that you can see the anatomy well before removing the yellow ligament on both sides, not only the ipsilateral side. Now you can see the midline structure there, dissect the curative.
And the inferior side where we have.
So inferior side, this is the end of your inferior ligament. This is a midline. This is a midline.
Okay.
And this is opposite lamina.
Okay.
Opposite inferior lamina. So you can just strip off the ligament here also. Once we are coming, and just strip off the ligament here. You can see I'm just stripping the ligament from the midline,
And
from the inferior lamina.
You're using the Spinoscope. What happens if you use a regular scope? Is it enough to go to the contralateral side?
Yeah, definitely. Yes, the smaller scope, it is the smaller scope. One disadvantage is the time, RF. You take lot of time to remove the ligamentum flavum. So because you use the smaller instruments, it takes lot of time. So here you can see I have stripped off the ipsilateral lamina or contralateral lamina inferiorly also. So now I can remove the ligament easily. You can see this is a spinous process.
Do you want to remove that tip of lower spinous process?
No, in this case I don't think so we should remove. Now I start removing the ligamentum flavum, curate.
Dr. Mahesh, why did you ask that?
No, that is a valid question, because when a stenosis is more inferiorly and the canal is very much narrowed, so we might have to a little bit chip off the bone that coming there also, so that canal is spinous canal, so space is also opened up nicely. So now what I did the RF small.
Because sometimes this tip of SAP will obstruct your vision going to the other side.
Yeah. Okay. So now I just removed the ligament. Here small bleeders comes, you should tackle it before you go further in. So otherwise they keep on, you becoming blind and keep on coagulating. So I coagulated once. You have detached from that is a lateral recess area inferiorly. So that's a lateral recess area, pedicle area. So we'll just take a shot once we go inside. That's a pedicle area. So now I use a upcut. So I use a upcut here now to detach from the medial side, the lateral side. So I just go there, so detach it. So don't pull it, stop there. If bleeding is there, you start coagulating. So just start detaching here. This is a vessel I was talking about. If this vessel is gone, so you can see the lateral edge of the root. Can you see the lateral edge of the root now?
Yeah, we can see.
So this vessel, you can see the vessel which I have taken in the punch. That vessel correlates the lateral edge of the root.
Can you exactly show me where the vessel is?
Patkomitla.
There I can see that. Yeah.
I'll just show you. Dissector. So the question is, where is that exact vessel which we saw? So this is a vessel, see? This is a vessel we saw, which was here, and this is the lateral edge of the root, see?
Correct.
So most of the time it correlates. This is my observation. Writing on it, the observations of endpoints in endoscopic stenosis surgery. This is one anatomical landmark where you can stop while you are doing drilling most of the time. So I'm just detaching from the lateral aspect. So the advantage here is, if you remove bit by bit, sometimes.
What I am observing is the superior part has easily got detached. The inferior has also got easily detached. The one which is towards you is. No, the superior and the inferior part seems to have got detached quite easily compared to the one which is on your side, on the ipsilateral side.
Yeah, because here it is the ligament goes below the facet anteriorly towards the pedicle. It spans the capsule and goes. So I just have detached. This is the pars and shoulder area I was talking about. Shoot.
Please, yeah.
Okay.
Yeah.
So here the Mahesha was asking about his favorite question, the tip of SAP. So you can see the disc there. Can you see the disc?
Yes.
This is a disc, upper end of the disc. So we have detached till there. Then we have to detach it little bit cranially and medially. So just go there.
What you can see here is there is not too much space lateral to the root. That means the facet is very well preserved. If you see too much of space lateral to the root, that means you have removed too much of the facet. So this is very important, especially in a narrow canal and a vertical orientation of the facet.
There is a small bleeder there, which is hindering your work, dissector. So here either you can use RF. Again, RF doesn't work most of the time. So I use this. You can see I am coming closer to that bleeding point, and you can just crush it. So just crush it. So what Dr. Karunakaran calls it as posicify. So you can posicify.
Posicify is only with RF, but
what is that? Can you repeat?
So
what is that Tamil? What is that Tamil dialect?
He says in Tamil, posicify. Posicify means just
RF, ablate it.
Ablate it, or you can crush it.
Okay. Now what he is doing is something.
So you can see just the bone. I just compressed it and it stopped. So now I just remove this part of the ligament, detach it from the pars area. Then our entire cranial, lateral, caudal limits are removed. So I'll just go in here. In the midline. Can see I just hold the ligament and just take a bite. So again I go in. Here you need to be careful not taking a bite of the thecal sac. So I detached it.
But how do you do that? Because you're not seeing it, but how you are going with the feel?
No, hold the ligamentum flavum. Just pull and see whether if your thecal sac is moving, don't pull it. You stop. So then only you confirm and pull it. So just detach the entire ligament there now. Then once it is done, the midline raphe helps us just detaching it easily. Dissector. So
has
here,
anybody got any other technique of doing this?
You can remove a bit by piece. The piece by piece, the piecemeal technique, you can do that if you are not confident. But the only drawback is every punch you take, you are at the risk of injuring the dura. Punch. So, especially critical stenosis. So you might harm the function. Now you can see I am removing the entire ipsilateral half of the ligament.
At this point, is there
entire you can see the video, Babu. Ikkada, close see.
Now the concern is during this detachment, is there any adhesions? What would you do?
Yeah, so for that, always try to dissect it, use a dissector, dissect it before pulling it out. And if you feel any additions, you can address it before. So second important point, the common question asked is the bleeding, epidural bleeding. So whenever there is a lot of epidural bleeding, we are not able to control it. We will have to coagulate. Sometimes root is coagulated. So root is thermal injuries to the root causes lot of paresthesias post-op. So here you can see the and just removing that flimsy area. Once you remove that, there are four corners of bleeding. One is the medial part or just below the ligament. You can see the midline raphe. You start coagulating just under the ligament. Don't touch the thecal sac. Lift the ligament and coagulate. The second corridor is inferior. This area, which I was told in starting, there will be some bleeders here. You coagulate. The third quadrant is inferiorly towards the axilla and the pedicle. So here there will be lot of bleed. You can stop the bleeders. Small bleeders are there. So you can stop them. Once you stop this, then the lateral to the root is the one which often troubles you. On. So that part is over. Then lateral to the root. On. So lateral to the root. See here, because being L4, L5, I don't want to lose my facet here. You can see I am just coagulating the lateral edge of the root, lateral to the root. Then come to the cranial part. Can you see the bleeders now?
No, awesome.
Entirely it stopped. So these are the corridors you should to understand. Now you see the opposite side because of drilling. I rotate the scope again caudally from cranial. See, I can stand here. My sheath is standing on the base of spinous process shoot. You can see where is my sheath landing. Can you see the sheath?
Yeah. So the spinous process.
Can you appreciate?
Very much.
So then we go deeper now. So I go deeper and use the upcut.
Can we see the C-arm picture?
Yes. Can you show the C-arm picture?
On the monitor, on the screen?
Can you see?
Yeah, C-arm picture is on the screen.
See, I'll just come out. I'll just only show the sheath. See where sheath is there. Shoot. See the sheath. I'm standing there.
Okay.
Then my scope goes inside. See, my scope goes inside. Shoot. Sheath is there. Only scope goes inside.
Okay.
Can you appreciate the C-arm?
Yeah. But why do you do that?
Just because the entire sheath goes inside, I cannot have a movement like this.
Okay.
See, the movement what I am doing is blocked. So if I am outside, the sheath is outside, I can have a good movement. Okay. So craniocaudal movement is better if the sheath is not inside. Otherwise, that sheath gets locked and your entire work space is locked. So just remove the ligament.
So was the endoscopic view larger?
Endoscopic view larger. So now you see I am going to the lateral recess. The question Dr. Hussain asked was till what level you drill or remove the bone on the opposite side. Here I am going to the opposite side here. Here one point I want to show is I thank Mahesha always because of his tools. Our work becomes so easy and beautiful. So now here I use the curette now. So curette. We stripped off the ligament from the lamina. You can see now I strip off the ligament from the upper part of the foramen. So and just see that how I am stripping off the ligament. Can you see the stripping of the ligament? It is so difficult to remove with any instruments other than this. Can see how
SUKUMAR, you are using this curate more than I do.
But thanks to you, because you are the inventor for this curate, so because of that I am, my work has become very
beautiful,
easy. So now I always remove this small areolar fascia which is there. To remove, you see the bone landmarks better, so that whether to remove more bone or not, you know better. See that's the opposite side, RF. You are seeing the opposite side without any losing the bone. That's the opposite foramen. Shoot, Chera. I am taking a C-arm shot there. Can you see the foramen there?
Yeah. Very much. Yeah,
yes.
So that's the opposite foramen. You have opened up the medial on.
Actually, if you remove little bit of bone and remove that flavum, you can see that exiting root fully.
Root also, yes.
Yes. But
So,
this case it may not be required.
Yeah, in this case it is not necessary. So now I'll just curate further. This is the advantage of a little bit of opposite side drilling, so that your vision becomes better and you can see the curate working or helping us to remove the entire opposite ligament without losing the bone. So now, the question Dr. Karunakaran asked, whether how do you know that you have not caught the dura? Whenever you are holding the tissue, just gently pull it, see whether dura is moving or not.
Okay.
Dura is not moving, just remove it. You can use the force. If dura is moving, don't use the force. You can
Now
see
it's moving.
dura is moving, I will not use the force, I will come out. So I will use RF and first. See,
Yeah.
if I had pulled, I would have injured that upcut. So now you can see the edge of the root, congested root on the opposite side. ले लो. Position सब ready कर लो. नहीं, केस फर्स्ट कर लो. एक टॉक खत्म करो. So you can see the lateral edge of the congested root here. Now I just go inferiorly. I go inferiorly and remove the ligament inferior recess punch. Inferior recess, you can see there is so much of ligament. If you don't remove the superficial layer, the visualization of this, how much is there inferiorly, we miss it. So that's why you always remove the superficial layer first, so that you can know roughly how much inferiorly our ligament is there and to be removed. So upcut. I'll remove inferiorly now. I'll remove the inferior ligament. So I'm just removing the inferior ligament. We can use a cutter also here if you want to work faster. So again, you see here there is a bleeding here. What I do is go close to the bleeder, go close to the bleeder, go close to the bleeder and see the bleeder. Whatever small it is, try to just arrest it, because later it will cause too much of hindrance and you end up in coagulating the nerve. So once it is done again, now we need to detach from the opposite lamina cutter. So I just remove this ligament and start showing the opposite recess step by step. So this I'll just cut here so that I can debulk it faster. Just cutting it. Then I'll use upcut now. Upcut. Punch. Sorry. Punch. So what we have done is 3 quadrants we have done. The 4th quadrant, that is inferior opposite, we are doing now. So we'll just, once we do this upcut, we are done with our decompression, and then we see the disc whether need to be removed or not. So again, how to do it? Just follow the layer between the I'm just removing that. These are all the things, refined things we have learned over the period of time. So you can use these techniques and shorten your learning curve. So, and safety increases. You can see the opposite root.
Yes, yes.
So opposite root is nicely decompressed. We have not removed any bone here. We are just removing the ligament which was in the recess. So that's the advantage of a little bit of cranial drilling. That's towards the lower foramen and the pedicle area. That's the lateral recess area. So just coagulate this, then remove, detach it from the ligament, the lamina opposite side. Upcut. Once I remove this over the root, then will come superficially. So root is freed completely now. Then I'll use a curette for detach from the bone, inferior lamina there, and I'll show you the superior facet of the opposite side. So that is the superior facet of the opposite side and the inferior lamina junction. So once we strip off this ligament, you see the entire bone nicely.
The bone, at the moment you are seeing is the descending facet.
Huh?
The bone which you just saw.
No, that is the superior facet. I'll show you. Because inferior lamina will follow.
No, this one.
No. I'll show you. Cut up. I will show you in a minute. So whatever doubts will just clear. So this is a lamina, inferior RF. So what I wanted to show you, your question is, this is the inferior lamina, this is inferior lamina, this is inferior lamina superior facet junction. On. So this is a root, see, this is a root, then this is the inferior foramen beyond the pedicle. Shoot, shoot Siam. Can you see the Siam shoot there?
Yes.
So that's a pedicle area. So where root goes beyond. So you have decompressed the opposite root till the lateral edge of the root is fully decompressed on. So opposite side of the root is entirely decompressed. So
Sukumar, I like to take 2-3 bites from junction of superior lamina, inferior lamina and SVP.
That's what
so
I was trying to go to do. So once you do this, so again here what happens sometimes, tendency to press the nerve is more when you take this bite. So what I do is tube sheath punch. Take a smaller upcut, that's a tube sheath punch. See, now you can see that's the lateral edge of the root, okay? Lateral edge this is a disc.
Disc, okay.
So this is a disc, then go there and take the bite. So this is a disc, go there and take the bite. So this is a bleed, usually happens lateral to the root. So stop, Chedra. You tell.
And it always bleeds there.
On. So go there, just do some small coagulation. On. Just below the pedicle, there will be some bleeders. Being a foramen, there will be some bleeders there. Don't coagulate too much there. It's okay. Small bleeder. It will stop. On. Stop. On. On. Okay. So I'm happy here now. Done a decompression bilaterally. Adi pinch. So some mild, the small bleeders from the opposite side punch. So this is okay. These small bleeders are okay. They will eventually stop the moment you make the patient supine. This is a small bleeders. చేయొద్దు చేయొద్దురా ఆన్ okay. This is a small bleeder which was troubling us. Now you can see the lateral edge of the root on the opposite side entirely freed.
Yes.
This is the opposite lamina. The ligament is freed. Ipsilateral lamina, the root, the axilla. So I'll just delineate before coming out. So this is a root. This is a root, congested root. This is axilla, the ipsilateral one, the midline thecal sac, the opposite axilla, opposite root, congested root. That's a disc. So again here ipsilaterally, the disc is firm here.
So you are not doing discectomy?
No.
Okay.
Well, how do you make a decision now whether to do a discectomy or not?
One is the MRI finding on. If MRI doesn't show significant disc prolapse, the color of the disc on T2, if it is very dark, the annulus is very dark, it means that it's a chronic disc etiology. And second thing is the intraop, seeing whether it is a uniform bulge and it is tough. So you need not remove it, just shrink it. I am just shrinking it.
What would make you remove the disc?
What
would make you remove the disc right now on inspection?
If the disc, the palpation disc is very soft, there is a pointed bulge, and I will remove the disc. So here the disc is tough, there is no pointed bulge, and the roots are congested bilaterally. It just denotes that it was a bilateral recess stenosis more rather than the disc etiology. So that's why I am not removing the disc. Can you see the end point here?
Yes.
This is the end point here.
Wonderful.
Thecal sac and the bilateral roots are seen, inferior, superior. So we have gone beyond the shoulder, till the upper foramen bilaterally. So patient should be relieved of surgery. So I am just coming out. So
do you recommend to put drain?
This is surgery. What he said was, you stop the saline and see. Here I am just trying to stop the saline. I stop the saline here. You see there is no active bleed here.
Okay.
If there is no active bleed, then he says no drain. One thing. Second thing is, keep your saline at 40. Keep your saline at 40 and see whether there is active bleeding. There is no bleeding at 40, then there will be no hematoma formation post-op. So I think here we
40
have done
means 40 mm
40 mm
pressure.
of mercury. Yeah.
Okay, on pressure
So
pump.
if there is no bleeding at 40 mm of mercury, then there will be no hematoma formation. So here, because we have done a good hemostasis, and when I stopped the saline, there was no bleeding. So I think I'll just come out. I'll just come out. See, you can see I'm just coming out. See, any muscular hematoma should not be formed. Any bleeder here, I will also coagulate that. There is no bleed. I'm just coming out. I'm just coming out. Thank you.
Yeah, wonderful. Thank you.
Thank you.
Sukumar,
Yeah.
you can take one CM shot without any instrument just to show the bony work
Yeah.
you
We'll
have
always
done.
take that last
yeah.
part. AP. మెల్లిగా చెయ్యి. So now our technician is taking a AP image. So just to show how much what intended preoperatively we thought, have we achieved that or not. So we'll just take a AP image. Mahisha, can you show them? Can you see the Siam image?
Yes, it is wonderful. You can see if they can put the pre-op and
Pre-op
this
also
one,
is there.
Yeah, it is fine. Yeah.
Can you see the both pre-op and
Yes, we can see.
what we thought of preoperatively flushing to the pedicle, drilling the bone flush to the pedicle. Here we have done that. So I think I think the patient should be relieved of this. Thank you, Mahesh.
Yes, sir.
Thank
It
you.
was wonderful. Thank you. Thank you. Is the next OT ready?
Yeah, it is ready. So they can complete one talk before my Lokand is ready. Huh?
He is getting washed now. In between, we can finish.
Mahesha,
yeah,
you can complete one talk.
Okay.
Lokande sir is washing. So
Okay.
by the time talk is completed, patient is ready already.
Okay. Okay.
So you can complete one talk.
Okay. Okay.
Yeah. Okay, Gadar.
You can have 5 minutes break if you want to take some tea or visit the stalls. You can go and come.
Check one.
So everybody just take a tea and get back to the hall. We'll start with a talk, video talk of Dr. Arun Bhanot, full endoscopic foraminal and extraforaminal stenosis decompression. तीन है, हाँ, yeah. We'll finish 3 talk and then we'll have one live surgery. Never be. Indian standard time है.
अभी ये इसका प्रॉब्लम ठीक हुआ? एट्यून का? But problem था तो वो
लोगों ने टी ब्रेक नहीं लिया।
हाँ नहीं ठीक है। No, I am there. No issue. So we have time, na? 5 minutes, 10 minutes. No, I'll stand there. यहाँ पे कैसा है कि this guy will come immediately and touch me. This. No, it's okay. This is a sterile area. I'll be stand here. He's a separate.
Hello.
Hello. Good afternoon, everyone. Everybody are requested to join back and seated. We'll start with quick lecture, and Dr. Pramod sir is ready to demonstrate another stenosis surgery. Now I would like to request Dr. Arun Bhanot sir to share his lecture on full endoscopic foraminal or extraforaminal stenosis decompression.
Mr. Madhu, ये लाइट चालू कर दो ना ऊपर वाले.
Over to Arun Bhanot sir. All the delegates are requested to seated, please.
Can you transfer? Good afternoon, everyone. My name is Arun Bhanot, and I have been given the responsibility of sharing some of the tips on how we address pathologies in the foraminal and extraforaminal region, especially in reference to stenosis, but even for your extraforaminal herniations and foraminal herniations, the same steps can be used and they can be extended according to the need of the situation. Now, if you see, I have labeled the title as the superior articular process. It is the guide to manage these lesions. So, why it is the guide? Because as we go through the talk, you will understand how it is a very important structure that is our main landing focus, where we start our work around that area. So we know superior articular process of the caudal vertebra is our initial needle insertion point. If we remember our basic spine endoscopy, we learn for transforaminal paracentral herniations, we always say touch the superior articular facet and then glide under it or slide your needle underneath it. So it is a bony landmark first reference where you feel the spine under C-arm, and then from there you get inside the foramen as well as the central area of the disc. So you can walk under the superior articular process for extraforaminal herniations. I'll show you in a couple of minutes from here. So that is how we use this superior articular process. And sometimes if the superior articular process is migrated superiorly in a very severely degenerated disc where the disc height is very small, so this can actually go under the upper pedicle, the cranial pedicle, and pinch the exiting nerve root with its tip. So sometimes it is a part of the pathology where you may have to address it. So in all these situations, we have to first remember how to visualize, how to proceed to address the position the cannula and work around it. When we have to understand how it is located, how the various neural structures are in relation to the superior articular process. So this is an MRI showing a large left-sided extraforaminal herniation. I'm sure everybody can appreciate if you compare it between right and left. Many times these herniations were missed, but now we've been talking about them for many years. So the incidence of missing out these herniations is becoming less and less. So as I said, how do we approach these? Because this is more of a practical approach, so I'm not getting much into theory, only about the surgical steps, how we address this lesion. This is a better informed audience as far as endoscopy is concerned. So you remember, you see how we approach these lesions is, we first look at the picture, we first dock our needle and then pass a guide wire at the junction where the superior articular process is touching the transverse process. So this is in the lower half of the foramen. So we are well away from any neural structure here. So this is your first safety. And for foraminal, extraforaminal lesions, we don't need to get inside the Kempin's triangle, we don't need to get inside the spinal canal because our pathology is outside. So there is no need to get inside unless and until there is a mixed pathology where foraminal herniations sometimes are accompanied by coexistence of a paracentral herniation as well. So we touch the lateral surface of the facet where it originates or where it joins the inferior transverse process. Let's say it is a L4-5 disc. So L5 superior articular process lateral surface where it is joining the L5 transverse process is our initial landing point. From there, once we dock our cannula, once we dock our needle, then followed by guide wire, of course we have to tap the guide wire a little bit to anchor it in the bone, otherwise it will be floating, so you may not be able to exactly reach there. So we tap the needle, then followed by guide wire a little bit, maybe a millimeter or two into the bone just to have an anchor. Then you glide over your blunt obturator and then you put in our beveled working cannula. From there you will start walking cranially, clearing the soft tissues on the lateral surface of the superior articular process and then go cranially and then work under the anterior surface of the transverse process, the superior articular process. So this small animation I created only to make you understand. So all this what I just described. So we touch, this is after the cannula has been positioned at this junction where the articular process is at the then we glide it, clear the undersurface of the facet, and as we clear, now I am holding it here, going back just to make you understand. So this was, we glide the cannula superiorly, clear the undersurface of the facet, and then we move towards the pathology which is in the foraminal, extraforaminal region. Sometimes the herniation is anterior to the exiting nerve root, pushing it dorsally. So this is important to come from a safe zone, then reach the nerve root, identify it, and then you handle the pathology. Just to have a revision here. Now see these steps and they will be followed in the subsequent video for the same MRI which I showed you in the previous slide. So here we tilt our cannula. Now this is, we have docked at the lateral edge. Again it is from the same MRI, the Siam picture I showed you. So this is the superior articular process which has been cleared by the grasping forceps, and now we are shifting the cannula superiorly. We have shifted, and this is the herniated disc which has been identified. The exiting root is between 9 o'clock to 6 o'clock position that has been protected by the sleeve of your cannula. It will here you can start seeing a little bit of that exiting nerve root here. So as we decompress, so it becomes easily because it was tented and posteriorly, so we don't manipulate it much. Just keep your cannula docked there without putting any pressure, rotating or trying to twist it. So here you can just feel that the nerve, this full thickness of the nerve is now, as we remove it, automatically tends to fall inside your central vision of the cannula. So after doing the major fragments, you look for any further fragment, and then you can see there is a nicely decompressed extraforaminal herniation. This is the post-operative MRI. So if you follow this dictum of landing at the facet, walking under it, anterior surface, clearing it, reaching the upper pedicle, from there you follow it downwards to see the exiting nerve root, and then you can nicely handle this pathology without having any risk of damaging the nerve. Now, as I said, foraminal lesions can also be because of the, when the dimensions change because of degeneration, the foramen tends to migrate up. So then it pinches, the tip of the foramen will pinch the exiting nerve root. Why it can happen? It can cause because of facet hypertrophy, ligamentum flavum thickening, thickened foraminal ligaments can also be there, and sometimes a shoulder osteophyte arising from the posterior surface of the vertebral body. So all these lesions can cause foraminal stenosis. Again, just a small animation how it happens. If you see, the superior gliding of the ascending facet will pinch the exiting nerve. So if now it is a part of the pathology, and if we are dealing with the endoscope, then we have to drill that part and free the exiting nerve root. Many a time you will see these lesions in degenerative scoliosis in the elderly, where the concave side, the foramen is, the facet is pinching right up to the upper pedicle. So if you choose to treat such patients because of comorbidities, if you are not correcting scoliosis or doing any big reconstructive spine surgery, this can work handy. So foraminoplasty is the technique of widening the foramen to create more space for the neural elements inside the region. So if you see these two pictures, this is the tip of the ascending facet which has been cleared, and now this part has, this is a post-op CT scan where we have reconstructed. So this particular step can be used for multiple indications, like if you are doing a thoracic, lower thoracic herniations, you can drill the facet to have a safe access into the foramen. Earlier we used to do these foraminoplasties with these mechanical shavers, but now with the advent of the drilling system, which is very nice, we usually employ this. So this is a small video how we drill the undersurface of the facet to widen the foramen to address the foraminal stenosis. So this is a mixture, this patient is a mixture of foraminal stenosis with a disc herniation which was in the paracentral region. So here we are widening the undersurface of the, drilling the undersurface of the facet, the ascending facet. So just a few seconds the pictures will become clear. So you can see the medial edge of the ligamentum flavum which is infolding along the facet. So now the drilled bony surface, this is on the right side, the about 3 o'clock side is the pedicle. So this was drilling right up to the pedicle junction, the undersurface of the facet. So as we reach the medial edge, then we are able to reach the spinal canal, and then we can remove any fragment lying there. So this is how we drill the undersurface of the facet. So now you can see there is a nice wide space available, and we can reach right up to the, so this we can apply to remove the down migrated fragments as well. Now coming to extraforaminal stenosis, it's a rather uncommon diagnosis. Many a times it's missed. Disc herniation can be seen, but sometimes you do come across elderly people with this herniation, especially at L5-S1 level, because the transverse process is big, and if the disc degenerates, this can cause a stenosis in this region. So if you see, this is a typical case of a loss of disc height at L5-S1 with a extraforaminal stenosis on the left side. The patient presented typically with a left-sided claudicant radicular pain and significant restriction in the walking and daily activities. So before we ventured to do a decompression, we gave him a test root block, and he did very well after the root block. So that prompted us that, okay, we are at the right region to diagnose the source of pain. So again, in this case, we again employ the superior articular facet as our first landing point. Now you have to understand, because the facet was thick and lying more coronally, so we have to drill the lateral surface of the facet here rather than just walk under it. In the first case, it was a herniation. We have to just walk under it, use it as a landmark to move up. But here it is right in the trajectory and part of the problem. So we'll be drilling that facet to reach the foraminal, extraforaminal region. So what we'll do is we'll dock our cannula here, drill this part which is marked shaded green, and then go down vertically more anteriorly from posterior. So this is how the needle is positioned at the lateral edge of the superior articular facet. So cannula is positioned at the lateral edge. So we bring in our scope, clear the soft tissue, the muscle covering the lateral edge of the facet here. So once the bony surface is clearly outlined, so you can see this is orientation for you. Left side we are operating. So the posterior lateral surface of the superior articular facet is now visualized, which we start drilling to make it thin so that we can give it that tunnel view directly to the extraforaminal region where the pathology is. So you realize there was a shoulder osteophyte also in the MRI I showed. So we have to try to address that as well in this case. So as we go down, as we go anterior, we will be using a protected drill because we do not know when the exiting nerve root will be. So as we go down, now we are using the protected drill, and as we drill the anterior most surface, edge of the lateral surface of the superior articular facet, we are close to the exiting nerve root on the 11 o'clock side, which is the area where the exiting nerve root. So this is the foramen, the intertransverse membrane that we are cutting now. And as we see, you can start seeing there is a pulsatile nerve root, exiting nerve root below. So this is the perineural fat. You pick it up to clearly visualize the nerve root. So now you can see the exiting nerve root is clearly visualized. So this gives you a guide. Okay, now that you have done the posterior decompression, so this is the shoulder osteophyte arising from the S1 vertebra, which we are going to drill to remove the pressure from the exiting nerve root. Here I am using a bendable drill moving away from the exiting nerve root. The tip to use it is use it slowly and do it in parts. Don't be in a hurry because if either the bit can break or it can injure the nerve root. You can see the exiting nerve root is right in front of you, so you are drilling very close to it. So be sure, be gentle, be very clear when you are drilling. So once you have drilled, you can thin it and you can take the remaining part with a punch. So now we feel the superior edge, the inferior edge we have already drilled. So this is the width of the decompressed nerve root. So this is how one can address the extraforaminal stenosis by using the drill. So this is a post-op MRI, post-op CT showing good decompression with a good relief of the patient symptoms. So to address the problem of extraforaminal and foraminal region, just to wind up, we dock the cannula on or close to the superior articular facet, which is the ascending facet of the caudal segment. No need to introduce the cannula into the disc base, as I already said. You use a beveled working cannula because by using the flange of the bevel, you can protect the nerve root from harm's way when you are working close to it, and start the decompression from a caudal to a cranial side to avoid inadvertent damage of the exiting nerve root. That will be all. Thank you.
Any questions? We'll take a couple of questions and then we will go to the theatre. So what is your preferred anesthesia for this?
Earlier I used to do extraforaminal herniations under local anesthesia, but it used to be painful to the patient because the mere act of docking the cannula onto even when you are in the lower part of the disc, because that will give transmitted pressure to the exiting nerve root. So since about 2-3 years ago, I've started doing these procedures under general anesthesia now, especially with this approach, because now you're moving a much safe approach, coming to from the very inferior part of the edge of the facet. Earlier I would be docking my needle onto the disc in the lower half of the foramen, so that still left some room for neural injury.
Yeah. So only if you are experienced enough, you can do it under GA. I also do under GA nowadays because I have enough experience. But If you're not experienced, always do under local anesthesia.
Yeah, everything.
Or if you have some experience, you can do under epidural anesthesia also.
Don't need now.
Actually, the trick is that you need to recognize structures through the endoscope more efficiently. So if you are able to do that, then under GA is no problem. But if you are not that experienced that you will miss the nerve root from the disc fragment or the other structures, then it is safer to do it under local so that you have a live monitoring. Yes. Can you pass on the mic to Dr. Shrikant, please?
Shiva.
Hi, sir.
Yes.
So, my question is how to correlate a AP and lateral view, which we actually do for a posterior lateral herniations. I mean, when you are touching the medial pedicular line in AP view, and in lateral view, you are at the posterior border of the vertebral body. So, this is the way we correlate in posterior lateral discs.
Correct.
So, how, means in extraforaminal herniations, is there any way to correlate both views?
Yes. So, I believe most of the audience here is familiar with using pedicle screws, correct? Show of hands, pedicle screws, right? So, if you remember, this is the nearly similar entry point for your pedicle screw insertion, except that at that entry is slightly caudal, where the lateral edge of the facet joins the transverse process. That is the reference point, the middle of the width of the transverse process. Here, the width is not the central point; it is the superior edge. So, if you interpret that big picture in your percutaneous kyphoplasties, percutaneous pedicle screw, it is the same. That means, but still to describe it, how it is going to look on a fluoroscopic image, it is the lateral pedicular line in the AP view, and it will be the facet line in the lateral view. Got it? So it will be about a centimeter away from the posterior vertebral line, as we are used to seeing in the standard transforaminal endoscopy. Yes, so correct. So if you are dealing with a combination of a foraminal herniation with the paracentral herniation, you would want to be flatter, maybe about 60 degrees to the ground. But if it is purely foraminal, extraforaminal, a 45 degrees is good enough, no problem, because you are not trying to get inside the canal. So the only region that you have to work is the lateral surface of the facet and the exiting nerve root. So that same triangular area.
Now, as we are shifting from transforaminal to interlaminar, so what are the cases you will select for the contralateral interlaminar approach for foraminal herniation or foraminal stenosis? Anything specific?
Contralateral interlaminar approach?
First, foraminal stenosis. So, which are the cases, if you would?
So, Prasad, it is reasonably clear that only lesions which are bounded up to the middle of the foramen are safe to be addressed if you want to do it contralaterally. Beyond that, you will have to cut so much of facet that then the benefit of a minimally invasive approach will be lost. So then if something is beyond the middle of the facet, let's say pedicle, so if you define the foraminal dimensions, medial pedicular line and lateral pedicular line, so something which is mid pedicular and medial, you can still think of addressing with the
but your facet angle decides anything, means do you see the facet orientation for these?
Because we are dealing with these lesions are mostly degenerate, so rather than facet orientation, I would rather look at the CT and how the facet has metamorphosed in the years behind. So if it has become hypertrophied besides the orientation, yes, it will be possible, but usually I am not a very big fan of a contralateral approaches.
Okay.
We'll move to.
I think OT is ready. If you have questions, you can ask sir later. We will move on to OT. Thank you very much for this talk, Dr. Bond, sir. Now we move live to the OT.
Yeah, good afternoon, everybody. I'm Dr. Pramod Lokhande.
Good afternoon, sir.
Yeah, good afternoon. You can hear me well, no?
Yes.
Okay. So we have a 19-year-old male patient here having severe bilateral claudication since last 4 to 5 months, and he also has a right-sided radicular pain, going down the posterior aspect of the calf on the right side. No neurology, the SLR is 30 degrees on the right side, and there is failure of conservative treatment. And this is the MRI picture. If you see, there is a small protrusion of the disc at L5S1, and if you see the axial MRI sections, these are the axial MRI, you can see here, this is the disc level and this is the lower end plate level. So you see there is some kind of stenosis, which is very rare for a 19-year-old. There is a hypertrophied thickened ligamentum flavum. The interlaminar space looks a little less here, but let's see it on the X-ray also. And there is a bulge, there is a central bulge, slightly more on the right side, compressing the thecal sac from the front side. So our plan is interlaminar approach. Since the patient has got bilateral claudication symptoms, we'll be doing an over-the-top decompression. Along with that, we are going to try and see the disc, and if necessary, we'll remove the disc from the right side, so that we are treating both the posterior compression as well as the anterior compression. Now, since it's a stenosis, I would prefer to start with a stenosis endoscope, and once the posterior decompression is completed, probably I'll shift on using a smaller interlaminar endoscope, and then we can just insert the cannula, rotate the cannula to retract the nerve root and observe the disc, and if necessary remove it. So that's the plan. Any questions till now?
Is this fellow lifting weights, or how did he manage this stenosis at 19 years?
I didn't get you. What did
No, does he lift weights, or how did it happen?
Oh, actually, no, I don't think so. He's doesn't look athletic that way.
Okay. Very unusual case.
Yeah, very unusual case. Stenosis first of all at L5S1 is very rare, and that too in a 19-year-old.
Yes, very unusual.
Again. So we are going to start. Already I think SUKUMAR has done a wonderful job. To operate after him is going to be a big challenge for me, but let's see how it goes. So as usual, we mark the interlaminar space L5S1. Okay. I slightly try to take, shoot please, yeah. Okay. Slightly try to take it not at the center of the interlaminar space, but a little bit away from it. Take the stab, incision, 2 cuts, one for the skin and one for the deep fascia. Dilator goes inside. Now normally if you see the tube surgeons, they insert the dilators and they move it like this to elevate the muscles of the lamina, but that we don't do it in endoscopy. We try to preserve the muscles as much as possible. Okay. So you try to feel the bone, see where it is there. Okay. Shoot please. Just a minute. Shoot. Okay.
Can you shoot?
Yeah.
Oh, okay.
Yeah. So it doesn't matter if it is low, below, because the scope is going to be mobile. So later on we'll be able to shift the endoscope up and down. Okay. Take a lateral view for this. Be careful of this. Thoda sa dekho. Now for the beginners, I would like to tell that and sometimes you have a large interlaminar space and the patient may be very thin, young patient. So the ligamentum flavum is also very thin. So in that case, if you are not sure, either you direct the dilator towards either side of the bone, the closest lamina or the lateral medial part of the facet, or you advance the dilator in the lateral C-arm view under direct vision, so that you don't puncture through the flavum and injure the dural sac. Shoot please. So we are still up. Okay. Shoot. Okay. So we are slightly lower, but it's manageable. I can feel the superior lamina here. Shoot. Okay. Yeah. So now this is the working channel, the tip side, the bevel side. This adapter is attached in such a way that it denotes or shows which side is the opening side, and we keep the tip side towards the facet joint, towards the lateral side, and the opening towards the midline or the medial side. Shoot, please. Okay. So this completes the docking of the working channel. Can you take an AP view? No, AP. You can either take the view or you can directly start. Either way is good for me. Any questions till now? Just hold it. Any questions from the audience?
So far, no.
Okay. Shoot. Okay. Yeah. Okay. Take out the Siam. Table is down. ले लो पीछे ले लो. Get the table height down. Yeah? Maximum down. Okay. Little bit too high for me. Okay. Bipolar. Correct. Okay. Where's the cautery? So I'm using the stenosis probe, the elephant probe. Okay. This is faster, takes less time, and probably I feel it is more sturdy as compared to the trigger flex. Okay, forceps. Can you see the blood vessels? Try to coagulate them before you can, Otherwise the bleeding starts and the whole field becomes a little messy. Bipolar, yeah. Okay, forceps. Sometimes the cannula gets lifted off, and that tells you that you have to remove a lot of muscle. So this is what has happened now. So you have to give a gentle downward pressure to the working channel. You see my little finger is pressing down. Can you see this?
Yes.
Yeah. So be aware of these things also. That's the flavum. And this is the facet. Okay. Bipolar, please. Okay, forceps. So the thing is, you can either retract this muscle or you can remove it, doesn't matter. Retraction will keep the muscle bringing, the muscle will keep coming in the field. So sometimes a little bit of more muscle, if you can remove, doesn't matter. It just makes your life more easy. So this is the superior lamina which I see here. This is the spinolaminar junction. Okay, bipolar please. So that's the lamina here. Okay. This is towards the midline. That's the spinous process. And this is the inferior lamina. Can you see? This is the inferior lamina. Forceps, please. Can you hear me?
Yes.
Is the audio?
Yes, yes.
Am I audible?
Hello, we can hear you, sir.
They can hear me?
Yeah, yeah.
Okay.
Small announcement. In between, we have lunch till 2:30 to 45. We request small groups can finish lunch and then join back in the session. Surgery will be continued.
So this is the safety zone. Now Sukumar has taught you one technique. I'll be trying to teach you something else. Both of us do either of the techniques, so it doesn't matter. But I'll tell you what are the safety points for a beginner surgeon. Give me an annular cutter please. Cutter please. Is it possible for me to stand on something because it's too high? थोड़ा ऊंचा हो गया है मेरे लिए.
They have big platforms.
Yeah. Yeah. Okay, wait. Give me a carry some punch. Yeah. I'm just trying to delineate the anatomy.
You will expose the tip of the facet.
So this is just another way. So my job is to let the audience know the different ways so that they can choose which is right for them.
Yes.
This is more easy for a beginner,
Yeah.
Yeah. Okay. Be careful, otherwise the wire will break. Yeah. So this is how the position has to be. Your iliac crest should be at the level of the back of the patient. Otherwise, you will injure your shoulder.
Yes,
Okay.
you will end up with the rotator cuff problems.
So this is the pars area. This is the superior lamina. Can you see this?
Yes.
And this is the attachment of the flavum to the superior lamina. Okay. Yeah. Give me a Carrison point. This is the upcutter. Sorry, I don't know the names. Okay. I call the forceps as the forceps and this as the Carrison. Doesn't matter.
Here you try to.
So I'm just detaching the phlegm attachment from the medial margin of the facet joint. Okay.
Yeah. Okay.
So it becomes easy for us to drill, and the whole job becomes very easy. Forceps. Can you appreciate now?
Yes. Are we seeing the root down there?
No, that's not the root. That's the SAP. This is the SAP.
Okay. Okay.
Okay.
Because,
Now
yeah,
this is the attachment of the phlegm to the
yes,
SAP.
yes,
Okay.
Okay.
Now this is the area which you have to be aware of. Now I'll again orientate you with the anatomy. This is the facet joint. This is the medial margin of the facet. You trace it, this becomes the pars. You trace it, this becomes the superior lamina.
Yes.
This is the attachment of the phlegm. If you come down, this is the tip of the descending facet.
Yes.
On. I'll just show you again so that. Forceps, please. Can you see now?
Yes.
Okay, the tip of the descending facet. Can you see now?
Yes.
Okay. So this is the safety net. All the newcomers, please try to understand, this is the area where you should start, this is the area where you should start drilling, because your drill is not going to enter the spinal canal here. This is the base of the SAP which is going to protect your drilling. Okay. So give me a drill. Any questions? Yeah. Forceps, please. Forceps. Side protection. Yeah. I need the drill foot pad on my stand. Okay. This part. This is the foot pad, no? Yeah. Okay. So I'm using a side protection drill as compared to what Sukumar used. He used a round diamond drill. The advantage of this is fast, but the disadvantage is it will cause some amount of bleeding. So let's see how it works. Okay. Recording is not there. Now another important thing you have to remember is when you're drilling, always zoom in. Don't drill like this. Okay. You have to drill and you have to see the tip of the drill, where the tip of the drill lies. The tip of the drill should always be under constant vision. If you don't see the tip of the drill, it is okay in the lumbar spine maybe, but definitely not in the cervical spine. Forceps, please. Any questions? Now another thing you have to look for, how much to drill superiorly. No, drill. You can drill in two ways, either like what Sukumar did, you can drill till you expose the attachment of the ligamentum flavum and you detach from the superior lamina, or you can drill till the tip of the SAP is visible. Tip of the superior articular process is visible. Okay. Okay. Forceps, please. Any questions?
See, I don't talk much, but
how do you avoid damaging the capsule here?
we are too, medial. You see how much amount of blood. My tip of the cannula is always till it is not retracting much. I'm just retracting the soft tissues.
Okay.
So little bit of capsule damage is bound to happen because you're cutting the facet. But the main part, which is the middle and the lateral part, is kept intact.
Okay.
Yeah. There you see the bleeding has started from the cancellous bone.
Yeah.
So this is the disadvantage of this serrated burrs. But sometimes I think it is faster. Okay. Bipolar please. Okay. So as far as possible, try to coagulate with the bipolar. See it works for you or not. Okay, dura dissector please. So this is the drilled part of the superior lamina.
Many times this point of time when you are at the lower discal margin where probably there is a hard disc below,
yeah,
and you are already on the nerve probably at the moment. So how
On
to
the
avoid
nerve.
any injury because of the base plate of the kerosene? Means with the kerosene you are not pushing the nerve. How do you make sure?
We are at the superior level. We are not at the nerve root level. So we are at the center of the dural sac. So right now you mean to say, no?
Yeah, yeah.
So right now we are not.
Because
see,
now
if
we are
you-
removing IAP, part of IAP, and then we are trying
No,
to
this is
expose
the superior lamina which I just cut.
Yeah.
Okay, drill please.
Okay.
The IAP is already drilled. Now this is the SAP, what you see here.
Yeah, this is SAP.
Okay.
Yeah.
So what you are saying is that injury to the nerve root, that
Yeah.
may happen when you are drilling the SAP.
Yeah, drilling the SAP. So this you are drilling now lamina. and
Lamina,
this is
yeah.
the junction. This you are coming down towards IAP SAP junction.
Yeah. I'm coming down towards the SAP.
Yeah.
Dura dissector please. So aim is to try to identify the tip of the SAP.
SAP.
Now this you have to trace, and you see that it's now turning around to form the tip.
Yeah.
So it's, so probably if you remove this part, we'll get to see the tip of the SAP.
SAP, yeah.
Any questions? Anybody does it in a different way? I think Mahesha, you may, or Arun, even Prasad.
No, the same way. Only thing is, my intention is usually to go to the shoulder of the nerve root. So usually burring till the till I detach the flavum from the lamina, yeah, cranial border.
So this is the cranial part which I am
Yeah,
trying to do.
yes, yes.
This one, okay.
Yeah.
So this is the cranial part.
Yeah.
You can see now the flavum has become a lot thinner.
Yeah.
Dura dissector, please. Carrison. Dura dissector. Drill. Bipolar, please. Bipolar, yeah, RF. Okay, Dura dissector.
Pramod, you use the hooded burr only always, or you have any preference for the burr?
See, I started with this, and one of the thing is that I got used to it because I didn't have any other burr.
Yeah, this was what I was earlier.
So initially when I started because that was the one which was recommended by Revo. So I started with that, and now I've got so used to it that I feel one of the advantage of using this oval burr is, you see that it drills the full thickness lamina. And another thing is that you can do a side to side movement with that, like a pendulum. Whereas with a round burr, many times you have to do an up and down movement. Can you appreciate that?
But still I feel that the round burr also cuts from the side only, it's not from the tip.
Yeah, I agree, but the movement is many times vertical.
Yeah.
So that vertical movements can be a little dangerous for, for the patient.
You do it layer wise only, you go deep and then come superficial, that's how. And you use a cutting burr also, is that also a preference?
Yeah, cutting burr is more faster and more long lasting.
Yes.
My only concern here is because the tip is actually not visible here.
Yeah, open burr gives you a very good vision.
That is not hooded also.
Can you see? This tip is visible.
No, the tip, absolute tip, which is this is
the visibility is better always with that round open.
Ajay, visibility is usually a matter of how you place the scope. I think most of us who use this burr can visualize this all the time. It just depends because you are doing it a little faster, so that's why feeling the bone he is drilling. Otherwise, both the burrs can be seen very nicely all along through the drilling process.
Okay.
I use both the burrs, but I also find that the round burr, the cutting burr, you have to start from superficial. First you drill a part of superficial bone, then you go deeper. So you have to keep drilling multiple times the same area, whereas the oval burr is sometimes able to give you the
Single
full
time.
thickness, yeah.
Full thickness
Okay.
drilling
Full
of the
thickness.
lamina in one go.
Carry
Okay.
some, please.
Usually I start with the round bar to just clear the edge of the lamina and then go on to this oval bar.
Just to reorient again,
Can you see?
at the
Yes,
3
yes.
o'clock
This is the
position is the
opening.
superior.
So this is the base of the spinous process. Superiorly he is drilled and now getting into the other canal.
Bipolar, this thing, single one. Yeah. Okay. Yeah. Forceps. Curate.
You can appreciate the kind of visualization and such proximity at which you are working. You can take the scope as close to the area to be operated, which is usually not possible with the other techniques.
Okay. Now this is the area which needs to be decompressed, okay?
Yeah.
That's the area which is always the problem, especially in a stenosis case. So there are two options. Either you can drill out this lamina part, but since we have a bigger kerison, we don't need to. You just cut it with a larger. This is like a 5 mm kerison, isn't it? Is a 5 mm kerison? Money? Yeah. Gaurav? Yeah. So it's pretty strong. Can you see the nerve root there?
Yeah. So this is where I was telling you
Yeah.
that if you are directly on the nerve and then your base plate of the kerison will be compressing the nerve. So
Yeah,
is it so that you start
see, it's
from
not compressing. Can you see this? It's not
means
compressing.
if the herniation is big, suppose
Yeah,
at
that
this-
is possible. Then in that case, you start from here.
shoulder. Yes,
This
yes.
part.
That
yeah.
is what. So now we can see the lateral border also. Then. Yeah, cranial end of the S1.
Forceps, please. Now, normally I try to save this phlegm, but since I am trying to show you another technique which you can incorporate, this is slightly more easy as compared to what Sukumar showed in the case before.
Yeah.
So that is why I am trying to remove the phlegm on this side.
Yeah.
We'll drill this part because there is a projection, no? So you see that projection at the midline of
Yes,
the
yes.
inferior eye. You need to drill that. Otherwise, you cannot reach the nerve root on the opposite side.
Opposite side. Yes.
Okay. My leg is slipping, huh? Carry some, please. Dura dissector. So this is the opposite flavum there.
Yeah.
Just try to peel it off as much as possible.
Yes, sir.
Give me the curate, please. See, there is a lot of resistance going on in here. What is it? Something is stuck or the size is mismatched? Aasel ka? But probably I think the
Curate must have got bent probably.
I don't know what is happening. It's getting, the shaft is getting stuck up.
It must have got bent, I think.
Yeah, probably it has got bent, I think. You're right. Forceps.
Now the opposite cranial end is remaining.
Yeah. Okay, curate please. Yeah. Ah, this is going so easily. Huh? What? Straight. Okay. I mean the tip was bent.
Yeah, so that's why you finally.
Ah. Forceps please. Curate. Forceps please. Okay, curate please. Forceps. So I am using the same technique of thinning out the flavum on the opposite side also, so that becomes easier for us to curate please. Can you see that's the opposite facet?
Yeah. So that is the inferior articular process on the opposite side. Yeah.
Give me your dura dissector, please. Can you see it's all stuck up here?
Yes.
There are a lot of adhesions. You have to be very careful. So usually I think the best way is to go at the periphery and start dissecting from there.
Yeah.
So even if you have that midline stuck up, doesn't matter.
Leave it like that.
Forceps. Yeah. Okay. Bipolar. Okay. No, curate. Dura dissector. Any questions from the audience? I think the audience has got pretty bored.
50% has gone for lunch. They are joining back.
Ah, okay. Lunch time. Okay, okay. So good thing. Then nobody is trying to find out faults in my surgery.
So most of the time you want to get the flavum en bloc?
Usually I don't know whether it's an obsession or what, but yeah.
Because everybody is very much eager to see the thecal sac.
Bipolar, please.
Now how do we make sure there is no adhesions here?
We try to break it with this, no, the curate and all.
Curate.
Yeah. If you feel that there is some doubt, no, better stop and remove it piecemeal.
Piecemeal.
Wait, okay. See how I remove the adhesions.
The 90-degree hook,
Yeah, that
isn't
also is-
isn't it that helpful?
What?
90-degree hook.
I didn't.
90-degree hook.
Hook.
Yeah.
Hook is a little bit sharper instrument, no? So I am worried about it penetrating the dural sac. We need blunt instruments here.
So after the posterior access, you are planning to switch to a thinner scope.
Yeah. We'll observe what is the status. Forceps, please. Because we don't have CTs of this, no? Sometimes that round part which we are seeing, that may be calcified.
It is likely calcified.
Likely to be, yes.
Yeah.
It is likely calcified.
So if it is calcified and if it is round, not a pointed hump, there is no point in removing that. Bipolar. Wait. Okay, on.
So to go ventral, every time you change the scope, or you
No.
use that cannulated now?
Actually, many times I keep the scope up. I don't go inside, and just my instrument goes inside.
Okay.
Curate, please.
Don't you use that cannulated root retractor?
No, I don't have it.
Okay.
What is it?
There is a cannulated root retractor through which you can place any of your 4 mm instruments.
Ah, okay.
That
There is a new
makes your
thing.
life very easy, basically.
No, I don't have it. नहीं हो जाएगा इसमें. थोड़ा एडिशंस की वजह से मैं धीरे धीरे कर रहा हूँ. फोर्सेप्स. हाँ. Am I on time or I am late? I am doing it very
You're going
slow.
perfect. No worries.
No worries, no? Because we have 2 more surgeries to complete now.
There is no end time, man.
Bipolar, please. Yeah, on. Wait, huh?
You are only pressing the foot switch of RF or somebody
No,
else?
Gaurav is pressing.
Wonderful
Gaurav
coordination.
is assisting me. He's like
So-
my
so
Krishna.
it is a
you know.
wonderful coordination.
I am the Arjun, he is my Krishna. Give me a forceps, smaller one, 3 millimeter.
Just to tickle a discussion, the amount of fat we noticed
Yeah.
in this approach, that itself doesn't say that there is not much of a stenosis posteriorly, but it is more ventral.
I cannot hear you properly.
The fat which we noticed in this
Yeah.
axis now, that
Yeah.
itself says that there should not be excessive stenosis posteriorly, but it is more ventral. Isn't it?
I don't think these findings are very consistent to
It's
say.
not consistent,
Yeah,
but definitely it gives an insight as to.
Yeah, but if you look at the MRI picture, the anterior compression is not significant. There is a small bulge.
But that is indenting there and probably
Yeah, but
hanging
just
there.
check.
Yeah.
That I don't feel it is very compressing. Carry some, please. Small forceps. Something happened. Did you hurt yourself, sister? No, na? The drill foot switch fell down. So okay, you can keep it down because if necessary we'll use it.
This is being operated under gravitational irrigation, or you have the irrigator there? Pressure irrigator.
I didn't hear him.
The irrigator is there, or it's gravitational?
I think we have a fluid pump.
Okay.
But how much is the pressure? Money? Fluid pressure? No, mmHg. .45 is the pressure, bipolar. So 45 is reasonably less.
Just to ask, why are you playing around with the fat rather than removing
Because
the flavum which is visible and can be removed?
Yeah, because I want to create a plane between the dura and the, because sometimes you try to pull the flavum and the dura gets torn.
Yeah.
Okay, carry some. You have to move it sideways like this, so that you are sure that you have not caught any dural structure or anything like that. Bipolar, please.
Sukumar's vessel has come.
Yeah. He tries to coagulate it before. I am impatient guy, so I try to do it afterwards. Wait a minute, wait. That's the lateral border of the nerve root. Okay. Carrison, please. Can we get a smaller one? Tube sheath. Can you see the facet there?
Yeah, we can.
Yeah? Yeah.
So do you keep the C-arm in lateral during this procedure or you keep it?
No, I just eyeball it because we know by the curvature of the pedicle. You see the curvature of the pedicle sometimes tells you where it is dipping.
Yeah.
I try to avoid too much of C-arm because see the problem is with MIS there is so much of radiation.
Yeah.
So dura dissector please.
So that is the joint we can see on the other side.
Hmm?
Other side we can see the joint.
Yeah, that's the
That is
joint,
that,
no?
yeah.
Can you appreciate this is the joint?
Yeah.
Huh?
Yeah.
Carrison, please.
Is it because our entry was bit caudal, we are getting some problem accessing the inferior other?
No, I don't think so.
No?
I don't think so that is the issue. The phlegm is too hypertrophied, so I'm just trying to dissect out. I don't want a tear because give me a bigger one. See, if you rotate it, you see I get good access to.
Yeah, and this is 25 degree. No?
So that is not my worry. Just trying to be very safe because I don't want Sukumar not calling me again next time, you know. Give me a Carrison, please.
Once this base of spinous process is clear, it becomes easier to see the other side.
There were too many adhesions there, so I was dura dissector. Tube sheath. Forceps. Okay, dura dissector. Okay, Carrison. Forceps, please. No.
That's the opposite axilla is
Yeah.
seeing. So you can see the fat there. So that's opposite axilla and the opposite root inferiorly. So just to remove this little bit of ligament, so inferior work is done.
Give me a curate, please.
Pramod, how would you decide that this is the distal extent of the decompression?
You see the pedicle on the opposite
So
side.
you see just the upper edge of the pedicle, or do you go a little below that also?
You go at the inferior margin of the pedicle.
Up to inferior margin of
Yeah,
pedicle. So where the root is leaving the pedicle.
Yeah.
So that means that some more work requires here in this region.
Yeah. Give me a drill, please.
So that is the region of the lateral
Side
recess,
protection.
as Pramod said. Anything that is lying anterior to the undersurface of the facet, right up to the inferior edge of the pedicle.
Can you push this a little bit in front? Thoda आगे रखना. Yeah. Forceps, please.
So any doubts here in between, you can ask the doubts so that master will explain or try to explain. So commonly people, the difficulties here are the bleeding. Whenever you have a bleeding from the bone, so the field become very disturbed, so you get fatigued coagulating those things. So you need to learn to stop the bleeder before it starts bleeding. So small bleeder is there, you coagulate, so that
Drill, please.
don't open up the too many avenues for bleeding, so that it becomes difficult.
Anytime you get headache post-op, patients complaining of headache.
Yeah, this question is always asked. So this depends upon which system we are using. So there are systems which I was showing in the morning. This system has the oval sheath. Oval
Wait a minute. Okay. On, intermittent. Okay. Now one of the techniques that if your discectomy is not planned and you just get a surprise kind of disc, yeah, now you have to go ahead and not just decompress the stenosis, but you have to remove the disc also. Then in that case, what you can do is keep the scope up like this, and you just insert the instrument. I'll just demonstrate. I will not do it, but that is one of the ways of dealing with it.
Is it soft? The hump is soft or?
Yeah, looks like. See.
Yeah.
Can you see this?
Yes. So maybe you can just use a cutter and pops out.
Yeah. Intermittent, huh? Okay, wait. On, okay. Wait. So there is one more way. So what you can do, give me a Dura dissector. If you don't have an interlaminar scope, you can just go in and puncture like this. See how I do it. Okay, give me a small cutter, smallest one, 2.5. So with the instrument, you can just retract. And my sharp edge is towards the lateral side. Can you see that?
Yeah.
Okay. Forceps. So we are not putting the cannula inside. Can you see? You're just putting the instrument, retracting little bit, and then coming out.
The other systems, the smaller, the shorter scopes have the retractor, the root retractor, where it's a hollow retractor. You can pass one more instrument through the hollow retractor and remove it. So, but here in this scope it is difficult because the length is long. The length it's 180 centimeter.
Yeah.
The all other scopes are 120 to 130 centimeter, 13 centimeter.
So since this is a central disc, I think we'll go inside and try to use the smaller one. So we'll change the scope now. Is it okay?
Yeah.
Yeah, the decompression is fine, na?
Yes, the wonderful decompression. Yeah. So
I'll remove this scope.
Yeah. So maybe we will be running this and parallelly Mahesh can
so
start.
It's not much of a job now. It's just like 15-20 minutes.
Yeah. So Madhu, you can start the
dilator. No, smaller one, small interlaminar. So see what I do, I just put it like this, remove this one.
This always happens with me also. It falls off. White balance you don't need, na?
Yeah, Rajendra, go ahead. Can go ahead, Rajendra. Madhu, you can switch to OT1. Dr. Mahesha is doing.
White balance, money.
Good afternoon.
Yeah, go ahead.
Yeah, okay.
Good afternoon. We have third case for today in OT1. It's a 64-year-old female homemaker by occupation. She presented with low back pain since 2 years, radiating
Flow
to
बढ़ाओ थोड़ा सा.
right lower limb. Pain increased from last 2 months, and pain increases on walking and standing, affecting her daily activities. She's a known case of hypertension and medication. On examination, right SLR is 40 degrees, left SLR is free, and her VASCO for back pain is 6, and VASCO for lower limb is 9. And she has right L5 radiculopathy with no motor deficits and sensory impairment over right L5 dermatome. Over to Dr. Mahesha, sir.
Good afternoon, Mahesha. Can we switch the video to Theatre 1? Theatre 1. Naresh, Theatre 1.
Hello.
Hello.
Dr. Sukumar, just wait for a few minutes. We are just arranging the mic.
Yeah.
So, Bhupesh, what is the plan here?
Yeah. Sir, I'm just first showing the MRI images.
Ask the person to focus on the MRI and give us the connection of the OT1.
Okay. Change the connection from OT1, OT2 to OT1. Just change.
One screen, that one screen. Vacant. Yeah. Can you focus on the MRI?
Yeah. Now.
And remove that X-ray image. Yeah. Ask the camera person to come parallel.
Just come here.
Yeah. Bhupesh, you can put the sagittal images lateral to the axial images. The light is not adequate.
Okay.
You can put this side, yeah. Yeah. Ask them to switch on the lights, the OT X-ray lights. X-ray light on kar de.
Okay. Now.
Yeah. Focus on the parasagittal images there. Yeah. Yes.
This one. This thing.
Yes, Bhupesh, you can go ahead.
See, the lady has right leg pain, and you just see on the MRI that on right parasagittal images, there is a down migrated fragment on right foramen, or paracentral area, and there is a foraminal stenosis with SAP hypertrophy. You can see the lateral recess and foraminal area.
Can you zoom in there? Ask him to zoom into the.
Zoom in this image.
Yeah.
These two images.
Yes. Perfect.
You can see the SAP is hypertrophy and the soft tissue over the SAP and in the lateral recess.
Yeah.
So that combine foraminal and lateral recess stenosis. Again, along with the down migrated fragment, a bit down migrated here.
So here what we need to see is how lateral the foraminal stenosis is. So is the medial foramen, mid foramen or outer foramen. So and how much we need to drill. In sagittal we need to see the how much we need to drill the superior articular facet, whether it's from the pedicle or only the tip. Now in actual images.
You see the facet hypertrophy here on the right side.
Mahesh, can be little bit louder.
Yeah. You can see the facetal hypertrophy on the right side. You compare with the left side.
Yes.
So you can see that SAP is prominent.
Yeah.
So we need to drill that.
Okay.
And if you see here, it's completely occluded. So again, the facet is hypertrophic, and if you see the last cut, that is at the lower end plate level, you can see that small disc fragment which is down migrated.
Yeah.
And if you see the whole annulus, it is very thick. So it is probably a calcified annulus.
Yes, yes. So what is the plan, Mahesh, here?
The plan is to land in the foramen.
Hello.
Yeah. इसका volume बढ़ाओ ना mic का.
Just my mic is not on.
So yeah, now we can hear you.
Yeah. The plan is to land in the foramen, land on the disc.
Okay.
Then we will drill the SAP.
So you want to enter inside the disc or on the disc?
I will not enter the disc in the initial stage.
Okay.
Because once you enter the disc, you don't get anchorage for your cannula to drill posteriorly.
Yeah.
So that's why we will land on the disc and do the drilling.
Okay.
Because here we need to do a lot of drilling.
Okay.
And it will be little difficult to decompress the root and also to remove the phlegm once you enter the disc.
Okay, and you have any specific modifications to the angle you want to land it on the inferior end plate, or is there any idea, or you just
no, this patient is very bulky. So I have done the marking, so probably I will take a 16 centimeter entry point and see how the needle lands.
Okay.
And if required, I can change 1 centimeter medially or laterally depending on what we get.
Okay, okay.
So patient is under epidural.
Epidural.
I have just marked the levels. Can you show the IIP? You are seeing the pictures?
PIP, just showing the PIP. Siam image.
Dusra glove. Can you see the?
Can you see the Siam image? Hello.
Yeah.
Yeah, now we can.
Yeah, now you can. Huh? Okay.
Okay.
So Dr. Mahesha has already marked the landmark here on the back. So we just can you just focus?
Can you?
Back?
Are you seeing the Siam picture?
Yes, we can see AP and lateral.
Yeah, we have taken AP and lateral. There is not much of lordosis. So two lines are almost meeting because you have not taken a true AP view. So I'll take the entry in the lateral line.
Okay. So are these images corroborating to each other, because we can see the needle has gone quite anterior in lateral and it is in. Huh?
Yeah.
What is this? Achha, this
Do
is
you
marking.
need to give
Okay. I thought the needle it is.
So this is a 16 centimeter entry point. Let us see, we may change it. I am not fixed on this.
Again, he has given local because this patient is under epidural analgesia.
Sure. So as I said, if there is not much of lordosis, so we need to go almost horizontal here. There is not too much of craniocaudal inclination. Okay, we check the lateral now.
Okay. This is the AP.
So still I am going more caudal, so I just change the angle. Sure. So I am hitting the facet. Can you see that in the lateral view it is hitting the facet? We'll check under AP view. And if you see the direction of the needle, it is towards the lower end plate. So that we avoid the exiting route.
Yeah.
So now you see I am just increasing my, show the angle so that I pass the SAP, show. This needle.
So on AP and lateral you have confirmed that you are touching the SAP.
Yes.
And now you are
And
sliding.
I think there is lot of facetal hypertrophy.
Yeah.
It is not going smoothly like normally we do.
Yeah. Do you ever do outside in
Sure.
technique for this?
Generally I do not do. So I have just entered. Can you see I am
Yeah.
near the medial pedicle line?
Yeah.
We will check again in lateral view.
Yeah.
Maybe the disc is very firm or calcified. That was.
So we are in the proper place, AP. Can you see I have just touched the posterior border of the disc. This is okay for me.
Yeah.
This is where we will start drilling.
Drilling, yeah.
And we are not going to enter the disc first. My point against outside in is it causes lot of bleeding. You have to use image, and sometimes you may end up doing more than what is required. Knife. So entry point seems to be okay.
Yeah.
So
So what is your policy here now? You start drilling at the base of SAP,
Yes.
go till the apex?
yeah.
Okay.
Because there is a small fragment which is caudal.
Okay.
So we will see if we can see it before entering the disc. Sure.
Okay.
So can we take a lateral? Lateral. So initially we make a very small stab incision.
Yeah.
So when we put the dilator, we extend the incision. So you can extend it either medially or laterally, depending on how you want to position it. So this looks okay.
Yeah.
So now we will put the cannula. So here the issue is because we are in the foramen, it will be freely floating cannula.
Yeah.
Sure. Okay, AP. So we just need to go in a little bit. Hammer. Sure. Okay, that looks all right. See amount. So can you get the scope? Yeah. So any questions? So we are in the foramen. So white balance. ठीक है. Start. Okay. Irrigation. फिक्स कर दो. ठीक है. Small grasper.
See, the challenges here a beginner will face is you're landing in a foramen and there is a stenosis already and you have a small disc fragment. So there will be lot of congestion, bleeding here. So sometimes the bleeding is so profuse that you don't know where you get lost and your cannula is floating. So because of this, you will have a lot of problem.
Foot switch. Can you give the foot switch?
So you need to learn how to control bleeding.
So this is not a easy case. Fresh.
That's why Mahesh, it is given to you.
So I thought you have given me a simple case, and I never bothered to check what case it is also. So we need to see the facet pedicle junction first.
Yeah.
And also the disc. Stop. Give me grasper. So there will be some soft tissues here.
Yeah.
Clean. RF. Can you press? थोड़ा पावर बढ़ा दो.
रिकॉर्डिंग ऑन
Yeah.
Stop. RF.
So for sake of beginners, can you orient the 3 o'clock, 6 o'clock structures?
Press. Yeah, I will orient in a minute.
Yeah.
I just want to make clear of this anatomy. This seems to be the disc.
Yeah.
So because the cannula is freely floating,
yeah,
you have to control the cannula all the time.
Yes.
Can you make out the disc here?
Yes.
Okay.
At 6 o'clock.
Yeah. The tip of the probe is on the disc.
Yes.
And this is the pedicle here at 9 o'clock.
Yes.
That is caudal, and 3 o'clock is cranial, and 12 o'clock is posterior.
Okay.
Is the anatomy clear?
Yes.
And if you see here, you see the bony projection.
Yeah.
It is hypertrophic facet which is blocking us. So foramen there will be a lot of bleeders, so we need to control before we do anything.
So what drill you are using, Mahesha, today?
Today we are using something from Revo.
Okay. So in your practice, what drill you use normally?
No, normally I use striker attachment burrs. So
okay.
Stop.
So Mahesh has devised some burrs where which you can fix it to the some motors where you can use it. So the idea is here he is not coming from the tip of SAP to the base. He is going from the base of SAP to the tip. So he is going the other way around because we need to open up the lateral recess more here.
And also other thing is this area is safer because directly we cannot go to the tip of SAP because here it is a dense stenosis.
Yes.
We don't know where the root is. Press. Press. Stop.
So it means you are doing this as a visualized outside in.
Yes. We do everything under vision. RF.
Because in outside in technique also, usually we place our first burst, we start from this point only.
Yes.
Mid-pedicular
technique
line.
is the same, but we do it in a different
it is visualized
way, that's all. Stop. Give me a dissector. I'm just seeing if I can see the root here. This probably is the root here. RF again. Press. There is a small bony bleeder. Probably I will have to use the burr. So give me the burr. A hand controller.
Here,
Foot.
we want to see the
Okay.
X-ray shoot. If you can. place
Okay,
a
we will
probe.
show in a moment. Can you show? Take a image.
Is it better to use a diamond burr here, or you want to?
We can use a diamond burr.
Yeah.
That is better actually.
Yeah, better.
Give me a diamond burr. No problem.
Bone bleeding there.
Yeah,
and
because there
this
is a bony
very
bleeder.
Very sharp
Correct.
burr. Can you make the X-ray image bigger for a while?
Yeah.
Just to show the X-ray image bigger. Yeah.
Okay. Can you take a picture?
Yeah. Yeah.
Okay. So that is a facet pedicle junction.
You can make the endoscopic image bigger.
Diamond, it will be little slow, but it is better.
Yeah, bone bleeding is better.
Yeah.
If you think near the root, it is better.
No, the bleeding will be much less.
Yes.
Otherwise, you would have been having more bleeding here.
See how he is putting pressure on the bone rather than the soft tissue here. So this is around 10,000 RPM, the diamond burr, what the Revo spine system is using.
So there is lot of facetal hypertrophy here.
Yeah.
So if I go to the disc, I will not get this leverage.
Yeah.
My cannula is sitting on the disc now, and I get the leverage to drill posteriorly, grasper. Otherwise, you will have to use this articulating burr.
Image, Mahesh, you can just increase the size of the endoscopic image on your camera head, so that
Burr.
can make it little bit bigger.
Burr again. Yeah. 1 second. Yeah.
Yeah.
Is it okay?
Yeah.
Okay. So Dr. Rajendra Reddy is here with me.
Okay.
So he is assisting me.
He has replaced Dr. Gaurav Chamble now.
Yeah.
So now he is drilling towards the pedicle. So that's the idea. You just flush to the pedicle. You can do some pediculotomy also. So you
Can
just,
we take an image? Sure.
Yeah, they can show the image here.
Can you see I am going medial? Still, I am not.
Can you make the X-ray image little bit bigger? Yeah. So you almost cross the mid.
In the middle of the pedicle.
Yes.
I mean, so.
You are flush to the pedicle here.
Yeah.
I think that's a wonderful thing you are doing. So you can make the endoscopic image bigger.
1 second.
So what is trying to create the vision here, because the exiting route
grasper.
is very close, so you should be very careful. So
grasper. Because patient is under epidural, sometimes you do not dissect her. Patient may not give you the feedback.
Yeah.
So that's why you have to be careful. And if you see the MRI, it is all glued in, so the demarcation is not that well made. Grasper.
Can we use a smaller grasper here so that it can go inside easily?
Use the smaller one, grasper.
The wolf graspers are small. You can use that wolf graspers.
Cutter दे दो. Cutter. Just RF once. Show me that. If I see the root, then the job becomes easier.
Yeah.
Till you see the, sorry, press. Yeah. This seems to be the root.
Yeah.
Okay. Press.
Yes.
You see how close it is?
Yeah.
Press. As such, the disc space is collapsed. So that's why, the root is very close by. Show. Press. Can you see the big vessel?
Yeah.
At 12 o'clock, which I am burning now.
Yes.
So before it bleeds, you take care of it. Later it becomes difficult. It will bleed like mad.
Yeah.
I hope everybody can see the root.
Yes.
And if you see, there is hardly any space there. So if you are careless, you will injure the root. Give me a cutter. So you can see the SAP impinging on the root.
Yes, we can see in the center.
So the root is very much compressed there. You don't see the movement of the root there. So burr again. So we will start drilling this SAP now. So most important is to identify the root. Once you identify the root, you are safe. You have to make this window big enough so that our cannula also can go in.
You see
Otherwise your scope will get damaged.
See the Mahesh's hands, how he is moving the drill. That is very important. So he is using, because the whole cannula is floating, he is using that floating as to his advantage. So he is moving the drill and drilling the entire non-articular part of the SAP.
So now I can retract the root. Can you make out?
Yeah.
So it is under vision. So disc is below that.
Yes.
So you can see this is the root.
Yeah.
So just retracting it. Sure. Just checking the Siam, we are still not reached the medial pedicle line. There is so much of facet work to be done here. take. देखते हैं, थोड़ा अंदर जाते हैं. हाँ? SAP is so big. थोड़ा curate. Can you give me a curate? So can you see the disc and the root?
Yeah.
So I am just using a curate to remove the thinned out facet and the pedicle. And if you see the pre-op MRI, there is a diffuse hump of the disc.
Yeah.
Which is chronic and collagenized and almost calcific. थोड़ा cutter, angled cutter. Root is still not free, it is very much impinged. Still some more bone to be removed.
Yeah.
Grasper. The problem is the foramen has become so narrow. Burr, RF. Press RF. Press. Stop. We can make out the stimulation of the leg muscles.
Yeah.
When we are doing RF close to the root.
Can we use a tube sheath upcut kerrison here?
Yeah, we can use. Give a kerrison, let me see.
The tube sheath one. Plural. The entire thick is a ligament.
You can see some pulsations have started.
Yeah. As you said, some more bone is removed, maybe the root becomes a little bit lax.
Yeah. Otherwise, you have to use some osteotome.
Yeah.
Yeah, that is better. Alright. The root is better now.
Yeah.
Sorry, press. Stop. Give me burr. There is a small bony bleeder. I will try to clean with diamond burr. You need good control of the hand. You can see how close the root is.
Yeah.
We have to literally create a space for the cannula.
Yeah.
There is hardly any space for the cannula to go in. Everywhere there is bone. Because I am worried about too much retraction of the root also. Curate. grasper. Give me a dissector.
It's almost poking into the nerve.
Yeah, that's what, the space, it's completely occluded here. So, give me osteotome, gauge something, gauge or osteotome. No, burr, it is too close to the nerve.
Radical.
So, I will try to use a small osteotome to take it out. Otherwise, give me a curette. Tube sheath punch. Grasper. Tube sheath punch.
Maybe you can come from above, that's the tip of the SAP, so it becomes little bit easy. Because it is too tight here. And come from the, from that place.
It is too tight.
Yeah.
Because I am worried about the root.
Yes.
Because I don't want to have
Maybe
issues.
you can drill more facet and so that you can loosen it up better.
Yeah, burr again. Give me the burr. Yeah, no problem. Yeah. Siam. So we are yet to cross the medial pedicle line. Sure.
Yeah, some
dissector.
Breach there.
That is a cortical bone there.
Yeah.
So still we have to clean this part of the bone. But
yeah. So we lost the video image, yeah.
Video image, okay.
Yeah, yeah.
Cutter. Huh? This is the disc. Huh? Hey, this is the root. Give me a dissector. Cutter एक बार. Cutter, give me the cutter. Dissector.
Maybe that is not the root, Mahesh, maybe we don't know. So,
No, there is some doubt whether it is a root or not.
Yeah, always we should be careful.
But I am not sure whether it is a root or not.
Maybe that's a disc bulge which is.
But for me, I will keep it as root as far.
Yes. Always
We will
feel
feel it.
be safe.
Cutter. For me, it looks like root only. And also, when I had stimulated,
patient is moving.
The leg is moving. So, RF. Always safety is first.
Yeah.
RF, press. Press. Yeah. What happened? Stop. What happened? So that is the root definitely. This is the disc.
Yeah.
Burr again. Burr.
So today once this case is over, so we have a evening some award ceremony. We are felicitating the masters in the evening, then followed by some culturals and musical night with dinner.
Small spine grasper.
So all are invited with their families. So around 6:30 to 7 p.m. we'll start the program.
Some metal debris. Okay. Give me a small grasper again. RF. That's okay. No problem.
And tomorrow we'll have endofusion day tomorrow. We'll have 3 cases. So we'll show the different variety of case insertion. One is the Mahesha's way how he inserts the case.
Okay, give me a dilator now.
The second, how to do facetectomy, pars, facetectomy and lamina, and remove the entire facet in one block.
Can we take a Siam?
And how it should be and how case should be placed. Then third, we are introducing the transtubular expandable case by Globus. So that we are doing tomorrow. So 3 cases will be shown different varieties of how the cage insertion, the transforaminal, that is transcambian, and transfacetal. So one is complete facetectomy, one is partial facetectomy, and the expandable cage. All the cases will be shown.
So I am planning to go inside the disc now.
Yeah.
I have done the initial burring.
Yeah.
So some anatomy I have defined. Now we'll go inside and then start cutting the annulus.
Yes. Can they show the picture in picture, the hand image also?
Lateral.
Yeah.
Hammer chain.
So commonly at this place you don't take care, so you might injure the root. Sometimes if you go blindly, that's what we were discussing with Dr. Prasad. The outside in and inside out approach, the only drawback with outside in such cases, the root is very narrow and you don't do a visualized way of bone work, so you might injure the root because it's very close to the facet and you might injure sometimes. So as a beginner, be sure that you are not violating the neural structure.
So I have entered the disk space. Can you see?
Yeah. So what does this help is once he enters the disc, so he has a control on the anatomy, so he can understand the anatomy better.
Sure. Sure. So I just entered the disk space. Sure. Okay. AP.
So he is half in, half out here. Half of the sleeve is, the bevel is inside, half is outside. So a part of it is docked into the disc, that's the annulus, and half is in the epidural space.
Can you show here? Just see here, the patient is so big, my cannula is almost getting buried.
Yeah, you went 16 centimeter.
Still you see, I have not reached the midline.
Yeah.
Okay.
Yeah.
So we will see inside the disk space now.
Yeah.
The space is very narrow.
Yeah, MRI we saw the facet is too horizontal and the span of the facet is more.
So we are half in, half out now.
Yeah.
So this is the disk space. Grasper. So I will clear the tissues now.
Because he has drilled the part of facet, so it is easy to go inside and you can see the drilled part at 9 o'clock.
It's a collapsed disc.
Yeah.
You can see the annulus at 12 o'clock.
Yes.
And the facet is part of facet also you can see.
Yeah.
And
there is lot of lateral recess stenosis.
Yeah. And this is still lot of facet is there. Cutter. Dissector. Can you see the root here probably?
Yeah.
Grasper. Grasper. It's a collapsed disc, okay?
Yeah.
Grasper. Curate. So I'll use a curate to feel where I am.
grasper.
Yeah, the traversing route will be quite medial because of the lateral recess ligament, which is so much hypertrophied. Here the worry is all about the exiting route.
So always when there is doubt, check C-arm and then proceed.
Yeah.
Nothing should be done blindly. Everything should be under vision. Curate again. Grasper. Cutter. I can see some pulsations at the top.
Yeah.
So let us see. RF. Can you make out?
Yes.
RF. Stop. Siam, shoot. This is the one. Okay. So, show now. I've just come out a bit.
Yeah, maybe you have to remove the 9 to 3 o'clock tissue.
Yeah.
So, the thick yellow ligament which is in the lateral recess.
Yeah, curate. You can see the pulsations.
Yes.
Here. Give me RF.
Maybe you start cutting that. You get the epidural space, then we keep on cutting it.
Stop.
Yeah.
So that is the traversing route.
Yeah.
Okay. Cutter. RF. Press. This is the hard annulus here. Press. The power button. Stop. Can you see the hard annulus? So I have to take out the whole of this tissue, and the root is somewhere here.
Yes. So you remove that yellow ligament curtain.
Yeah.
Maybe you can see the junction between the traversing and it's very thick ligament.
This is the hump which you see in MRI.
Yeah, the
annular hump. Clean. थोड़ा इधर दे. That was annulus.
Yeah.
But you have to be careful. Press.
Yes, you are right. Absolutely right. So until unless proved otherwise, everything should be considered anyhow.
Yeah. Cutter. But you see, it's all glued together. Small grasper.
Maybe you can use a straight cutter here, it works well.
Yeah, cutter. Yeah.
Straight one.
So the initial drilling has really helped. Yeah. Grasper.
So when local anesthesia patient is lying down like this, after some time with a little bit of handling of the exiting route, patient will have pain. So
कुछ नहीं है ना?
looks like there is some calcium in the disc. The
small grasper. RF. Okay, you will press. Okay, press. Stop.
This case would have been difficult for interlaminar approach. Then in the morning they were discussing if we had gone interlaminar, then we could have come from the contralateral side and drill the foramen and remove the ligament. So one concept. Going transforaminal is the other concept. So it all depends upon how we are trained, orientation. So if we are trained well enough for everything, can go transforaminal. Think transforaminal is difficult, then interlaminar contralateral approach is also one option here.
Cutter. Hold. Cutter.
Annulus calcify ho gaya. So here the annulus and everything is unified. The facet hypertrophy, the facet capsule hypertrophy, and the annulus.
Small grasper.
There is no gap there. You can see that now things started moving. So hard annulus there, which is now started moving now.
Now you can see the movement.
Yeah, so
still there is some adherent structure which we'll have to remove. And there is a small disc fragment also, small grasper. Cutter.
And again there is always a debate which technique to be learned first. So we have to learn both techniques. Dr. Bhanot was showing in the morning session, there are few cases where we need to use a transforaminal technique. Cases like this, transforaminal works better than interlaminar approach. So,
curate.
So Mahesha, can you take some CM image, how medial who are?
Yeah, 1 second. I will take, just give me a minute.
With the curate, Dr. Kannan wants to see how medial we are.
Yeah. Curate. You see, this is the pedicle.
Yeah.
Okay. Sure. You can confirm. Sure. Can you make out?
Yeah.
Okay. So
now you can see some fat, some epidural bleed there. So that's all the tissue which is adhered.
cutter.
So now we have separated the tissues from the epidural. So you can just use a cutter and remove this fibrous tissue. You can see so much fibrous tissue.
Correct. It's all glued together.
Yeah.
To cutter. Before we cut, we have to be absolutely sure. Clean. There is some oozing.
So Dr. Prasad is asking, why did you decide to give this case to Mahesha?
He wants to take out some old grudge.
So only Mahesha can do such cases.
What MRI finding which makes him decide that this is the Mahesha's case?
No, this needs lot of experience and thought process. So sometimes you get lost in the anatomy, you get lost when the structures are so difficult to delineate. So that's why we need some understanding of the foramen, variant anatomy of the foramen well. Otherwise, we might end up in definitely injuring things. So I think Mahesha is the one who started the drilling of facet, where there was lot of resistance when we started almost the same time in 2013. No one used to dare to drill the facet that time when we were getting trained. I think you remember. So then Mahesha designed that burr and started drilling. A lot of resistance that time. So slowly
Cutter.
things have changed.
I just have to, remove this tissue and see the root.
Yeah, once you remove that, some epidural structures will start be seeing. There is some rent there now. Some fat is seen.
Correct. But sometimes the the root or dura may be very close there.
Yeah.
Accurate. So that's why you have to be careful.
You can do some RF there so that the filaments goes sideways.
Yeah. Can you increase the power of RF? Cutter again. You have a cap here. Can you give that?
Whenever you find difficulty, go to the virgin area or go to the area where it's less adhered, so that it will be better. If you can do the RF edges will open up and you can see the structures beyond that.
थोड़ा fogging हो गया नहीं है ना? Huh? Just there is some fogging.
Yeah, it's
just,
all because of some bleeding.
दूसरा डालो. Okay, curate. It is like so close so far. We have still not seen the root. So most important thing is to see the root at the end of decompression. So
there's a lot of tissue there.
I think
can see something there. Yeah.
Yeah, I think that is the root there. Give me grasper, cutter. Because unless you see the root clearly, you cannot blindly cut.
Yeah.
So only after you see the neural elements, you can start cutting. Angled grasper. So this is the fragment.
Yeah.
That small fragment.
Yes.
Now you see the pulsations are much better.
Better. That's the body of L5.
Give me RF.
That's the body of L5 you are seeing now.
Yeah.
The end plate.
Press RF. So things are much better now.
You can see the fat now, so
Yeah.
that area is decompressed well. The recess has decompressed well now. Only we have to remove this, the lateral tissue.
This tissue we have to remove.
Yeah.
The root is free now. Can you see?
Yeah, inferiorly the root is free.
curate.
You cut this tissue further, it falls down.
Yeah. So it is very well decompressed. So she will have relief from sciatica.
Yes.
And this is very well free. Okay. And only this tissue I have to remove. Here also you see so much of adhesions.
Yeah.
Cutter.
It's much better now.
Yeah,
So
it
once
is
you
so much
remove this,
better,
you
you
can come to the
Yeah.
exiting route.
Yeah.
And start.
So our initial drilling was proper and it helped us. You see the pulsations so much improved.
Yeah. So anyone here in the hall would have done differently? Dr. Hussain, Dr. Praveen, your thoughts about the technique, what you would have, because you are a transforaminal surgeon, you like transforaminal surgeries. So what differently would have done here?
I personally start a lot more medial, and I always like to land on top of the facet and then come down. That's the only thing I would do differently. First, I like to see the IAP, SAP first, then work on the disc.
From my side, I prefer interlaminar approach for this as a first option. But if there's a problem with the exiting root, and if I want to decompress the foramen, I will start from the junction of the pedicle and the foramen. So first I identify all the bone structures till the SAP tip, then I find the exiting root. After that, if we have a chance to drill with the flexible burr, it will be perfect. So I start outside and slowly I will go to cranial, then I will free the first exiting root, then I go inside. Because when we push the sleeve inside the foramen, we will squeeze the exiting root a little bit. So it will be safer. That will what I will be doing differently.
I prefer to land on the SAP and use the TRIFI. If you use a TRIFI, and you will save a lot of time, because if after you use a TRIFI, remove the SAP, all the bone, it's a bone chip, and then you can see the traversing root directly, and then you can organize the orientation of your surgery faster, maybe. Okay.
Can you see the dural pulsations?
Yeah.
Very well now. So grasper. Now we have to decompress the exiting route where it is.
It's wonderfully done. So the same thing. You either go from outside or outside in or inside out. Visualized way of addressing the SAP or with the reamers, serial reamers, which work is very faster. Only worry is that you are not visualizing things there. The collapsed foramen, there is always that fear of injuring the structures. But once you are experienced enough, yes, definitely you can do that. But as a beginner, it should not be tried. Maybe once you become experienced, you can take such cases. You can see the nice epidural pulsations there. So now, as he comes out, he can decompress the lateral edge of the traversing route also.
Lot of adhesions because of the chronicity.
Yes. Yeah.
Actually, there is no plane between the flavum and the root.
Yeah. So maybe you can come more laterally and free remove that bone, curtain of bone. So you will see the root properly. Yeah, that curtain of bone. Yeah.
So this is the cranial end.
Yeah.
Some more annulus is there.
You can burr the SAP more so that you can remove the entire till the medial border.
Correct.
So that the lateral edge of the root is also seen properly. Yeah.
This is the flavum here.
Yeah, that's what. So you drill the remaining facet also, so that flavum also can be removed easily.
Cutter. Kerrison. Now you can see the root and the flavum. Can you see? Kerrison.
Yeah, you can use a Kerrison here, the tube sheath punch to remove that curtain.
Cutter. Kerrison, tube sheath punch. Still I have to do some burring. Burr.
I think the tip of SAP is merging with the annulus, so that area is probably.
Yeah, everything good. हाँ ये SAP है, थोड़ा निकाल.
Here you can use that flexible drill so that you can drill the bone faster. Now you have a control, you see the. You see the left hand of Mahesh, the drill, how he is drilling, it's almost making it horizontal. So
I am not using this articulating burr because once you get used to a luxury, then you can't live without it. So live the life hard way.
So you want to suffer.
That's okay, I'm not suffering.
Yeah. Always better, because when you don't have that, it's difficult.
So I can work anywhere with a straight burr.
Yeah. Right. So definitely it's a wonderful job done. It's a very difficult case, as I was discussing in the afternoon.
Or cutter deda.
So now you can see the laterally also, the ligament is so tough and the look is very dirty. So it's more of a tough calcified ligament.
So it is not at all an easy case
to
do it transforaminally.
Maybe you can use a hook or curette.
Tube sheath punch. Let me try with this. Oh, it's not catching because.
Best
Give me
is a
another
curette
kerison, bigger kerison है. इसमें है. Try with another kerison.
Yeah.
Curate. Curate. RF. Press. Now we have to see the exiting route where it is. So here also it is a very fibrous tissue here, a lot of adhesions.
Yeah, the annulus and the root is almost united, so on the ligament.
So we have to go step by step.
Yeah.
Clean. RF. Press. Stop. Just give me the cutter. So root must be somewhere there. So let us see. Arif. Press. Press. Arif. There is a big vessel here. Stop. Cutter.
Naresh, can you just announce about the realist talk, so that what is this model about? So Chris can just brief about this the model evolution of this model, and how it is useful for the youngsters to learn, and how it is going to replace the cadaver.
Okay.
After this one,
Cutter. Dissector. Give me cutter first. Cutter.
So thank you very much. I'll give a few words on what is about to come next. I'm here on behalf of Realist. My name is Christian Lüth. I come from Germany, and we have a training simulation company in spine surgery. And there was a lot of talk with Naresh and Dr. SUKUMAR to come here to Hyderabad to show our real spine training models and give a presentation shortly on it. It's been a long way until we come here together, and I'm very proud and honored to speak in front of you very soon. Thank you very much.
So the one problem with training on cadavers is, especially in spine, you don't get the real feel of the human live patient when we do spine surgeries. The muscles are shriveled, bones are porotic, and there is no almost disc is either not there or very fibrous. Ligamentum flavum is very thinned out or sometimes dissolved. So in such cases, when you want to learn on cadaver, most of the time it's always an unhappy resident or unhappy delegate going home, that he has not feel of what he wanted to see or do. So you want to create a real life situation, so you need a good simulator. So you have a good simulators for all other structures, other anatomical structures in other different fields, but there was no good near human simulator. So that the realists have put a lot of thought process, especially for endoscopic spine surgery. They've created a real situation where there will be a CSF leak if you puncture the dura. So you can have as if you are training on a body inside the theater. So that's how this model was conceptualized. So we are very happy that Chris is here, who represents the realist, and we are happy that we are starting this training program soon, maybe in the month of October. The first ISTEC that's we are trying to start. So that's what Chris will tell about more about this model, how it is. He will do a talk. So Mahesha, if you can give us
no problem.
10 minutes, the video, the audio will mute.
No problem.
And Chris will just present his lecture.
No Arif. Chris.
Mahesha.
No issues.
Just before muting, can you just orient the exiting route and the traversing route? for the sake of audience. Just orient so that we can mute you.
Yeah, exiting route will be somewhere at 3 o'clock.
Okay.
So the traversing route we have already seen.
Yeah.
So this is the traversing route and the dural sac.
Yeah.
That is very clear.
Yeah.
Okay. I just have to remove this
soft
tissue
tissue
here in the foramen.
Yeah.
And the tip of SAP.
Yeah. Yeah. Okay, then
Yeah,
you be doing. We are
yeah.
showing the video.
Okay,
The
no
video
problem.
is on. So maybe
No
your audio will be muted.
Yeah, no issue.
Thank you.
Cutter.
Test.
Okay.
Thank you very much for having this opportunity to speak in front of you. I'm very honored to be here today and want to present a partnership which we have been working on with my friends Dr. SUKUMAR, Vivek, and Vivek from Havana, and Naresh, of course, here from the Asian Spine Hospital. My name is Christian Lüth. I come from Germany from the company called Realists, and we are the market leader in healthcare education, and our vision is to increase the learner skill and to improve ultimately the patient outcome. Today we learn a lot about spine endoscopy and a lot of skills, but the more important is to apply these skills in a suitable and practical setting, so you can take what you learn, you adapt it, you apply it, and then you can use it as a patient. Some of our customers are, we have companies, so we work with all the major companies all across the world. We have the associations, and one I must point out, I'm very honored that we now work also with the Spine Endoscopy Research Foundation. And we have a new customer here today. We have the Asian Spine Hospital with Dr. SUKUMAR and Naresh. Now, we speak about a couple of challenges in the surgical training we have today. There's a challenge of adapting the new technologies, and these new technologies are driven by access and usage of these technology, such as full endoscopy spine surgery. We learn a lot today, but if you don't apply what you learn, it's not useful. So therefore, the best way to learn these new skills is in a hands-on scenario or hands-on setting. So this makes a very strong demand for high-level training. And as we heard earlier, you see one, you do one, and you teach one. Now, what to expect of real spine? The traditional training today consists of cadaver courses or traditional training. And where we come in as real spine, we offer a lower cost in training versus cadaver courses. We have a standardization of the products and our pathologies of the different models. And when you have, for example, when you imagine a cadaver course, you have maybe 10 stations and you want to learn about the disc herniation, stenosis, but often these cadavers, they don't have these pathologies. But when you train with our systems, you will definitely have everybody gets the same standard. Everybody gets the disc herniation, stenosis, and so on. With real spine, you have the flexibility to train anywhere. Technically, we can have the training here in this room or in your own theater. So a lot of trainings are actually done in the hospital itself, versus when you do a cadaver workshop, you have to have 2 different facilities, everybody get together, and it's not so, well, personally I believe it's a more relaxed way to have the training in your own environment, your familiar environment, versus a cadaver lab. And of course it's more cleaner, so there's no biohazard with these models of us. And we have the realistic anatomical bleeding, and it's even pulsating, and we have the CSF, as Dr. SUKUMAR was mentioning. And we are available worldwide, and most importantly now in Hyderabad. So training with real spine, this is what it would look like in a real scenario here. Our idea is to revolutionize the surgical training experience with game-changing realism of real spine. We can simulate the skin, the bleeding, and it's even pulsating bleeding. You will have the intervertebral disc, the fat, dura mater with CSF. So when you have a dura leak, it's a great learning technique and a great feedback from surgeons when we do the training to learn about the dura suture. So usually when we do the training, everybody said, like, what do you do when you have a dura leak? I call somebody. I'm like, well, next time you don't call somebody, you do the dura suture yourself. And this is one part what we are training. You have the ligamentum flavum, lamina, muscle, herniated disc, etc. But the question is, how real is real spine? So we made a study about the visual and haptic validation of our models comparing to real patients. And one is the best, well technically 0, but you cannot get 0, one is the best and 4 is the worst. But you see on all the parameters of bleeding, PLL, disc prolapse, nerve roots, etc. But also on the haptical validation, when you cut the bone of our models, it feels exactly like real bone. And you have the disc prolapse, the lamina, etc. Some of the benefits and advantages is that you will have a more effective training. This again is measured by a study of us by 25%. When you have a training center, everything is all inclusive. The preparation, logistics, assessment, and consulting will all be done in one center. So you don't need to take care of anything or handle anything. And it's of course more time saving for you to know everything will be there, no hassle of worrying, but everybody here is very busy, so you need to spend the time in the best possible way, ideally with the patient, and have a more efficient time when you train. And as mentioned earlier, we have a strong standardization, so every model is manufactured exactly as the other one. So we want to learn about disc herniation, we will have a disc. Every model will have the disc herniation, stenosis, and so on. And it's compatible with different technologies, such as X-ray. We can have the, because some of our models, they have no metal, so it's radiolucent. And often it's lower cost than cadaver training, on average by 30%. Talking about a couple of our models, what to expect. I have a video here of the dura suture, of a dura leak. The water pressure is exactly like a real patient. This is now mini open here with a microscope, but we also have the exoscope, or of course different approaches. With the bilateral decompression, you can see here the blood. You can do the drilling. We have the endoscopic decompression. So I think one of the most interesting parts for today here. Naresh, looking. Yeah, it's yeah. Yeah, you're right. You're right. Then we have a discectomy. So when you have a herniated disc, we can also adapt if there are special requests to make the bone a little bit different, more osteoporosis-like. We are fully flexible on adapting the models to the training needs of each individual surgeon. So, bleeding management. Our most recent products and advanced one is the advanced MIS, which we have a lot of requests for. It's mainly for both the endoscopic or microscopic decompression training in the lumbar spine. We have different pathologies, a disc herniation in L4, L5, extraforaminal disc herniation, again, L4, L5, stenosis, or complex stenosis. And this is how it looks like. So it consists of a base station, a cover, and inside there's the different cartridges as shown on the left-hand side here. Whoop. You could see that there. On the left-hand side here on the bottom. The procedures you can do with this advanced MIS is the incision, flavectomy, laminectomy, bilateral decompression, sequestrectomy, discectomy, fascectomy, dura closure, bleeding management, and so on. So this is the cover for the endoscopy, and this is for the larger models where you can also do the skin incision and have levels up to L3 to S1. And for the endoscopy, we have the L4, L5. Another very interesting part of the training is the real imaging, where we train the radiation-free X-ray simulation for surgical training. And it consists of a camera of NDI, and it's very, very cool because there's no X-ray, so it's X-ray free. And we simulate it by having two worlds. So one world is the real world of the model, and the other world is the virtual world on the screen, what you see. Where we adapt the tools, the instruments, and in a virtual world, and then you can see that the camera knows what will be displayed or what kind of patient is here, if we have the L4, L5, if it's an endoscopy patient, and by the tracking star. But the better way to explain it is to actually show it. I hope the video is playing. It is fantastic. So the camera is standing on the right-hand side. It needs a line of sight, and then you can see the tracking star here. And what we see on the screen, what you're doing on the hands-on, is exactly what you will see on the screen. Placing the cages, tools, endoscopy. So it's high flexibility on working with it. You can do screws, you can do drilling. So it's very, very interesting to work in this kind of environment. And again, we can work with we are working with all the major manufacturers, and we have adapted their instruments into our system, and they can be displayed on the virtual side. Another interesting product is the Spondy X, which is about the pedicle screws, so we can set 8 screws. It's a very basic model, so we have basic and advanced models. On this model, there's no bleeding and no metal parts, so you can actually X-ray it. And the bone quality is exactly like real bone when you drill it inside. And it's a more slim profile. But again, I would like to show you the video on how it works. Yep. So you have the base station, you have the cartridge, you can set 8 screws. And it's ideally for external navigation, pedicle screws, fusion, X-ray, robotics. I actually have a lot of robotic customers, and they work with that. And all our models are based on real patients. So you took the real patient data, and we manufacture the models based on them. And this is our portfolio in general. So we have the basic MIS, advanced with the bleeding, the Spondy X for X-ray, advanced Spondy with higher levels of L3S1, SI, very new, lateral, so you can learn about the different approaches and have a real haptic feedback which you can flip. We have the advanced myelopathie, and most recently the anterior cervical. And now I would like to announce the partnership. Vivek and Naresh, I'm very happy and honored to announce the world's first international spine surgery training center and education center here in Hyderabad today. And we call it ISTEC for International Spine Surgery Training Center. So we signed an MOU together, and it was a lot of work with Naresh and Dr. SUKUMAR, so I would like to bring you on stage to have an okay. Vivek.
Dr. Bhupesh has started one more interlaminar case in the first image. It's a small inferior migrated small disc prolapse with recess stenosis. So he started radiology. Once this is over, we can see the radiology. So it's on the left side. He has started. So we'll orient once this is done.
So quickly waiting for our friend Vivek. And I want to say a few words what you will be expecting or can expect in the future about ISTEC. ISTEC will be located in the Asian Spine Hospital and will be managed by Naresh and Dr. SUKUMAR. And you will have the opportunity to learn about spine, mainly about spine endoscopy, but all other spine training at ISTEC. So everything skills you want to learn, please ask or approach Naresh and Dr. SUKUMAR. And we are very honored and happy if you would take this opportunity and have regular courses, at least once a year or maybe once a month, I think, in the future. We'll have trainings. So take up this opportunity. Thank you. He is coming. So thank you very much, Dr. SUKUMAR, Naresh. We go on stage, yeah. Vivek. Thank you.
So thank you, Chris, and I want to thank Vivek, Havana Surgical Chennai for the partnering with us in this huge project. I know it's very difficult without Vivek. This would have not been a reality. So Real Spine becoming a reality. So full credit goes to Vivek and Naresh. Thank you.
Thank you very much also from my side, and wish you a great day and continue with the surgery. Thank you, Naresh, and everybody else.
Actually, we were planning to have the model demonstration here. Actually, it's currently in customs since it was coming first time to India. So maybe, if possible, we might try tomorrow. But in the next few months, with some master faculty, we might do a real spine course. I mean, by seeing this, see how we can, some of the young surgeons can acquire skills using this real spine model. So looking forward for all your collaboration and make this project very successful. So the very key goal is how we can make surgeons more skilled in endoscopy so that they can practice part of their regular clinical practice and adopt endoscopic spine surgery as a mainstream. Thank you. Thank you, Chris, for coming all the way. Yeah. And we'll be having dinner from 7 p.m. onwards. I think we have one, this is the fourth case, and after that, 2 talks from Dr. K.T. Chien and Dr. Hussain. Quickly, everybody are requested to attend and enjoy this evening, and also followed by cocktail dinner. Thank you. Thank you, Chris, for coming exclusively for this program. First time his visit to India, and I think our collaboration. Thank you.
It's really good here, and I met many new friends, so I'm very honored to be here today. Thank you, Naresh.
Thank you, Chris. Bye.
Can someone make
Hello?
OT? Yeah.
Hi,
Yeah, my
SUKUMAR.
son. Yeah.
So I have released this adhesion. Can you see, I mean, fibrous band, can you see the exiting route?
Yeah, wonderful. Can you...
RF left pug mapite.
Can you see?
Sorry.
Remove the PIP for Mahesha sir, OT1, please.
Transfer.
Yeah, the entire exiting route is free now.
Now drill.
So I have to remove little bit of ligamentum flavum from
I
here.
think there was a osteophyte also below the
Yes,
root.
I have removed that.
I saw that.
Yeah.
So remove the osteophyte.
So this is the exiting route.
Yeah.
And this is the traversing route here.
So
both are free. I have to just remove little bit of
the bridging tissue between the two.
Bone here.
Yeah.
And the axilla will be free.
Yeah.
Maybe you can go to the other side and see. Once I clear this part, I will get back to you.
So, Gaurav. Hello.
Hello. Yes, sir.
Yeah, Gaurav, just brief the MRI so that and orient our ask Bhupesh to orient what he is doing.
Okay, sir. 1 minute, sir.
Just first show the MRI.
Gaurav, just show the MRI.
Yes, sir.
So now, yeah, first show the MRI.
Sir.
Expand it. Yeah, this is better. Just zoom in on the MRI. Make MRI image bigger first. MRI image bigger. Yeah.
1 minute, sir.
MRI is in PIP mode, so for a while you can remove the endoscopy mode, make MRI bigger. No, yeah.
Hello.
Yeah.
Am I audible, sir?
Yes, yes.
Yes, sir.
मुझे RF का foot switch ठीक से दो ना.
This is a 40-year female.
Yeah.
She came with lot of back pain, severe back pain since 2 weeks. She is not able to sleep, and she is since last 10 days she has been sitting in the bed.
Yeah.
And for her difficulty in walking, even for 10 steps is also very difficult. So you can see here there is one L4-5 paracentral disc is there with slight downward herniation, very mild.
Okay.
Yeah.
Near the inferior recess of the L4-5, that will be better delineated in the axial plane. You can see on the left side there is a paracentral bulge, and small fragment has gone inferiorly, and it is pushing the traversing route in against the recess. So the fragment here is medial to the root. That's why she is having that unbearable pain. So much so that we have given her propofol in sitting and then made her lie.
Okay.
Now,
so what is the plan here?
Now plan is Dr. Bhupesh sir will tell, sir. Over to Dr. Bhupesh sir.
Yeah.
Hello,
Bhupesh
Dr. Sukumar. Yeah. Good evening. So we are planning to do interlaminar discectomy and decompression. So we do lateral recess decompression. We retract the nerve root with endoscopic sleeve, and we remove that fragment which is trapped between SAP and nerve root.
Okay.
You just see the SAP and facet, the fragment is trapped, so she has unbearable pain. So initially we target the spinolaminar junction. Here you can see the spinolaminar junction. I started drilling here, and gradually we'll start from here and gradually move toward the lamina and facet joint, and we'll clear out the lateral recess. We don't intend to go on contralateral side, but we'll focus more on our left side only.
So 3 o'clock is caudal and 9 o'clock is cranial.
So 9 o'clock is cranial and 3 o'clock is caudal. Okay.
So you are drilling the laminofacetal junction and laminospinous junction here.
Yeah.
Okay. So you are using a smaller scope here today?
No, this is an interlaminar scope. Actually, this is a scope from MP Medical. This is 8.4 mm outer diameter and 5.6 mm internal diameter. So whenever when he sees that because of 10 millimeter diameter, sometimes it's very difficult to move the scope once we did laminotomy. But in 8.4, we can go inside the laminotomy window, and our manipulation a bit easy. This is what I feel.
Okay. So the drilling, how much you want to drill here?
Yeah, again I want to drill as much as I just see the superior aspect or superior end of the ligamentum flavum, and then lateral recess and lateral and lower inferior end. I don't want to go on contralateral side.
Okay, okay.
Okay.
So what drill you are using now?
So this is spinolaminar junction, base of spinous process, and this is lamina.
The drill, which drill?
Yeah, drill is this Indian made drill. The Bharat Biotech is Barodan based company. This is the first time I am using this drill. Initially we did little bit of modification, but now I think they have come up with the almost micromotor system.
Okay. What is the speed?
Speed is around 30,000 RPM right now.
Okay.
Lamina is thick as expected.
Yeah.
This is my side facet, and this is lower lamina. I will go in the latter. First I'll So here you can see my hand movement. I am going from base to in lamina on my side and in rotatory movement clockwise and counterclockwise.
Yeah.
RF. मुझे ये RF दिखाओ ना, फुट स्विच दिखाओ ना, कौन से दबाना है? थोड़ा बड़ा होना है, RF ठीक काम नहीं कर रहा है ऐसा लग रहा है.
So there is a question, Bhupesh. What if the entire dura, the entire ligamentum flavum is also ossified?
Yeah,
so I will answer that. So in thoracic, when we do OYL, the ossified yellow ligamentum, so entire ligament is ossified. So we can still do the with the. So you drill at one place till you reach the dura. Then once you reach the dura, then you can. It's as we do in cervical corpectomy or cervical OPL. You just eggshell out the entire ossified area, that one place. Then you start drilling all around it. Yeah. Do that. So because the vision is excellent and you are using the diamond drill, so you have more control, and at one place you eggshell it and then you can drill around it.
Forceps. Drill.
So what is your usual practice, Bhupesh? You come from the facet tip or you come from the spinolaminar junction? What is your usual practice? Hello, Bhupesh. Hello.
Hello, yeah.
Bhupesh, the
Yes,
question
sir.
is, so what is your usual practice? You come from the spinolaminar junction?
Yeah.
Or you come from
So
the...
I also do UBE.
Yeah.
So from day one, my practice is like I usually start from spinolaminar junction and gradually coming down to the lamina and then facet.
Okay. Okay.
So I am more comfortable using that technique.
So there are two varieties. One we can drill the.
आपका आवाज थोड़ा slow है.
Yeah. So we can drill two ways, as you saw me drilling from spinolaminar junction. Dr. Lokande drilling from below, from the tip of the facet.
Yeah.
You can drill either way, you can land either way. So there are some disadvantages. So whichever way you are comfortable, you can do it because of the 25-degree angle scope most of the time, or 15-degree angle scope, it can be done. So depending upon if the foramen is a problem, better land more cranially. If the lateral recess and inferior area is a problem, land more inferiorly, so that you can address bilateral lateral recess when you land inferior. So it's all the pathology and individual practice, we can land either way. And the second thing, how medial, how lateral you land. Some people has a habit of landing little bit laterally when they want to do stenosis and want to go to the opposite side. Because when you land little bit lateral, tilting the scope become easy, so that you need not remove the more bone. The curtain is less. When you land more medially, the curtain to go to the opposite side, the bone visibility is more.
So here, can you appreciate the midline cleft?
Yeah.
What Dr. Sukumar was saying, the midline raphe in the morning.
Yes.
So now I am sure that I am not on unilateral side. So identify that midline cleft is very important, because that will decide your side, which side you are. So you are not drilling too much on contralateral side, or you are not drilling too much on ipsilateral side. And when you start appreciating this raphe, the cleft, so your flavum is around 3 to 4 millimeter ahead. So you are almost finished the drilling. So now I identify that I don't want to go on contralateral side. Again more clear, you can see.
Yeah, very clear. Just pass on the message once Mahesha is done the final.
एक
final
RF दे दो थोड़ा, RF को
just-
थोड़ा कम करना पड़ेगा आपको, है ना?
Yeah. So now you can see that this is Mahesha's theatre, the entire traversing route.
Hello?
And, yeah, Mahesha, go
Yeah,
on, go ahead.
So I am finished here.
Yeah.
So if you can see, this is the dural sac and the traversing route here.
Excellent,
I
Mahesha.
removed the entire length of flavum on the lateral recess.
Yeah.
And this is the axilla of exiting route, and
Yeah.
this is the exiting route. You see the
Fat
pulsation.
pulsating, yes.
I have just not removed this fat.
Yeah.
Let it be there, but you can see that the root is very nicely decompressed. Both
Excellent.
roots are decompressed. The axilla is free. It's pulsatile. The osteophytes I have removed. All these fibers, adhesions, everything I have removed. So it is fully decompressed.
Wonderful, Mahesh. Do you want to give some steroid here, Mahesha? You do
Which
have-
one?
Steroid.
I will put some steroid.
Yeah, what steroid do you usually prefer?
Anything, triamcinolone,
Okay.
Kenacort, or whatever you have.
So
Because
some
we,
people have the
actually we have
habit
not handled much of exiting route actually.
Yeah.
But anyway, it is very well decompressed. We will put some steroid and come out.
Yes. Thank you, Mahesha. Wonderful. Wonderful, Mahesha.
Thank you. Thank you. Yeah, triamcinolone.
So that was Mahesha removing the entire, it was more of, rather than bone, it is more of a hard fibrous the ligament which was causing more stenosis there. So he has released, just drilling of the bone is not enough. You need to release the scar tissue between the exiting and traversing route, and the osteophyte he removed. So this is the key for foraminoplasty success. If you just drill the bone, it's not enough. So that's why identify the neural structures, releasing them both, traversing and exiting route in foraminal stenosis is the key. So what is the size of the burr you are using, Bhupesh?
4 mm.
So 4 mm burr.
Yeah. So forceps.
So I use a curate here, so which works wonderfully.
Just give me forceps. छोटा तो नहीं इससे. Small.
Once your drilling part is done, maybe
Arif.
we can go ahead with our two talks. Professor Chen and Professor Hussain talks are pending. Naresh, I think we can just mute
Cutter
it
do
and,
that.
we can start one talk so that we will be completing in time.
Arif. Drill.
Parallelly, we'll have a lecture by Dr. Hussain Usturk on full endoscopic stenosis decompression.
अच्छा हो गया ना आरिफ हाँ yeah so I'm just drilling almost finished okay just low yeah so this is lower lamina you can see cutter Arif
Over to you. Go ahead.
Welcome. Sound is okay? Okay. Welcome from my side. We see 4 cases and we will talk about full endoscopic decompression in spinal stenosis. So you see the 2 different drilling techniques. So I prefer Dr. Lokanda's style, I can say that. So for the degenerative spinal stenosis, we have the problems with the bony, discal, capsular, or ligamentous hypertrophies. So the result will be the central stenosis or lateral, like recess and foraminal stenosis. So I prefer for the foraminal stenosis the transforaminal approach. But if I have a recess stenosis or central stenosis, I prefer interlaminar approach. We talked about during the surgeries, we have 2 systems for that. One of them is vertebris lumbar system. The other one is the stenosis system. They use the bigger one. I prefer vertebris lumbar 8 mm system more because I always check the anterior part with the disc herniations. So with the stenosis system, you cannot do this rotation maneuver. But if there's a severe stenosis, the stenosis system is better. because the stenosis system is 1 centimeter with the working sleeve, and you have step dilators. Of course, there we can use 5.5 Kersen punches and also 5.5 drills. By this way, we can address the bony pathologies faster. I will start from the operating room setup because it affects a lot of things. From my side, if you are doing here, if you do right side or left side, I always keep my dominant hand. Then I will do the setup like this. My nurse will be near my dominant hand here. After that, I put the C-arm here, and according to the surgeon's comfort, the equipment unit and the X-ray monitor will be set up like this. As you can see here, if you prefer the other side, then your instrument will fall down, and it takes a lot of time with the surgery. Or if you do like this, like the opposite, then the position of the surgeon is not so good. Like you see, this is one of my first cases. So I had a back pain after this surgery. Maybe after 20 cases, we need an endoscopic spine surgery. And this is the most comfortable way in this position, so our spine is safe here. I think the patient positioning is also important. As you can see, we have to free the belly here. If you put the pillows like this here, and if you don't give enough bending from the hips, then we will have some problems. First, we will have a lot of bleeding. So if we give the flexion point too much, then in this pillow, it pressing the abdominal structures, then you have more bleeding. I find this really comfortable. In here, we put these pillows like this, so the belly is free and the flexion is not too much. By this way, if the patient has a high sacral slope, then you have to work like most tilted all the time. But in this position, it will be really easy. And I have a different experience with the drape. This is actually the first case of mine here. I do the incision, I put the working sleeve, and with the working sleeve, as you can see the incised drape, I pushed inside the spinal canal. So after this surgery, I always remove the drape from the incision point. Now we can switch to the surgical technique. I always mark the middle of the interlaminar window, whatever I want to do. But if it's cranial caudal sequestrated migrations, then I will choose more cranial or caudal. But for the stenosis, I always mark the middle of the interlaminar window and as much as medial, because it's the entrance for me for the spinal canal. Then I put the dilator. First I go directly inside, then I lateralize a little bit. By this way, I will land on the facet joint. If I search for the lamina and other structures, I have more bleeding. By this way, I put down the working sleeve, then I started coagulation. It takes less time and less bleeding by this way. Then I can start the surgical technique. First, I prepare everything. The facet joint, the caudal lamina, cranial lamina, and the flavum ligament. First, I find the tip of the descending facet here. Then I started to drill to cranially. My cranial landmark for the stopping drilling is the tip of the ascending facet. By this way, I will reach the cranial border near the axilla of the upper root. Then I started to drill to caudally. Then I will complete the ascending facet and the caudal lamina. I always protect the flavum ligament while I'm drilling. At the end of the drilling, I started to open the flavum ligament from medially. Here's an example. I started to identify the structures. First, clean all the soft tissues, and then I need to find the facet joint. As you can see here, this is the tip of the descending facet. This is caudal, this is cranial. So I find the medial border of the facet joint. I cut the superficial part of the ligamentum flavum from medially, so I always follow the bony landmarks from here. Then I go inside with the cannula, I retract the soft tissues, then I look cranially. Then I can find here, this is the ascending facet, and this is the descending facet. After I identify these structures, I can start drilling. If you lost your orientation at the beginning, then find this anatomical landmark, then you can start from the beginning. I always use to drill the descending facet with the protective one. So it will be faster, and also during the drilling, I protect the flavum ligament with this side. And you can see the here. I hope. I always follow the medial border of the ascending facet. Then, for example, one of the advantages to starting like more caudally, you can undercut the lamina. So I don't have to drill too much because the lamina stay there. I just go undercutting there. Then I use kerosene. Then you can see the last layer of the flavum. It's the attachment point for the cranial border. And at that point, I check with the X-ray. If I reach the ascending facet tip, that's enough for the cranial border. Then the next step is drill the ascending facet. In the cranial, I still use the protective drill with the Rosen one. It will be faster. As you can see, you protect the flavum. But when I go to caudal side, on the caudal lamina, and I switch to the diamond burr. Sometimes if it's so thick, so I can continue, but this will be safer because the flavum ligament will be thinner and I will be on the root. So if I extend the fall down inside the spinal canal, the diamond burr gives me extra safety. And also for the bleeding of this part, on the lamina it's more, so the diamond doesn't allow to any bleedings, so it will be faster. So I check the cranial and caudal border like this. This is cranial border, caudal border. Then I started to cut the flavum ligament from medially. I always open it from medial side. I use scissors from medial. First I thin it like that, then I complete piece by piece. Then after removal of all the flavum ligament, I check the drilling points. So cranial border, cranial border, caudal border. So I always do a small foraminectomy on the caudal part. So I use kerosene to do that. And also if I need to check the anterior part for the discectomies, I switch to the vertebrous lumbar system, then the decompression is done. This is the ipsilateral spinal decompression on one side. If I want to pass the contralateral side, then actually the technique is the same. First, I need to decompress my side. After that, before I've opened the flavum ligament, I drill the base of the spinal process. So I can see the contralateral part of the flavum, and after that, I started to open the flavum, first decompress my side. I open it from my side and then clean everything, so it's free, I have more place. Then I follow the flavum with the kerosene or the scissors to the contralateral side. Here's the one side is finished. So this is the base of the spinal process. So I drill that part. After that, I check the area. I open it. First, I decompress my side. We can use the stenosis system if you are not going to check the anterior part. And also, we see today there's eccentric burrs with the stenosis system. You can protect the eccentric roots and then you can drill the osteophytes there. Here's the traversing here, axilla. And we can pass to the contralateral side. In here, I think the most crucial part is to put the working sleeve on one of the lamina, cranial or caudal. Then you can decompress the other side. And for the bleedings for the contralateral side, most of the time I use spongostan like this. So it stops, then you can take it out after the surgery. I think the most challenging part for the stenosis is the bleeding control. When you have such a position like this, everything is red. Okay, it's working. Then, of course, the first the thing that we can use is RF. Just go close with the endoscope, and the water flow shows you the point. But if you have a problem with the view, then don't close the working sleeve. Then it will be a problem. Just increase the water flow. You can use RF spongostan for the bleedings, and especially for the bony bleedings, I have steps like this. First, we use RF. Today, it's working really fine. Then I use diamond drill, and after that it's not working, I increase the temperature of the RF so you can coagulate easier. And if I do stenosis, I always use tranexamic acid. It helps you, and I think it lowers the hematoma after the surgery. So from my side, it's the interlaminar approach for recess and central stenosis. And also we have foraminal stenosis, intraextramural foraminal stenosis, which are the symptomatic ones, like only in the course of the extending nerve root, like SAP impingement or anterior osteophytes or cysts. There's two options for that. One of them is radiologic control, and the other is full endoscopic controlled resection. Of course, we are talking about full endoscopic control. This is a really good device, and you can address all this area easily. I always prefer the extraforaminal approach. So not inside. I started between the junction between the pedicle and the foramen here. After that starting point, then we can start to identify the structures. Here's the pedicle, the SAP is going there, this is the annulus. So after that, we can start to do our surgeries. We can drill with the protective one or diamond one, Rosen one like that. So we can go more posterior, inferior, or superior. It depends on the pathology. But for the lateral recess, I prefer interlaminar approach. For example, if we have a case which we needs to increase the mobility towards cranial, so I pull back the sleeve from foramen and prepare it towards the cranial. Like if there's an osteophyte on the vertebral body, and if you want to reach the cranial side, then here's the case. There's a cranial sequestration here. So you can rotate the endoscope and the camera to cranially. By this way, if you have a narrow foramen, there is no risk for the squeezing the extending root. The rotation maneuver gives you more space to do that. So here's the axilla, here's the decompressed part, here's the annulus, and this is the SAP. You can see the decompressed part here. So we can increase the mobility towards posteriorly. So to do that, we need to pull back the sleeve, then prepare the ascending facet, and resect the bone at the ventral surface of SAP. Like here, you have two options for that. If the iliac crest is low, then we can do foraminal approach. But if the iliac crest is high, there's a small stenosis, and also if you want to do the disc herniation, maybe interlaminar approach is good for that. But with the flexed burr, you can drill this part is easily. After that, you can resect all the herniation like this. And here's the floating structures and the traversing route, and this is the decompressed area. And of course, to increase the mobility towards caudally, we drill the pedicle. Actually, we did a little bit today. From my side, I don't want to drill too much the pedicle, because if in the future, if I need to do a fusion surgery, then I need to put the screws there. Sometimes if we destroy the pedicle, so where we can put the screws. So sometimes it's a good option to do the interlaminar, but it can be done. If you have a herniation like that, this is the pedicle. Also, this is the SAP. So with the flexed burr, you can drill easily this part. You see the cannula is stable in the foramen. So there's no risk to squeeze the exiting route. So we can address the pathologies here. This is on the literature, so I put it there. I never do this transpedicular one. You just do drilling on the pedicle, then you can address, but it's a limited approach, I think. So I never do that, but if you need to see, it can be done. So from my side, foraminal approach, if there's a pure stenosis on the lateral side, I can do it, but I use most of the time for these pathologies. Because I believe that for the lateral approach, if there's a stenosis, there will be always compression from this side. We can decompress here, but maybe in the future, we need to do something here. So, and it's not easy as we see it today. So from my side, the algorithm like this, if we have a pure foraminal stenosis, we can do a transforaminal approach. But if there's a lateral cess and central stenosis, I prefer interlaminar approach. Thank you. This is Izmir. I opened my private practice 2 weeks ago. So if you have any questions or if you would like to visit Turkey, Izmir, you're all welcome. Thank you.
Yeah, any questions you can ask. So, thank you, Hussein. So, why do you prefer from drilling from the inferior to the superior? Is there any?
When I do the marking from middle of the interlaminar window, so I can find the tip easily. Okay. With the angulating of the cannula, I can undercut the lamina. So I don't need to resect the lamina. If we do the resection for the lamina, it takes more time, and it's bleeding too much sometimes, yeah. Especially severe stenosis. So I prefer it like this way. Okay. Then if it's easier for me to orientate myself, because I can always see the medial border of the ascending facet, so I know where's the flavum, so I can drill easier.
Okay. Okay. So any questions? So we can go to the next talk.
Hello. Excellent, Dr. Hussain. You also talked about starting from lateral also is a good way of doing for over-the-top decompression also. So what is your preferred point of starting? Is it lateral docking only, or is it a spinolamellar junctional docking?
I prefer always docking on the pedicle, so caudal part. You mean for the extraforaminal, yes?
For the over-the-top decompression.
Over the
contralateral.
Top. Yeah, it's the same.
It's the same.
Yeah.
And you remove the ligamentum flavum as a enmasse lastly.
First, I decompress my side, then I do contralateral side.
But in your cases, we saw that you open the ligamentum flavum early.
No, what do you mean?
You open the ligamentum flavum early on the lateral side. You dissect and open the canal early.
Yeah, first, I resect the bony part, then I drill the spinal process tip, so I can pass the other side, but I don't drill the facet joint contralateral side.
Those two videos were different. So first he used the smaller scope with the tube sheath punch. He removed the entire we cut the ligament. That was a smaller scope.
Okay.
The second video is mostly done for the ipsilateral decompression because I presented in the first case.
Yeah.
So I try to shorten the presentation.
Okay.
At that part, I first decompress my side, then the base of the spinal process, then I open the flavum, then I decompress with the kerrison my side completely because you don't know how much you need to take before you open the flavum ligament because sometimes the lamina is pressing down the exiting root there. So I complete my side, then I pass the other side.
Go to the opposite. Okay, thank you.
Question is for Dr. Hussain and actually every other senior here. Will there be a scenario where we need to have a combined approach? Sometimes we will not be happy about, let's say, central decompression in a transforaminal or in a transforaminal approach where the decompression is, interlaminar approach where the foraminal decompression is not adequate. Will there be a scenario where we have to do both? Combined approach, is it?
From my practice, I always do selective injections. For example, when I check the patient, so I try to identify where is the problem, L5, 4, then I look at the MRI. So to do that, I do selective injections to do.
नहीं dissector है ना? Hello.
Yeah, Bhupesh, just go ahead. We have stop. Bhupesh, go ahead. Hello.
Should I answer? No?
Yeah.
Then if I identify like this, I don't do combined approach. Okay. Then if I couldn't understand where is the problem, I prefer T-leaf. Okay. So it's more comfortable for me. If I need to do interlaminar and transforaminal combined, so it's a total disease of the segment, I believe it. So I prefer T-leaf for these patients. But if I can identify if it's the L5 or 4, then if it's foraminal stenosis, I will do the extraforaminal approach. Then if it's interlaminar, I can decompress the interlaminar. And to do that, I use selective injections.
Very good. SUKUMAR sir? So this case Dr. Mahesh has done
Yeah.
is quite a difficult case altogether. But we see by radiologically and intra-op, will there be a scenario, would you like to reconsider going from the other side? Or it's always we can go finish through the transforaminal?
No, transforaminal, if you just understand the anatomy there, definitely transforaminal is still the best.
Okay.
So even though interlaminar contralateral you can decompress, you cannot bear the root as he did today so easily, remove the osteophytes, remove the entire ligament. We can do it, but at the cost of opposite side inferior facet and lamina removal also, and some part of superior facet.
Correct. So there is no need of combined approach any point.
No, there is no need. If you see the traversing route and you are able to decompress the lateral.
If not, sir, if not, we are not able to decompress.
Then you can go. Then again, if you go interlaminar, you can only decompress the ipsilateral route. So again,
I mean, after finishing one after the other, because there was a point where actually sir did very good job. If we were as a
beginner, you have difficulty in that. First go interlaminar, decompress the traversing route, then go transforaminal and remove the.
It is possible that.
Yes. Okay. There is what is called as a lamino-foraminoplasty.
Okay.
Where you go both way. So go interlaminar, go transforaminal.
That's what my doubt actually. If I was there, I would have done both way.
Yes. So we used to do that, and there are tools being developed for that, so that it can be done faster. Okay. Go interlaminar, go transforaminal. Put a kind of a wire kind of a thing where you just. It's like a giggly saw used for a cranium, so where you can just remove the entire tissue between the traversing and exiting route.
Tough tissue. And thank you, sir. Thank you.
Yeah, Bhupesh, go ahead. Hello.
Sir, I am audible?
Yes, tell me, Bhupesh.
Yeah. We just, you see, we just leave the lateral recess and we just retract the nerve root.
Yeah.
And you are oriented. The 9 o'clock is cranial, 3 o'clock is caudal, 12 o'clock is medial, this is a nerve root.
Yeah.
So we are just retracting the nerve root and we just put that endoscopic sleeve so that our root got retract. Okay?
Yeah.
And now, sorry. So we have, remove kar do isko, okay. So these are the fragments, small grasper. So with sleeve you can again retract the nerve root a bit.
So that's a fragment which was very tough fragment sitting on the below the
just below the nerve root. So it was again,
so patient should be relieved of pain. She was suffering a lot. We thought we'll do it as a first case, but then so being a stenosis day, so we thought we'll do some classical case. Well done, Bhupesh. So you want to dig into the disc, or you just want to dig?
No, I just do targeted fragmenectomy. I don't want to go inside the disc because it was only the fragment.
Yeah, in the MRI looks the tough annulus, deformed annulus, but it's not acute.
Forceps निकल गया क्या यहाँ से फ्रैगमेंट था वो आ गया ना चलो अगेन स्लीव
Bhupesh, can you just show the cannulated retractor once? They want to see that.
Okay, just give us, show us the video, forceps और RF दे दो पहले यहाँ दिखाओ video.
Can someone zoom in the Bhupesh hand, Dr. Bhupesh hand, or you can just remove that once you are done, you can just show that sheath once.
Okay. This is the sleeve.
Yeah,
can you see?
Yeah, make it a
so
bigger.
It is beveled.
Make it a bigger image. Remove the endoscopic image, and make it a bigger image. It's a tubular sleeve, just like the endoscopic sleeve, but longer.
You can see. Yeah. So inside you can around put 3.5 mm grasper.
Yeah.
So can I put? Isko, yeah.
Got it, Bhupesh.
Okay.
Yeah.
So again, I am putting in and just retract so that we can just say we don't need to change the scope every time. Okay. So now these are annular defect. Can you see? Appreciate?
Yes.
We don't want to disturb too much. We just go do some interannular RF.
Is there any hump around medial or just cranial and caudal? Is there any hump? Bhupesh?
Yes, sir. Sorry?
Koi hump, the cranial and caudal, is there any hump there?
No, there is no hump.
No
dissector,
hump.
give me dissector. So it's almost flattened to the nerve root, okay?
Yeah.
Parallel to the end plate.
Soft, yeah.
So there is no hump.
Okay.
So I just remove this much, and I don't want to do too much discectomy in this case. And root is completely free now. You can just see.
Excellent, Bhupesh.
Okay.
So excellent work. The patient will be completely relieved of pain. Thank you.
Yeah, thank you,
we'll
sir.
Go ahead with the next talk. So thank
Sure,
you,
sure.
Bhupesh.
Sure, thank you.
So we'll go ahead with the next talk by Dr. Prasad Patgaonkar. He'll be talking on complications.
Okay, done. नहीं कहाँ ना दिखाओ डिसेक्टर
Complications in transforaminal.
नहीं वो दिखा ना तूने नहीं है कुछ भी this one नहीं वो
we'll have full endoscopic lateral recess stenosis decompression transforaminal approach
कड़क हार्ड है वो कुछ
by
नहीं है
Prasad sir from Indo.
काटना है निकालना है कुछ क्यों निकालना है we have just remove the fragment no need to remove ना okay so this is the अपना final view we didn't
So
go
I'm
to
sorry, so Prasad is talking on lateral recess decompression,
bony
what
work.
Mahesha just did. So he just
थोड़ा
will
flavor निकाल
show
देते हो,
the
निकाल
tips,
देते हो यहाँ वाला।
tips
थोड़ा
and
केरोसिन दो
tricks
मुझे।
how it should be done
It's not needed, but छोड़ो।
in a better way.
Okay. So, as we have seen the nice demonstration of lateral recess decompression transforaminally, we have been seeing since morning interlaminar and how we can do transforaminal. So, basically, we cover this topic in following points. First, one need to be oriented to transforaminal approach. Then we need to know exactly when to select transforaminal approach versus when to go for interlaminar when we are dealing with stenosis. Then how to exactly select the entry point. As you saw, Dr. Mahesha took almost 16 centimeter from midline. So what makes him select 16 centimeter from midline? What is the trajectory? How should be the line drawing? Then what are the technical considerations when you are dealing at different levels of dorsolumbar or lumbar or lower lumbar? Then you need to know about the endoscopic optics and endoscopic anatomy, and then what are the maneuvers you need to do and what is the exact endpoint of decompression. So as we know, this is the basics which we all already gone through, that whenever we are going for the left side, it is cranial is at 9 o'clock. When we are going for the right side, cranial is at 3 o'clock. And we are going between the traversing and the exiting nerve root. So when it comes to the patient selection, basically we must know what our approach can do, what is the limitation and what exactly is the accessibility. So when we are dealing with transforaminal approach, what we can do is the lateral recess decompression like this. You may deal with extraforaminal, foraminal and even the central herniations, and you may go up to the other side also when there are bilateral symptoms, suppose, and you are doing just subannular discectomy on the other side. You can deal with the ipsilateral lateral recess and you can still go to the contralateral decompression of the herniation. But when you know that the flavum is the most important structure which needs to be dealt with, so this is the way you go ipsilateral and then you may go contralateral and you can reach up to the foraminal stenosis on the other side. So as somebody was asking, which are the case scenario when probably you may need to go for both the approaches. So I think by selecting a proper ipsilateral or contralateral interlaminar approach, you may not need that kind of approach. But in one of the situation which I remember, probably when there was a foraminal herniation, but there was a bilateral symptoms, flaval component was also there. So I went from same side, ipsilateral transforaminal, because I wanted to deal with the ipsilateral exiting nerve root. Same time, from the same side, we did a over the top decompression and ipsilateral traversing nerve root decompression. So multifocal herniations with stenosis may be the situation where you may need this kind of condition. So this is our recent paper published just last month, that this is an algorithm for selection of full endoscopic approach for symptomatic nerve root decompression. So this is an open access journal, you can go through this. These are the factors we consider, that FAP disc is a facet angle, anterior pathology, posterior pathology, then DIS stands for herniation, which is either dorsally migrated herniation, inferior or superior. So if you consider all these steps of FAP disc, then probably selecting a proper approach without much of challenges would be a better idea. So when we consider transforaminal approach, the most important thing is whenever we are dealing with any kind of pathology which is dorsolumbar or the upper lumbar, probably the most important thing is you need to know that maximum distance is this. This is the posterolateral distance from the midline. This is the point you can select. You cannot go beyond this point because then you have a chances of visceral injury. Similarly, when we go for the lower lumbar, the possibility is you can take this measurement, that is the posterolateral measurement. You can take the entry point, which usually gives you 35-40 degree of angulation. And when you are taking another point, which is tip of spinous process, so this is the entry point. I consider the entry between these two, that is called as PLTOSP. This is also our publication in last year's journal, that PLTOSP, and the most important better point in support to this PL-TOSP entry is this always gives you somewhere 24 to 27 degree of angle from the horizontal. So the best part is our transforaminal optics is a 25 degree optics, and if you go with this PL-TOSP entry, you will always go at a 25 degree. So this also helps us defining, even the patient is obese, like what today Dr. Mahesha took 16 centimeter, that was his experience, and arbitrarily he took that entry point. But probably if you, for the patient who is just 45 kg, probably 16 centimeter would be, even DFJ would be the far lateral entry point will come at 16 centimeter. So if you mark these two entry points, your angle would always be 25 degree and your optics is always supported with this. So that is why I consider this PL and TOSP, the midway between the two, is the better point for taking transforaminal entry point whenever you are doing lateral recess stenosis decompression. So how do we mark it? So this is the most basic stuff, that yes, this is the PL length that we draw. This is the point we get. So this is how our approach is in the lateral recess. Similarly, so you can see how we mark it on lateral view. Similarly, on the lateral view, you mark the tip of spinous process, and that tip of spinous process will guide you to almost 15 degree. So this angle, which is PL entry, which is almost like 35 to 40 degree, and TOSP, which is usually at 15 to 20 degree. So if you go midway between the two, you get the 25 degree entry. So this is how we draw the line. The first step is when I first check it on AP. First I draw is a vertical midline. So you check on the C-arm, this is the vertical midline. Second is horizontal line at the level of the disc. The next step is, you on the lateral view, you check that posterolateral entry point. So that is that at the level of disc inclination, you just mark on this rod which is placed on the disc inclination line, and that this disc inclination line, once you check, this is the entry point. So this length I transfer it from the midline, and this is the tip of spinous process. So you get these 2 points, this is TOSP and this is PL, and I take midway between the two. So these are the 3 markings, PL, TOSP and midway between the two. So now needling technique. So once you have taken that marking point, now you take the needle, and first in the initial practice, make sure that your bevel is ventrally placed. So you err more dorsally. So you go horizontally at 20 degree around, because you know your entry point will give you 25 degrees. So you go by 20 degree and try to hit the superior articular process. So I check it on AP that I have reached to the lateral pedicular line, and I check it on the lateral that yes, I have not entered into the foramen or I am too much ventrally placed. So once you check it, now there are 2 options with you. Probably you may, depending on the situation, you may go inside out or outside in. If you are going outside in, yes, then your docking should be, as we discussed today, that was a visualized way of doing outside in. Otherwise, you can use the reamers. And the other way around, when you just rotate this needle by 180 degree, you will just slide over to the SAP and you will enter into the foramen. So this is how you place your needle. So the point is, on AP you need to check that you are on the medial pedicular line, and on lateral you should be on the posterior vertebral line. So this is the standard concept that we know. Although in cases of severe foraminal stenosis, many of the time your docking point is on the mid pedicular line when you are on the posterior vertebral line. So you are more closer to the exiting nerve root, and try and avoid that exiting nerve root injury. So what you do is you just dock your cannula at that particular point and do the foraminotomy first, and then you go for, then you place your dilator more medially and then get inside the disc. So this is how I place my dilator. That important thing is you have to place the tang. Tang has to be placed more caudally so that you avoid any inadvertent injury to the exiting nerve root. And because I do my procedures more into the epidural analgesia, patient is awake. So this is why usually we, sorry. Okay. So, and then regarding the optics, now our optics is at this is 25 degree, and I usually prefer any scope which is 4.1 or above, because through this scope you can use even the tip control burr, So that gives me additional mechanical tool, which can actually decompress you can do the nice foraminotomy, you can deal with the foraminal herniation, you can deal with a more central herniation, you can deal with a lateral recess stenosis. So this tip control burr will be an additional tool for this. So having 4.1 mm or bigger working channel is better. So now the important thing, once you see this half in half position that we saw today in today's case also, that your bevel on AP is in the paracentral region and on lateral you are half and half, and you are now in between the traversing and exiting nerve root. So what happens, very first endoscopic vision, if you are inside the disc, then you will see the disc itself, but your exiting nerve root is outside the cannula. Or if you are doing the half and half position, means suppose you are going outside in, then your first position, first view, endoscopic view will be something like what we can see on the right sided screen. So the important thing is to understand, after doing subannular discectomy or a foraminal ligament clearance, the most important thing is to understand this stuff, which is half in half position. If you see, this is the superior articular process, so you need to create a situation when you are halfway, you can see the SAP, halfway you can see the annulus, and so this is superior articular process, this is the caudal end plate, so this is cranial end plate, this is the annulus, and this is the subannular disc. Now the job of lateral recess decompression is opening this lip. So what you need to do is raise the roof and lower the floor. So raising the roof is possible only with the help of superior articular process burring. So you do a foraminotomy, you keep on burring from the tip of SAP till the middle of the pedicle. And regarding the annulus, you need to take care of removing the annulus from the upper discal margin to lower discal margin. In today's Dr. Mahesha's case, probably the most important endpoint which we could see was because upper discal margin there was an osteophyte, and that osteophyte was troubling and not allowing that traversing nerve to come down. So that is most important part. So this is how we do the foraminotomy. The burr foraminotomy, you have to use this diamond burr in a telescopic maneuver, but you simultaneously keep on rotating the cannula more caudally and cranially, so that you start from the tip of SAP and then come down towards the pedicle. So that is how, once you burr this constantly in a telescopic maneuver from cranial to caudal, you create a nice area so that your cannula is not constantly pressing upon the exiting nerve root, and you have to keep the pressure on so that you are getting away from the cannula. Sometimes you have to hold it because you do not snugly fit into the disc, you are inside the foramen, and you have to hold it in such a way that you are just pushing onto the bone without pressing onto the exiting nerve root. So this is a combination maneuver which is most important, that simultaneously you have to check whether you have to do more and more foraminotomy, you are burring more and more to raise the roof, or you are lowering the floor. So lowering the floor is with the help of annulotomy, and burring the SAP with the help of burr or the mechanical tools. So this is when I have reached to the 45 half in half position. This is the annulus. So once I see the annulus, rotate your endoscope in such a way that you create a 90-degree angle between the scope and the annulus cutter. So this is called as medialization of annulotomy, that you are decompressing the ventral surface of the traversing nerve root. So once you do this, you usually find some upper discal margin, you will find some bleeder there. So you need to ablate that area so that you create a good space for the ventral space for the traversing nerve root. And the most important point is you have to see the fat between the exiting and the traversing nerve root you have to see the inverted V shaped, that the fat of exiting and traversing nerve root has to come together. And other part is this burr foraminotomy. So this is the tip control burr. So once you see that you are able to see the fluttering, you are able to see the epidural fat underneath the traversing nerve root, but you are not able to visualize. The end point of this surgery is always visualization of traversing and the exiting nerve root. So this is how you use tip control burr from tip of SAP to the middle of caudal pedicle. And once you have decompressed enough, you have burred it enough that you are seeing the phlegm, then to visualize that traversing nerve root, you have to do phlebotomy. So that is how you can see the ventral aspect of the traversing nerve root, you can see the dorsal aspect and the lateral edge. You can see the maneuver, how exactly when we are cutting, every time you have to take the scope, you have to take it more and more horizontal so that you can hold the phlegm with the help of your Kerrison punch. And the end point is when you have to do adhesiolysis, the important thing is I always make sure that I start from the caudal end, I have to go till the middle of the caudal pedicle with the help of my palpation hook. Then I go from the lower discal margin to the upper discal margin, go into the axilla and then come out till the lateral pedicular line for adhesiolysis of the exiting nerve root. So if you see overall, when you see this image, you don't realize that there are two maneuvers simultaneously going on. One maneuver is telescopic maneuver. So you are going inside the disc, coming out, you are seeing the traversing nerve root, and then gradually if you come out more, you will see the superior articular process. But at the same time, the other maneuver which is going on is when you are doing caudally rotating, then you are seeing the cranial part, that you are seeing the axilla. And when you are rotating it more and more towards the cranial side, you will see that you can see medial to the caudal pedicle also. So that extent of traversing nerve root in the subarticular lateral recess has to be confirmed, that your nerve root, traversing nerve root is decompressed and it has come down more ventrally. As compared to when you start the procedure, you will not see the traversing nerve root, but as an end point, we always see this is the probe going medial to the caudal pedicle. Then I rotate my palpation hook from the lower discal margin to the upper discal margin. And then this is as an end point for the right side, this is the exiting nerve root. You can see it, this is the right L4 exiting nerve root. Similarly, if I check it on the left side, this is the traversing nerve root after the burring and the removal of the phlegm. So here the cranial end is on the 9 o'clock position. So this is superior articular process, this is the after phlebotomy, this is the pedicle. And then once after the complete ventral decompression and adhesiolysis, you rotate your scope and as an end point, I always make sure that you have to see the exiting nerve root. So this is the axilla, and when you come out, simultaneously you have to withdraw the cannula a bit. This is the exiting nerve root. So for example, if we see the important cases where transforaminal surgery has a huge role to play, this is one of my case where there was a D11-12 myelopathy with L4-5 lateral recess stenosis. In a single sitting, we could do both the levels, D11-12 and L4-5. You can see the pre-op and post-op. On the left side is D11-12, and on the right side, there is a pre and post-op left L4-5 lateral recess decompression. So it is a targeted lateral recess decompression which gives you a wonderful results. So this is the D11-12 level. So you can see the exiting nerve root, and if I just rotate the scope again, this is the thecal sac, this is the ventral aspect of the cord. This is another situation probably in my early days when interlaminar surgeries were not being done so frequently. So this was even lateral recess, bilateral decompression we used to do like this. Probably the same case if it comes to me now, probably interlaminar approach would be a better idea. So bilateral lateral recess decompression also can be achieved like this with the transforaminal approach. This is a kind of situation when there are 3-level bilateral lateral recess stenosis by combination of full endoscopic approach. So L3, 4 left and right was done because of the facet orientation. We did it from the two different transforaminal approach, and because L4, 5 and L5, S1 both were done through a single incision over bilateral over the top decompression. So this is the L3-4 level, where the pre-op and post-op, you can see the bilateral lateral recess decompression, which was done just to preserve the facet. We went transforaminal bilaterally. Then for L4-5, we did, this is the LEULBD, that is the PSLD interlaminar approach. And this is L5-S1 because it was only on the right side, so we went from the right side approach and did the decompression. So basically, transforaminal lateral recess decompression is a wonderful way to deal with lateral recess decompression, but you need to know the correct way, correct indication, and correct approach, correct tool. Thank you so much.
Any questions? Otherwise, we'll move on to next talk by full endoscopic lateral recess stenosis, interlaminar approach by Dr. V.V. Ramesh Chandra sir from Tirupati. Thank you, Prasad sir.
Hello. Prasad, only one question, non-academic. Your presentation was excellent, so there is nothing academic I can ask. Was the shadows what was coming was corrupted, or it was intentional? You did something pink and green. So this is what? Yeah. So something it corrupted, or you did it intentionally? Okay. I just kept on thinking, what is happening?
Yeah, even I was thinking, because some...
Yeah, is it intentional or...
Good evening. First of all, I would like to congratulate Dr. Prasad for the paper. I think he posted it in the WhatsApp group early morning. I went through it a couple of times, and I think everyone should go and read the paper, because it's a very scientific and objective way in putting what we subjectively feel. So I think it was it will become a very landmark paper, I guess. Now coming to my talk. So I was introduced to endoscopy just at the time with SUKUMAR. 2013 we had gone to DAY-1 a couple of times, but transforaminal approach went completely out above my head and I missed the bus. So now with the zeal what SUKUMAR showed in educating and promoting endoscopy, with especially that base group, and I renewed my interest in endoscopy, especially when the interlaminar system has come in vogue. So my talk will be like, he asked me to present something which will be useful who are starting stenosis work. So I have done around 100 cases of only the interlaminar discectomies. But what I found was this technique, this small video, which will be useful for people who want to shift from endoscopic discectomies to stenosis work. So basically, the initial classification was on lumbar spinal stenosis was about the stenosis at the spinal canal level, the nerve root canal or the tunnel level, or the intervertebral foramen level. But there was a lot of discrepancies in what is called the nerve root or canal level. So this was modified again in 1987, where they divided it into several zones. So entrance zone stenosis, which we call it as a lateral recess, maybe due to facet arthropathy, a bulged annulus, or hypertrophied ligament, or short pedicles, and mid-zone stenosis, that is because of the pars. So what we see in lytic spondylolisthesis, which causes compression on the dorsal root ganglion, which has a separate set of symptoms, and then the exit zone stenosis. So this video will be just a short video on only the lateral recess stenosis part. So it's not something different, because when we start our endoscopy interlaminar disc work, one thing what we notice is very narrow foramen. So the disc may be small, but the interlaminar window is small. So what we need to do is, you need to enlarge the window. Sometimes the window may be moderate, but you have a very huge disc. Again, in that cases also, you need to enlarge the window. So the same process when you do it, when there is a lateral recess stenosis, that becomes a lateral stenosis decompression. So basically, many surgeons differ in where we put the incision, dock cover, retractor. So basically, it's a junction of the inferior margin of the lamina and the middle of the disc space. First thing is you need to expose all the bony landmarks. So the inferior facet, the junction of the inferior facet with the upper lamina, the superior facet junction with the lower lamina, and the interlaminar window. So these are the landmarks which we expose, and make sure that all the soft tissue is completely removed. And what do you cut? You cut the descending facet and the ascending facet. So just as Dr. Sukumar showed today, it would be flush with the pedicle. So this is the green shading is the descending facet with a part of the cranial lamina, and the blue one is the shaded one is the tip of the superior auricular facet with the part of the caudal lamina. And what are the endpoints of drilling? So once you drill the inferior facet, we should be able to reach the tip of the superior auricular facet. So this is the tip of the superior auricular facet here, seen here. So that is the end of the drilling of the descending facet. Now when should we stop drilling the superior auricular facet? That is when we reach the junction of the lower lamina with the descending facet, that is the mid pedicle. When you see in the laterally, in the mid pedicle range. These are the endpoints of drilling. So the right sided L4-5 level, this is the caudal, cranial, medial and lateral. So once you prepare, now this is the preparation, this is the caudal lamina, this is the superior auricular facet junction with the caudal lamina, this is the inferior auricular facet, and that continuing as the cranial lamina, and this is the interlaminar window or the ligamentum flavum there. Now you have to spend a lot of time in preparing the this thing. You need to remove all the soft tissues to expose the bony landmarks. You can use cutters, RF and all that. Then once you identify the tip of the inferior facet, this is the tip and the medial margin of the inferior facet. So you cut the medial margin of the inferior facet and the tip of the inferior facet so that you reach the tip of the ascending facet. So we can use the burrs, variety of burrs. You do the drilling. Till you reach the tip of the ascending facet. So here you can see the ascending facet is already seen here. Some amount of inferior facet bone is still there. You can, with the rongers, you can remove some of the inferior facet. And here, this is the tip of the ascending facet. Once the tip is identified, still some bone of the inferior facet was there that was been removed. So you can clearly see this is the tip of the superior facet. Now from the tip of the superior facet, you just drill the superior facet till it becomes thin. The cartilage is gone, the cortical bone goes, then the cancerous bone comes, and then again the cortical bone comes. And this drilling should continue till the junction of the superior facet with the lower lamina. And based upon the indication, you can enlarge the window, you can drill the lower lamina also. You make it eggshell-like thinning, and then you cut it with the ronger. They remove the ligamentum flavum. Sorry. Once the flavum is removed, depending upon the pathology, lateral recess stenosis, maybe a diffuse disc bulge is there or an osteophyte is there. So that you can do, here it was a diffuse firm bulge was there which was coagulated as the root was already free. So this procedure you need to do when there is a very narrow interlaminar window or very huge disc but the normal window, and the first step for any lateral recess stenosis. So most importantly, what we find is iatrogenic dural tear and root edge is the major cause or complication which we see. So common complication endoscopic spine, and usually because of the surgeon's learning curve. And basically you need to keep the endoscopic view very clear. The irrigation should be good. Maintain, whenever you use the punches or the drills, you make sure by tilting the endoscope, you see the tip of the working instruments. And you need to create a safe dissection plane by blunt probe, so that when you catch the ligamentum flavum, you make sure that you are away from the neural structures. And wherever the stenosis is less, for example, the upper ligamentum flavum, cranial end of the ligamentum flavum, if you remove the flap there is a more chance of saline going there, and it will create a space, wider space for you to work, so that you don't disturb the neural structures. So expanding the lateral recess is a very useful tool. So especially in narrow interlaminar window, huge disc in a normal window, and lateral recess stenosis, good anatomical orientation is imperative, lest you go lost in that. It has a steep learning curve, and complication avoidance by following a strict routine or workflow. Thank you.
Questions before we end?
Hello, excellent presentation, Ramesh. What difficulties during your learning curve, the most challenging part when you're doing interlaminar stenosis, what is that you faced?
The most important thing is, like, we really underestimate how much the cannula moves and how much the dural tear or the root injury occurs. So there is always a temptation that little more turn and then you can catch and get the disc out, but that will be a very this thing. Whenever you have a little doubt, better to do your recess work earlier. So whether if it's a very huge disc and even though the interlaminar window looks normal, there is always a chance that you can't negotiate your instruments because already the disc is occupying a lot of space. So you need to do your lateral recess work. And obviously interlaminar window, if it is narrow, you better always be on the safe side by increasing the space. And whenever there is stenosis, and first you look where the stenosis is less, and then remove the ligamentum flavum, so that it creates a space for the saline or the irrigation fluid to go. Because here you need to work you don't have a cavity to work. But once the more fluid and irrigation goes through all the ligamentum flavum, it will create its own space, so that you can have a good working area.
Okay. Anything else? I think there's one more talk, but I will wind it up because lack of time. So Naresh will.
We will have, Dr. K.T. Chians and Dr. Zakari's talk tomorrow in the first session, because we have to start the dinner program by, we thought 7, and seen like more than 100 people sitting in the hall, even at the 6:30. We didn't want it to stop at 5:30, but thank you very much, and just a little bit more stretch and relax and come back for more fun now. Surgery is over, so more fun now. Thank you, and we all will regroup by 7:30. Yeah, thank you. Here only, same hall, okay.
రాహుల్ రాహుల్ తీసేద్దాం మనమే తీసేద్దాం మళ్ళీ వాడు ఎవడో వస్తాడు
తీసేయచ్చు అది తీస్తారు శబ్దం ఉంది దీనికి బ్రో వెండర్ భయ్యా पोडियम क्या पोडियम निकालना ये भी निकालना ये पूरा
क्या पोडियम नहीं हाँ अवार्ड सेरेमनी ఉంది కదా ప్రస్తుతానికి కొంచెం హలో అది